The first speaker for the session is Dr. Kailash Sharma. We would like to invite our first speaker. He's the Dean of the Academics Professor. He's the Dean of the Academics Project Professor, Department of Anesthesiology, Critical Care and Pain, Tata Memorial Center, Mumbai, India. He'll be discussing on the topic Tata Memorial Center and Merck Foundation Africa Oncology Program and its impact in changing the landscape of oncology care in underserving countries. Over to you, sir.
Good morning to you all. On behalf of Tata Memorial Center, very warm welcome to Mumbai, India. And morning when I was coming here, I was very lucky to meet my old friends from Uganda, from Liberia, and from Ghana. And then, okay, now once I start, I will ask them only who are here and who were here right from 2017, 18, 19. And then during the COVID period, it was unfortunate for the entire world due to the pandemic that nobody could travel and they were there in their own home states. They were managing the cancer care. So with my lecture, when we started Merck Africa Foundation, the fellowship, training, short-term, long-term, in Tata Memorial Hospital for doctors, nurses, and technologists. Initially, it was thought that we will do the training initially for doctors, and we got good doctors who were having attitude and aptitude towards the medical oncology and towards pediatric oncology. The lecture revolves around what is the impact of this fellowship or this training organized by Merck Africa Foundation for the sub-Saharan region, African region, and their cancer hospitals, their general hospitals, district hospitals, or maybe their medical institutions. So how it revolved and what we could achieve. It is very difficult to say what was the correct impact there and what was our goal set for to see that those who were trained here for 6 months to 1 year and they went back to their own home states, their hometown, district, to their hospitals, how they were able to impart the same knowledge and training which they got here into their home states, to their patients, and how they became a good caregivers after getting this training from Tata Memorial Center. Next slide, please. Yeah, thank you. So this photo gives me a nostalgia when the Merck Africa Foundation fellowship agreement was being signed at Tata Memorial Hospital. You can see Dr. Badwe, Dr. De Cruz, and Chairman Rasha College. Okay. So thereafter, when we started, this is just some photographs. So where I remember very vividly Nihat Safelu from Accra, Ghana. And I'm in touch with her for last more than 5 years. She is practicing in one center. She has developed one pediatric oncology unit, and Dr. Banavali was very gracious enough, and the entire unit of pediatric oncology, Tata Memorial Hospital, to give her good training. She was very sincere, very studious, and she used to ask so many questions. She was involved like a senior resident of Tata Memorial Hospital for more than 1 year. And I am in touch with her on WhatsApp, and she's very well managing, and she gets pediatric oncology patients from all over the Africa, and she manages very well. So that is the best impact which I have seen in the pediatric oncology group and hematolymphoid group when they were trained here and now they are practicing. And I think I don't have any statistics that how many patients she has seen, how many they are treated, what are the guidelines, but yes, she is in touch with me, and she always mails also that yes, whatever she got trained here, and she saw the mix of the patients, variety of patients here, and she could give the same kind of care to them. So this, if we see, these are all the states from say Africa, and we had two types of training here. I have to mention the Indo-Africa Summit, our very prestigious program of External Affairs Department, Government of India, which also started, and they also had the same kind of training here. So Merck Africa was the first to start, and then the this thing came, Indo-Africa Summit Forum also. So these are the countries, their name and the number of doctors who were trained. So I think around 96 were there on the TMC Merck, and then from Indo-Africa Summit there were around 35. So this shows the mere statistics, and then there was a gap. But now I heard that for last, I think 2 years, there's Merck Africa is still continuing here, and they are here for the training from Accra, Ghana, Liberia, the other small parts of the African countries also. Now you can see the high income group versus low and middle income group countries. The statistic shows when it was taken by the Concord study that 5-year survival for breast cancer is better, say 90% in Australia, 92 USA, 66 India, and then comes down to Uganda and Algeria, and less than 20% in Gambia. So this shows, and this is 5-year-old statistics, it must have shown some improvement by now. So it shows that the breast cancer is most common across the world and here also, and in the LMIC, but their 5-year survival is up not more than 40 or not more than 35%. And pediatric cancer, acute lymphoblastic leukemia, 5-year survival, high income group countries like St. Jude and all, it is more than 95%. In India, it is around 85% now, with the intense treatment and good follow-up. Not only the treatment, which is important for initial induction and consolidation phase, but it is important for the 1-year follow-up continuously without any break and without any getting any infection from the periphery. That gives a very bad result. So good news from Concord 3 that overall trend in cancer survival were on the upward trajectory because of the good training, good availability of equipment, good availability of the drugs, and well-trained doctors. So bad news is that high-income countries are enjoying the bulk of this benefit because of they have got the revenue, they have got doctors, they have got training, they have got big hospitals and big medical colleges, and USA, UK, Australia, as compared to low and middle income countries. So we have to really concentrate towards LMIC and Africa and sub-Saharan region where these cancers are increasing, like breast, cervical, then Kaposi sarcoma, the bone and soft tissue tumor, and other GI oncology patients also. So currently, say why it is more common now, because aging population and then commercial interest, unhealthy lifestyle. Currently 1 in 5 men and 1 in 6 women will have, say, cancer. Suggests that by 2030, 30 million more than will die from cancer each year. And a heartbreaking truth is that many cancers could be prevented by stronger public health action, tobacco control, alcohol control, then other pollution, hepatitis B, weight control, and lifestyle control. It is very well proven that obesity leads to breast cancer. Infertility leads to breast cancer, cervical cancer. Bad hygiene of the private parts also leads to cervical cancer. It is very well proven by, say, HPV vaccine, HPV infection. These are again the same statistic which shows the age adjusted data of say lung, colorectal, stomach, then again again the incidence and the mortality, which is being very well depicted here, which shows the occurrence of the cancer of the common organs across the LMICs. So cancer is emerging as a major public health problem in sub-Saharan Africa because of the population aging and growth, as well as increased prevalence of key risk factors, including those associated with social and economic transitions. This slide shows the common cancers, their occurrence, preponderance versus their severity or mortality. So these are the 3 or 4 main cancers which are really affecting the LMIC these countries, and the scenario is very much bad. So after the training, after the availability of good drugs, after the practicing of evidence-based management of cancer across the country, or whatever you give NCCN guidelines, then only with the equipment, manpower, and availability of drugs, all three combinations when you have, then only you can achieve good results, and that too, it must be affording. So accessibility and affordability, these are the two main things for any country like India also, to have these two things, when and the availability at the center with the trained and qualified manpower and dedication, then only it can be very well controlled. So these are the three main core subjects: surgical oncology, radiation oncology, and medical oncology. So a comprehensive review of literature originating sub-Saharan Africa, including South Africa, on the state of surgery in the region revealed that the number of surgeons was approximately less than 2 surgeons per 1 lakh inhabitants, which is very, very low. In India also, we face a crunch. But now, over the last 10 years period, we are having very good trained and qualified human resource available in the country to treat the cancer across the country in their respective home states. Now, radiation, very important. Directory of Radiotherapy Centers maintained by International Atomic Energy Regulatory Body had given that how many radiotherapy machines are there across the African or the LMIC countries. They were old Theratron cobalt machines. Now they must be having good linear accelerators being installed. So if I ask my old friends from, say, Ghana, then Uganda, and other neighboring countries from where they have come, how many LINAC accelerators have been installed in their respective countries? You can raise your hand and tell me how many LINAC accelerators are there in your home state, at your center where you are working. What about Accra, Ghana, Liberia, Guinea? So you are still managing with old Theratron cobalt machine? Not having cobalt also. So for radiation, you have to refer the patient or shift the patient. How many to only Ghana? So Accra, where Nihat Safel is practicing, she has WhatsApped me and she is in continuous touch with us that she is managing pediatric cancers there very successfully because she was here for more than 18 months. So that is the real impact which we have shown. But to have trained and qualified human resource available in your country and to see the impact, the availability of infrastructure, then equipments, manpower, and the drugs, when these are available in your country and your neighboring part of your small states and the small district places, then only the real impact can be studied. So we are very happy that we have imparted training for over a period of, say, last 6 or 7 years, minus the pandemic of COVID. And you have gone back to your home states, your home districts, and you are practicing whatever you have been imparted here, the same kind of training, but it all subjects to the availability. If you can't do that much severity of, say, surgery, if you can't have drugs, and if you can't have a machine, so like a LINAC accelerator, then I think it becomes very difficult on your part to have the evidence-based protocol. Otherwise, you will have to cut the corners and you have to manage with whatever is available. But still, if you are managing with whatever is available, I think it is great on your part. But it becomes very difficult to measure the impact after having training here and gone back to your country, and what type of cancers you are managing. What I have listed, the common cancers like, say, lung, colorectal, breast, CS cervix, and other things. What we have shown, because of the aging population, because of your lifestyle habits, because of tobacco, smokeless or with smoke, and the bad hygiene of, say, private parts, all these things which contributes to the most common cancers across the world also, and in the low and middle income countries, which you belong to part of that world, Africa and sub-Saharan region. Then third becomes medical oncology. So medical oncology, yes, we have trained many medicine people, physicians from Africa and LMIC in pediatric oncology and in medical oncology, adult hematolymphoid versus solid tumor also. But when they go back, the availability of drugs, the availability of monitors, availability of the laboratory is very important, because you have to have the basic pathology report, then few markers like ISC or molecular sequencing. Then only you can have the targeted therapy. But leave apart targeted, if you have basic drugs and basic protocol for say cancer cervix, cancer lung, and cancer breast and colorectal, say after surgery, or you are having a concurrent RT-CT program and the protocol, then the availability of these very common and very old drugs is also very important. I'm not talking about the targeted therapy or immunotherapy, which is not part of this say lecture also, and we are not expecting that will be right now there. It is beyond our reach to have there in India also. So considering LMIC, it is the ultimate financial status and the economic growth of your country to provide all such things, and that should not cost a single pie to the patient. Then only it is very useful. Then very important is pathology. People think pathology is a laboratory where you have biochemistry machine, hematology machine, and say microbiology machine. No, histopathology is very important. And to do histopathology, the basic technology of preparing a good slide, that is number one, then reading on the slide and giving the correct diagnosis and giving the prognostic indicators also is very important. So oncopathology training is also very important. And I think I remember during that last 5-6 years of period when I was here, that time 5 or 6 pathologists were trained, and few Merck Africa fellows were into research pathology laboratory for 3 months, but they were students, they were pursuing their PhD in their own country. So they came here just to have a look around the laboratory and the what type of equipments available. So this was the thing. So these are the main thing. And after that, very important is the palliative care, and not at the end of life care, but the continuity of care right from the OPD, right from surgery, during medical oncology, during radiation oncology. If there is a continuous support to the patient with supportive guidelines for their physical well-being, their economic well-being, their spiritual and their psychosocial. If it is there, then I think you can treat patient, you can boost their moral and their support from the family. And then I think their last few days or last few months or years will be very comfortable. If you have got to have the palliative care department and to have the pain relief department, the supply of narcotics is also very, very important. And that's a real debatable question, how far it is available, how much it is available, and what form it is available. And the social stigma towards use of the narcotics again goes that it is a drug abuse. So if it is not being part of drug abuse and it is available only to the patient for the proper dose and proper format of the drug available, whether it is instant release or sustained release tablets or patches, which are all available across the globe. But what is their availability? I'm going to ask you once I finish my lecture. So what comprises the survival gap? The lack of access to diagnosis, lack of access to treatment, cost and healthcare resources, and then ultimately it is a toxic death or a toxic phenomena, or maybe the symptoms or the complications which arises out of the treatment. You must have technical knowledge, you must have social background to treat with the supportive element to avoid these things and to give a continuity of care. Then patients, because of the accessibility or affordability, they may abandon the treatment. So you have treated them halfway, they have left halfway, abandoned, and there is no treatment left for them because they can't afford or they don't have accessibility because center is far away and they are in one small village or some small town or district place. Then the relapses of the well-treated patient also, and relapses of untreated or half-treated patient also. So these are all the things which ultimately culminate into halfway treated and mortality which is being shown. The mortality which was shown here, which was only a statistics of Globocan or Concord studies, but far more in reality, what we find because of these factors, I think this is much more. And cancer not seen as a priority. So across the world now, cancer is seen as a priority and it is the second most leading cause of death after the cardiovascular events. So these are all the strategies which I have highlighted. These are all from any good journal or any good textbook. This is nothing to see. These are all very ideal things to practice or to maintain when you are practicing. But when it becomes a difficult accessibility and affordability, it becomes a part of only the academic part of the study or academic part of the knowledge. Now, very important, is lack of human resource. So it is the basic lack of the prevalence of, say, well-trained doctors. So like in India, we have MBBS, then we have post-graduation, MD and MS, and then we have super specialty, which is 3-year course in oncology like MCH and DM, and in radiation oncology, MD, and very important, oncopathology. And the other parts of the, like oncoimaging also, PET-CT imaging also, nuclear medicine also. So all these departments, when they are there, then only the comprehensive cancer hospital functions. So the basic lack of number of doctors and doctors available in the community. And if they have so many things to practice and then don't have any knowledge or training to treat cancer and to diagnose the cancer, then the major part of the human resource across the globe, which is pointed out here in the sub-Saharan and African countries. So 3 factors: human resource, well-trained, well-qualified. Not qualified will do, but it has to be a well-trained. And this was the main aspect of this training program of Merck Africa Fellowship, or say Indo-African Summit Fellowship program, which Tata Hospital was running for last so many years. And we have to really see how it has been effective when you see the impact of this fellowship program when you go back and you study. So I'm asking my old friend from Tanzania and from Liberia, when they were here for a year or 6 months, what was their experience after going there? So my good friend from Uganda, from Accra, and in Liberia, Tanzania, where are they? I met them early morning. So how are you practicing? Where? Niger. Okay. And who is from Ghana? From Uganda, then Liberia. Okay, so after your training, how do you find yourself when you see the cases, diagnose, treat, and follow up? How do you find? Okay. Acha, advanced oncopathology. Okay.
Prior to coming here, I had just done the basic pathology in Ghana, and we didn't have that diversity. For example, immunohistochemistry was not part of the training at all. So molecular, is still like...
It's still, yeah, I mentioned that,
way
yes.
out of reach. Yeah, so because of the diversity here, because in Ghana, where I train, we see like 1,000 cases a
But
year.
you have basic histopathology available?
We have basic histopathology. Immunos, no. But the training here sharpened my ability to actually diagnose histopathology, basic histopathology.
Okay.
Basically, that has really improved.
Improved.
Improved care in Liberia.
So
Yeah.
that I'm very happy that you had some kind of a training here, and whatever available resources at your level, you are, I think, basic into the practicing of good, at least diagnosis with basic histopathology concerns.
Yes, definitely.
Very happy.
Definitely.
Very happy to note.
Yeah,
and
definitely.
this was the real impact, which was part of my lecture, that after training, we can't really follow up, but you had practical issues there, which you can solve and you can give back to your own home state or country. I think I will feel great that, yes, whatever training was imparted by Merck Africa Fellowship Program was fruitful when you went back.
Yes, and I'm in touch with the departments.
So,
like Prof. Sumit, he still provides guidance for us. The PG lectures that goes on within, and Anita Ma'am, with Songa Lot, and
yes.
So it's actually still ongoing, and we are very grateful for that
work. As we see, these are all advocacy areas of African Cancer Advocate Consortium, where important is political will, good bureaucratic support, which is also important in India also. We see the political will and bureaucratic support. If it is well coordinated, then successful program implementation happens, successful opening of hospitals happens, training program happens, and accessibility and affordability to cancer happens. As I have not shown you that after, say, for last 6-7 years, Tata Memorial Hospital has expanded across the country like a decentralized program in the northern part of the country, then Punjab, then northeast in Guwahati, south in Visakhapatnam, and now we will be going to Orissa and Bihar also. So this is the real strategy and real fruit, what we want to see now with a good political will and good bureaucratic support. And the main important is funding, which is mentioned here. Nothing to, this is just for reading. If you can practice, if and can government practice this, then I think the accessibility and affordability will not be there, and you will be able to successfully implement the basic diagnostic, therapeutic, and follow program for the cancer. And if you have got funds available, patient can go abroad, means he can go out of African countries and get the other type of treatments. So India's apex tertiary care referral center for cancer treatment, education and research, and a leader in Asia since 1941. This is Tata Hospital. And now I have just referred that it has expanded into, say, now around 10 centers. And because of this, we can see now the accessibility and affordability of these patients in their own areas, near to their hometowns, with the same line of treatment and same kind of cost involved by trained and qualified people from Tata. They are giving the same kind of treatment there. So that is the real fruit which are now being seen by Tata Hospital across the country. And same thing should happen in Africa, so that this program should become stronger and stronger in imparting such kind of training to African and low and middle income countries, doctors, nurses, and technologists. Nurses are very important. Technologists are also very important. Whatever amount of, whatever grade of machine is available, if the man behind the machine is not available, then I think nobody will able to run the machine, however sophisticated it is, like the physicists, the radiation safety officers, and the technologists. So many technologists and physicists were also trained across from the LMIC, and they went back, and I think they are practicing, but subject to availability of the good LINAC accelerators available, if your country permits on the financial and the economical reforms. So these are all things which be shown as per the Tata Memorial Hospital, how much we do, how much we practice, that you have practically seen. And I have already mentioned, with our other centers coming up, the number goes up. The number of cancer is increasing, not particularly because of the rate of the cancer, but because it is the aging population, and the number of cancer cases per million, when you calculate, it goes up and up. And the hospital has got collaborations with many good organizations across the globe, so that we can have exchange of knowledge, we can have training. Still, our doctors are going abroad for some kind of training and revision, and they attend conferences, they have their research papers. And very happy to say that in lymphoma and leukemia, we have achieved a great novel path of treatment, CAR T cell therapy, with the collaboration of Indian Institute of Technology, Mumbai, and it has been given, I think, go ahead and patent also. ICMR has also agreed, and it has become very cheap as compared to what is available in USA. So these were the international African fellows we attended for 4 or 5 years, and during the pandemic there was a gap. So now, for last 5 months, with the initiation of Dr. Badwe, and he has told me that how many we have trained from different countries under different fellowship programs. So we gone back to the list, their mail IDs, and we have mailed them. And I think I got around 7 or 8 replies back from their own countries, that what they learned here, when they were here, and where are they now, where they are attached, how big is the hospital, and what kind of treatment they are imparting in their own home district or their hometown. So I think whenever the next Luminary happen, I will be in a position to at least say that I have got 100 replies, and I will consolidate all the replies, and we will be able to show the real impact. So the title of this study, my lecture was Impact, but it was, I have not yet studied. It is just started. But what I could see and I could hear from you when you went back to your country, I think that's a great heartening thing. And if it continues, and if your government political will and bureaucratic support is there, then I think you will be able to achieve the target. What we see here for last so many years, we could do that. I think next 5 years, we will be also able to do that. So thank you very much. Thanks, Merck Africa Fellowship Program. And thanks to Tata Hospital for arranging this thing. And as a say host to have this program, because it was always in African countries or out of India. So now it is a great host on the part of Dr. Banawali, Dr. Badwe, and all the directors and the management of Tata Hospital, which they have given a helping hand and they could successfully organize this conference. Thank you very much.
Thank you very much, sir, for your wonderful presentation on the impacts in oncology care for Africa and Asia.
Good morning and welcome to Tata Hospital. Good to see people who have been here earlier and have been trained here coming back for interactions. This is a non-evidence-based talk. A talk for which there isn't much of evidence as to what can we do. But we will borrow from some general principles that we follow in management of cancer. And I was given this title that it is chemo-resistant disease or lots of residual disease after chemotherapy too, and no availability of radiotherapy. Let me start off with saying that there are very few solid tumors where you can cure without surgery. There are very, very few solid tumors like that. The areas where radicality is not easily possible, like cervix or areas like prostate, where radicality may not be as easy because of access or the proximity of vital structures, maybe esophagus. There, you might find results that are equivalent, whether you do surgery or you don't do surgery, and you will still have good amount of cures with, but some which are, I know that. So irrespective of whatever we do, in absence of loco-regional treatment, whether it is surgery or radiotherapy, it is unlikely that we'll be able to have cures in any solid tumor for that matter. Chemotherapy might add something to a wall that has been created up to say 5 feet or so. 1 or 2 bricks might be added to it. Immunotherapy might add some more bricks. But having only that in absence of loco-regional treatment does not work. You will, since I'm going to talk about breast cancer, there is a very good Cochrane review of neoadjuvant chemotherapy in breast cancer versus the post-operative adjuvant chemotherapy. Large amount of randomized data, no difference. But when you do a subset analysis, and the subset analysis is in individuals who have had complete response. Now, these are high kind of cure rate individuals, not because of chemotherapy, but selected out that there are individuals who have had complete response. They are obviously going to perform well. Now, such individuals, when they don't have radiotherapy at all, or they don't have surgery at all, what's the recurrence rate? And the recurrence rate in that meta-analysis is more than 50%. Imagine early breast cancer or slightly larger tumor up to 4 centimeters having given chemotherapy and no surgery done, have 50% local recurrence. What's the otherwise conventional local recurrence? It's under 10%. So not having loco-regional treatment is not appropriate. So let me make that very, very clear. The second important thing is that as a routine, we give something like, say, hormone therapy or whatever chemotherapy we give more so hormone therapy. When we give it, large amount of our data is essentially based on adjuvant setting in early breast cancer. And some of the early breast cancer tumors at worst would be about 4 centimeters or so without any neoadjuvant treatment. We give post-operative hormone therapy, but we also give post-operative hormone therapy for individuals, women who are locally advanced, who have given neoadjuvant chemotherapy, disease shrunk, the original tumor was 5 centimeters, 7 centimeters. Where is the evidence for that? There is no evidence for it, but we know that extrapolating from one to the other will be helpful, and it has been helpful. So using these two principles, I'm going to look at this. And the third, if there are any regulators here, then please try and get some radiotherapy equipment in at least one in each African country. Vitally important. And do not press for a linear accelerator, because in want of something which is the best, you can't be denying what is routine. That if there is no cake, I will not even give bread. That's not appropriate. We need to have our tummy full. We need to eat something. So Cobalt is not a bad equipment. It's in fact an excellent equipment, an equipment which is a workhorse. We, having had 14 linear accelerators in this hospital, we have 2 Cobalt units. And why do we have them? Because there is a time when palliative treatment, whichever we give, whether it is on Cobalt or linear accelerator, makes no difference, no outcome difference at all. And the second important thing, there are studies on radiotherapy that have compared 5 days a week versus 6 days a week treatment. So 1 day added per week, and there is a 10% improvement. The trial is called Dahanka trial, which happened in Europe. I think it's a Danish trial, and it was studied. The study was done in head and neck cancers. 10% improvement by adding 1 day. I want you to know that if you have a single linear accelerator machine in a place where there is sale services, after sale services are not appropriate, the downtime of linear accelerator can be up to about 25%. That means 1 in 4 days the machine does not work. What's the point? If your 5 days therapy is reduced to 4 days or sometimes to 3 days a week, you're not going to have the same cures. Whereas the downtime for the Cobalt machines that we have is never more than 2 days in an year. All days used. So it's a workhorse. Gives radiotherapy. There may not be precision, but for want of precision with a single machine and dropouts, what's the point in having it? So I would suggest that have LINAC. I'm not saying don't have LINAC, but with that, let's have Cobalt as a backup machine, which always is ready to deliver the therapy, even if there is no electricity. In absence of electricity, Cobalt machine works. Cobalt machine can work on a generator. It can work on an inverter. It can even work on inverter. It doesn't need great amount of electricity. Whereas LINAC needs fairly large amount of electricity. In absence of electricity, it will not work. Suffice to say that we need to have all machines, but we cannot just dispose of machines which are excellently functioning because they don't have some bit of precision that I don't want this machine at all. It is a workhorse, works well. Let me get on with my presentation. Chemo-resistant, locally advanced breast cancer. I'm going to get into the nitty-gritty of how do we manage and how do we take this forward, utilizing what we know at the moment. So get the machine is the first advice. If you don't have, let's look at this. So to your left is the typical locally advanced breast cancer because of the primary tumor. If there are matted nodes as you go to the right, or if there are internal mammary nodes, you will have, again, that being classified as locally advanced disease. On similar lines, when it is inoperable, it is actually infiltrating into the underlying muscle or maybe chest wall, or infiltrating the skin with satellite nodules. That also forms the area of locally advanced breast cancer. Similarly, the high-end supraclavicular nodes, these are also part of our N3 matted nodes, multiple nodes which are large enough. All of it constitutes locally advanced breast cancer. How do we deal with this? So we need to confirm the possibility of R0 resection. How do we do that? Is there any possibility of knowing whether this patient is M0 or not? What investigative modalities are available locally with you? If you don't have a CT scan, if you don't have a PET scan, do a chest X-ray. That's also fine. It may have slightly lesser sensitivity, but it will definitely not miss out on gross disease or gross M1. Similarly, when I was a resident, we were fortunate that we had radioisotope for bone scan, and bone scan was possible. But if it is not possible, in individuals wherein some days radioisotope was not there, we would do a X-ray bone survey, a radiological bone survey, so that axial skeleton, pelvis, and shoulders, the humerus, all these were evaluated by a plain X-ray. I understand it is not the best way of doing it, but the difference would be that you might add another about 5% or so of smaller amount of M1 disease, which you may miss. But it is better than nothing, far better than nothing. So some way of putting up or confirming either a skeletal survey or a bone scan or a CT scan, or if available a PET scan, any of these increasing sensitivity modalities to prove that it is M0. If it is M0, then two kinds of evaluations are required. Locally, if I were to perform surgery, can I get an R0? Am I away from primary tumor while I perform my surgeries? For primary tumor, it is usually possible. The skin might be much bigger, and I'll tell you what needs to be done for that. But what is difficult is in the armpit. Will you be able to get an R0 there? So it is best to have an ultrasonography. It's available, and a Doppler will give you exactly what's the proximity of lymph nodes to either axillary vein, or if it is supraaxillary vein, how close it is to the axillary artery. So either of these can give, even today, when I'm planning a surgery for a locally advanced disease which has not responded to chemotherapy here, I ask for an axillary ultrasound to understand, should I be braced or pre-warned that I might need a vascular surgeon. I might need availability of a Gore-Tex graft or a saphenous vein being prepared, harvested beforehand, assuming that I'm going to excise the vein too. But the goal is to do an R0 resection, get rid of all the gross disease. If that is not possible, because the artery being involved or the brachial plexus being involved, there cannot be any replacement for brachial plexus, and you can't excise it. So if that is the case in a symptomatic individual with arm going flail or neuropathy, neuralgic pain in the arms, that is something which is a complete contraindication for going down and doing surgery. Resectable areas go all the way to see that you are wide on the skin away from the primary tumor. You are clear of the tumor as far as the blood vessels are concerned. If not, they are also dispensable. You can have, so this is where the training comes in. An individual who is trained in vascular surgery can easily do this, and he can do it for life. Your radiotherapy machine may have 10 years of life, but the individual who has learned this will be able to deliver it for 20, 30, 40 years. So that's the kind of training that I'm looking at. So plan a good cover. That means how much is the excision of the skin? Can I get all that covered? Covered fully, not with a graft, not with a split thickness graft. It's a vascularized cover that I need so that the patient may not have the mound that is expected compared to the other side, but at least has a cover which is like a normal skin. That's vitally important. You can have additional things done, but at least have this thing done basically, and I'll show you some examples of what all things we use for vascularized cover. I'm sure these are the kinds of tumors that you also see in your practice, especially the extreme right-sided lesion. If this is not going to respond to chemotherapy, this will need a wider excision, and that needs some form of cover. And this, the one to the extreme right, is not the kind of cover that I'm looking for. That's a completely wrong way of doing it. Even if you were to send this patient somewhere else for radiotherapy to Ghana or some other neighboring country, she will not be able to receive that radiotherapy with a split thickness graft on top. You need a vascularized breast tissue, and that needs to be planned. It could be a latissimus dorsi myocutaneous flap, which is a simple flap, can be done by any good surgeon, any surgeon who has seen. And if somebody comes to train here, in 3 months' time, he will see at least about 25 to 30 latissimus dorsi flaps being done here. It is easily possible to make use of it. If it is bigger than that, then one can use the abdominal VRAM flap. We're not looking at any microvascular thing. Mobilizing tissue and taking it up and closing, everything being closed primarily. The grafts might appear, the area might appear, the scars might appear bigger, but they are fully vascularized area being transported from one place to the other without any problems as far as the local condition is concerned, the donor site as well as the host site. So there are various areas from where we can do. It can also be a microvascular kind of flap. You can have, as you go further, you may have somebody who is trained in microvascular using loops and the area. So when I talk to some of the ladies and suggest this kind of flap, one of the lady promptly said, "That's nice. I will have a tummy tuck as well as a breast being created." So what I mean is that look at the positivity of the lady. It's quite comparable to, I give another example of how positivity works in women and the kind of coping skills. I am amazed by the kind of coping skills. A lady whom I gave the diagnosis, and she just kind of crashed. She just collapsed. She just couldn't take it that she was having breast cancer. Started crying, and I knew that whatever I said after that cannot be taken in. So I told her, I took her outside the consulting room. I said, "You please sit here with her husband, that once you are feeling better, please come in. Then we'll discuss. This is not incurable. This is curable, but you should understand the kind of treatment planning that I'm doing." After about next 2 consultations, the lady walked in again and she was beaming. She had all smiles, and I was wondering what changed. And I asked her as to what happened. You were very different when you left this room, and you are now completely different, 180 degrees different than what you were some time ago. And you know the answer? I was so very surprised by that answer. She said, "Doc, outside your consulting room, it's written that 1 out of 23 women get breast cancer in their lifetime. And if I have got it, 22 others are not going to get it." What had changed for that lady? Nothing had changed for that lady. But she was looking for positivity in gross negativity in front of her. That's where coping skills come in. And so suffice to say that there are things that can be looked upon as, what's the best thing that I'm getting here, and will that improve my quality of life? There are other areas. This is a ALT flap, but this is a free flap. Somebody, you need a plastic surgeon who will do microvascular surgery, may not need a microscope. There are individuals who put on their loops and do microvascular surgery. You will be surprised. what techniques can be used and how techniques can be mastered. I was visiting this microvascular center in Korea, and some 15 theaters, all of 15 doing microvascular surgery. And while I was leaving, there was a room wherein we had to kind of, the door was open and there were about 7 or 8 girls there. They were in scrubs, but they were girls. They were, I mean, my assessment of their age was about 12, 14, 15, that age. And I asked the gentleman as to what are these girls doing here? So he said, the most steady hand is between age 12 and 18. So we train these girls to only suture under the microscope. They have the most steady hand, and an adult trained plastic surgeon, if he takes about 45 minutes to suture a vein and another 30 minutes to suture the artery, the girls do it in 6 minutes. It's only because the hand is extremely steady, they are trained to look under the microscope. The harvesting, getting all the vessels close to each other is done by the plastic surgeon. So he does his job, but look at the expertise. What can we train and how best? And their patency rates were better than an individual who was doing it at 40, at 45, at 50. But they didn't know what to put together. So all that was done by the plastic surgeon, and the girl would come and they would work for 5 years. Between 12 and 17, they would retire on 17. So a continuous changeover training. What I wanted to let you know that you may not do this, but find what works well in your own environment, and there are solutions in front of us. Solutions which are superior to what the world does. And you need to have then the regulatory approvals for this. Show them the data to say that this is superior. What are we working here for? We are working here for our patients. If patients will do well, why not? I'll take you from here into areas where we have found some simple solutions in large operable and early breast cancers, and can they be used in the indication that we are looking for. So that's the kind of thing that happens after the anterolateral thigh flap, which is at the donor site. Now, if by any chance, when you do the investigations, you find that patient has M1 disease, what do you do with the M1? You will still do surgery if there is ulceration, bleeding, and pain. But surgery in M1 disease does not affect overall survival. It's only for palliation. In fact, it does shorten the distant disease-free survival. Those who are M1 patients, I'll show you some data. This is a trial that we did between 2008 and 2007 and 2012. 350 patients who had M1 disease where all received chemotherapy, some responded, some not responded. They were randomly allocated to have surgery versus not. No surgery done. And that's the graph of overall survival. Surgery done versus not. No difference. When we look at the local control was 80% difference. Those who obviously had disease left behind, it was progressing. Whereas those who had mastectomy, only 20% had recurrences. So local control was excellent. In spite of 80% difference in control of local, why were they not living? Obviously, there was a problem. When we looked at the distant disease-free survival, the graph was reversed. Those who had surgery had a lot more distant recurrences or progressions compared to those who did not have surgery. So suffice to say that this was the first proof in humans that something happened at the time of surgery for distant metastases. It got published in Lancet Oncology, and From there on, and even prior to that, we have been working only on what treatment to give around surgery. So if you're performing surgery in large tumors, wherein there is no distant metastases, what will you do to prevent surgery producing those problems? Here is a study that we did much earlier of giving a single injection of hydroxyprogesterone. Hydroxyprogesterone given in an average tumor size of 3.5 centimeter. The largest tumor in this trial was about 6 centimeter. Hydroxyprogesterone 500 milligram. This injection is available as a depot preparation, and the indication for this injection is threatened abortions. This is the standard indication. So if it is safe to be given to a pregnant woman holding a fetus whose life is threatened, then there can't be anything safer than that. So that's the indication of this injection. If given 2 days prior to surgery, you're doing surgery today, 2 days prior, give this single injection, and that's the difference. 10% difference in disease-free survival, 10% difference in overall survival. The cost of this injection in Mumbai is 60 rupees. That is short of $1. 10% difference in the overall, this is in node positive, slightly advanced disease, that you have a 10% difference in outcome. If it is there in early breast cancer, why can't you use it prior to surgery? Do it for all patients who are undergoing breast cancer surgery, and you will have some differences. Extending the same, so this was published in JCO, and there was an editorial that so much for so little, you can get returns. The second perioperative study that we did was giving local anesthetic. Under general anesthesia, patient under general anesthesia, we gave local anesthetic around the tumor on all surfaces. Now that may be slightly difficult in a very large tumor, but periphery can be done, and under surface, wherever you can go. While you start surgery, you can still inject as you go ahead in an area closer to the periphery of whatever you have injected. Inject and then excise the tumor. So 1,600 patients, 800 had local anesthetic injected after general anesthesia being given, and another 800 did not. That's the difference in overall survival as well as disease-free survival. So preventing something. What is the cost of local anesthetic? All of them, I'm sure, local anesthetic is available everywhere, in all parts of the world. This was presented in ESMO 2 years ago. This is now published in JCO. Have a look at it. But what I'm trying to tell you is that if this is effective in a 4 centimeter tumor, a 5 centimeter tumor, why can't it be effective in a 10 centimeter tumor? The same analogy that I spoke right at the beginning, that postoperative adjuvant hormone therapy is proven within trials for early breast cancer, but we use it for locally advanced breast cancers also. Where is the evidence for that? But if it is available there, and if it is effective there, why can't it be effective here? It is plain simple extrapolation. I don't need another trial for that. Give this some thought so that you are able to implement. Again, the cost of a single bottle of local anesthetic here in Mumbai is 100 rupees. That's just about $1. $1 worth, and that's the difference in reducing local recurrences as well as reducing deaths due to breast cancer in a study that had 1,600 women on trial, half of them receiving, half of them. So robust evidence, conclusively without ambiguity, a difference in outcome. What I wanted to tell you again, I will reiterate that it is best to have some form of radiotherapy being made available. Speak to your regulators. If there is help required, IAEA under the PACT program is giving these therapies, these machines. Again, as part of that machine, you may want a linear accelerator, but don't insist on a single linear accelerator. In India, where facilities are available in a remote place where electricity may not be there, I cannot use a LINAC. When I say electricity, persistent electricity continuously. If it's not available, there are load shedding in parts of the world. We don't have electricity sometimes for 6 hours, 8 hours. 1 day of radiation missed, efficacy reduced by 10%. Please understand this. And the second bit, even if you have a LINAC, it's good to have a cobalt machine. Workhorse, least downtime. So seek these machines. I'm sure government to government request for India also can offer that machine in addition to a LINAC coming from any other source. Having said that, quick training with loops for a regular surgeon to do microvascular surgery. If that happens, hundreds of patients can be treated over a period of 30, 40 years. There is no end of life for a man who does microvascular. If you are great, you can teach some of the girls from 12 to 18 to do those microvasculars, but somebody has to harvest the tissue, bring it together, and then somebody can do it. Simple things are easily possible. And the cheapest two interventions that I mentioned to you, giving progesterone prior to surgery and local anesthetic on table, give it, and I'm sure there will be some outcomes wherein there are a lot more patients treated with this kind of radical surgery are walking on the streets of Africa saying that we are cured of breast cancer. Thank you very much. If there are any questions, I'll be happy to answer. Yeah.
Yes. So, Prof, thank you for the presentation. I was just kind of breathing everything in as you were saying. Given the resource limitation of the countries we come from, this is really helpful. And the affordability component, which ties in with the earlier presentation, is also so good. With respect to the local anesthesia, I was wondering, is it the one with or without adrenaline?
Without adrenaline.
Without adrenaline. Because I know the adrenaline will cause vasoconstriction and stuff like that. All right.
So I'll give you the underlying mechanism that we were looking for. The underlying mechanism, while we did surgery, our understanding of the primary tumor is based on what presently? It is based on a core biopsy performed beforehand, or it is based on the whole tumor in hand going to the pathology. These are the only 2 points where we have studied the tumors. Correct me if I'm wrong. What we did is, the first situation is what? Tumor is completely vascularized. I do a core biopsy, tumor is in perfectly harmonious environment of the host. I do a core biopsy, right? So this tumor is normoxic, and it also has normal nutrition. The tumor that I excise in my hand, given to the pathologist, is completely anoxic, has no oxygen. It can't breathe, only blood brings oxygen for it. So, no oxygen, no nutrition, right? Between these 2 extremes, what we did was we did a middle biopsy. So, let me explain to you. I'm audible that way. If you were to imagine that that's the primary tumor, I start my surgery, 50% surface of the tumor denuded of its blood supply, right? I do a biopsy from the opposite side of the tumor. That's a 3 centimeter tumor. I've done 50% surface denuded. I do a core biopsy from the other side. So I have now 3 samples. The first sample before I start surgery. This is a completely normoxic, good nutrition condition for the tumor. First biopsy. Second biopsy, hypoxia. Little bit of hypoxia is there. I have denuded 50% of the surface of the tumor. And the last biopsy, anoxia. No oxygenation, right? If I were to be walking on streets of Mumbai, say right outside St. Regis or along the marine lines, there is no reason why my survival instinct should be up. Everything is hunky-dory. right? Suddenly I find that there are 4 individuals who confront me. What will be my reaction? My reaction will be fright. I'll be scared. I might want to fight, right? If it's a losing battle, I find that there are too many of them, I might want to run away, flight. Yeah. So fright, flight, fight. These are the normal survival responses to the tissue. God forbid nothing should happen, but if all these 5 people overpower me and hold me, I'll stop reacting. Can you see the simile between the 3 states of tumor biopsy that I mentioned? Yeah. So, having done those biopsies, we sent it to be evaluated on the next generation sequencing for expression profile. What mRNA was coming out of the tumors? The first and the last had some 60 different genes which were up and down, and majority were metabolism related genes. A little few hypoxia related genes. But the middle sample had 900 genes that had gone up and down. Can you imagine that I have done a biopsy beforehand and my next biopsy is in 10 minutes. Denuding 50% tumor in breast conservation doesn't take more than 10 minutes. Sometimes it takes 5 minutes. In 5 minutes, I have taken biopsy from the other side. 900 genes up and down. How does the cell from this end convey it to the other end? See, it has to be conveyed. If there is an attack from outside, the other end of the town or city doesn't know that there is something happening there. How do you send this message? Normally in body, this happens through hormones. Hormones secreted here, going to blood, going to heart, lung, coming back. Takes a lot of time. Not possible. Paracrine, it can diffuse, or something can diffuse through and through. But even that will take time, not 5 minutes. In 5 minutes, it can't cross all the barriers. So there has to be something which is faster than that. What goes faster? What goes faster is electrical current. And on the surface of the cell, there are gated receptors which allow sodium to come in. The moment sodium comes in, there is a depolarization of the surface of the cell. And that depolarization is carried like an electric current from one cell to the other within seconds. That there is something wrong here. Easy ready. And these genes that were up, 900 genes, were essentially proliferation, invasion. What is that? Fighting. They were also of motility, flight. I want to run away. The cell wants to run away from there. So all the responses that the host will have were also there in every cell. If it is happening so fast, what paralyzes these sodium channels? What paralyzes it is local anesthetic. And that's how local anesthetic was used. Okay? I'll give you another tip on that. There is a molecule better than local anesthetic. You know what that is? That completely suppresses the transport mechanism of ions. That's cannabis. Our next trial is on cannabis. Not for a long time. It's just before surgery. So cannabis given a day prior, morning, evening, on the day of surgery, and then surgery performed. Let's see. And let me tell you an antecedent. I'm a storyteller, please. So while I was doing my residency long time ago in Guy's Hospital, the norm there was women would come in the morning for admission for surgery during the day, and they would go home either late evening or next day morning. And when they came into the ward, the nurse there would ask, have they had their pap smear? If they've not had in the last year, that will be informed to the cytology department. Somebody from cytology would come and they would have a cervical cytology done. So that happened, that must have happened for 1 or 2 patients. And I get a call from cytology department that such and such a lady who has come in, my technician came and did the cytology, but there are no cells. in the cytology specimen. So the cytologist said, I will come personally and I'll take the sample. I said, please. So she came, everything was adjusted, the cervix was shown properly, and she took the cytology, she went down. And in 15 minutes, I get a call again. There are no cells. And the lady asked me a very pertinent question. Will you please check with this lady? Is she a cannabis addict? And I said, why do you say this? He said, those who are on cannabis have such tight cell-to-cell adhesions that the cell cannot move out. So the flight component of the cell response will not be there if the lady was. And I did check with the lady and she was a cannabis addict. So something out of what happens somewhere else can be borrowed in your day-to-day practice. We need to be observant. Look for something good. Why is it happening? Is it applicable somewhere else? And you will be a Nobel Prize winner.
Good morning. I would like to thank the organizers for the opportunity to interact with all of you today. Sorry, I think I'm more comfortable that way. Okay. So what I will do in the next 15 minutes is to give you a little bit about how we conduct research at Tata Memorial Center, some of the examples of the research studies that we have conducted, and what are the tools and mechanisms that we have created to enable clinical research. And some of the examples were given by Dr. Badwe just in the previous talk. So I'm sure somebody has already told you that Tata Memorial Center now exists at several locations across India, and they are mentioned here. These are all our hospitals of Tata Memorial Center in various states, and there are two of them in Mumbai. One is where we are sitting just now, Tata Memorial Hospital, and the other one is Actrec, about 40 kilometers from here, which started as a research center, continues to perform basic and translational research, but is now also a very large clinical center. So I don't know, but perhaps somebody has already also told you that between all our hospitals across India, we now register close to 130,000 new cancer cases every year. And the estimated number of new cases, cancer cases in India is about 1.4 million. So close to 10% of all cancer cases in India are registered in one of the hospitals of our institution at the current time. So what we have done in the past 20 years is to think about how we will make an impact on the care of patients, as well as the research, which is clinically relevant to our own and contextual to our own scenario. So it is important to imbibe the best practices and think about cutting edge research that is conducted all over the world, and to imbibe the best traditions from everywhere. But it is also very important to think about what is relevant to us. So we have conducted research in new treatment strategies, improved treatment delivery mechanisms, cost-effective treatment and technologies, population-based interventions, and translational research, but all of them in well-designed clinical trials. So this is the mechanism by which research is overseen and conducted at Tata Memorial Center. We have what is called the TMC Research Administration Council, which is the track that is right here. We have 3 hospital ethics committees in Mumbai, 2 in Tata Memorial Hospital, 1 in Actrec. And we also have a hospital ethics committee in each of our institutions that are outside of Mumbai. We have what is called a clinical research secretariat, the clinical trial center, and several data monitoring committees that ensure the quality of the research that we perform. So the TMC Research Administration Council is chaired by the director of Tata Memorial Center, and it includes various other stakeholders that are listed on this slide. And the remit of this council is to frame and implement policies that are related to research at our institution. The Clinical Research Secretariat is an extremely important mechanism. This was started in 1997 to facilitate clinical research within TMC. And a few years later, we created what is called the Department of Atomic Energy Clinical Trials Center in 2003. And what this did was to enable dedicated intramural funding for practice-changing and practice-defining trials from within the DAE mechanism, so that there is assured funding, not huge funding, but assured funding for a number of years to be able to conduct the kind of clinical research that we wish to conduct. So we have this whole mechanism of the Clinical Research Secretariat and the Clinical Trial Center. And the focus is on three main aspects of promoting clinical research, which is education and training, propagating the practice of evidence-based medicine, and also to provide the financial and logistic infrastructure for implementing important clinical trials. So you can see, I will not read out everything. We have a biostatistics department, we have the clinical coordinators hub, we have the monitoring room, we have the audio-visual consenting room. And some of these are shown in the pictures right there. We have a dedicated research pharmacy where medications that need to be temperature controlled and need to be kept under certain conditions are appropriately stored and dispensed. We also have created human resource, because after all, any infrastructure is not the building and the chair and the table and the cupboard. It is actually the human resource. So you can see that all of these individuals who are listed on this slide are extremely important to enable the smooth conduct of clinical trials. And when I talk to my colleagues who are in the private sector, the single most important reason that most of them are unable to conduct important clinical trials is because of the lack of infrastructure. It is not the lack of willingness. It is the lack of infrastructure support that prohibits individuals and groups from conducting the kind of research that they would like to do. Over the years, we have also created standard operating procedures. So you can see the most recent version was in 2021. So this is like a cookbook for all investigators in Tata Memorial Center. They can refer to all aspects of clinical research and see and look for themselves as to how clinical research should be conducted. And at each point, there is guidance for any investigator and trial coordinators. We also, of course, have national guidelines and national framework for research, which is created and updated periodically by the Indian Council of Medical Research. And we are guided in an overarching manner by the rules and regulations that are framed by ICMR under its policies, and also by the Central Drug Controller General of India. Very important aspect is to continue to train our faculty members as well as other staff to be able to conduct research in an appropriate manner. So we have several workshops and training courses in clinical research methodology. And you can see the number of participants by each year, how many individuals were trained. And this needs to be done on a continuing and periodic basis so that we continue to have a pool of individuals who are well trained in the nuances of and the procedures of clinical and other types of research. Very importantly, as I told you, we created what is called the Department of Atomic Energy Clinical Trials Center in 2003. And what that has done is to enable dedicated funding for many years. Now, I'm very fond of saying this when I get a chance to speak in various other forums, such as the Government of India agencies like the Department of Biotechnology and Science and Technology. So the typical funding cycle of most granting agencies is 3 years. Sometimes, occasionally, it is 5 years. But in a disease like cancer, if you are to conduct a clinical trial, the outcome will not be apparent in 3 years. The outcome with respect to survival and what is clinically meaningful will only be apparent after 7 years or 8 years, after full accrual, at least a few years of follow-up. Now, no funding agency is willing to give you a grant that will last for 7 years or for 10 years. But without that kind of a long gestation period, it is impossible to produce meaningful results in terms of clinical research. It is okay to have a 3-year funding cycle or a 5-year funding cycle for laboratory research. If I want to create an animal model of breast cancer, I should be able to do it in 3 years, but not a proper, well done, large randomized trial of the kind that Dr. Badwe showed you. So 1,600 patients cannot be accrued in 6 months. 1,600 patients will take 3, 4, or 5 years to accrue, and then for a median follow-up of another 3, 4 years, you need that kind of a dedicated funding. And that is what has come through to investigators in our institution through the mechanism of the Department of Atomic Energy. We, of course, also have the ethics committees that are constituted according to the regulatory framework that is prevalent currently in India. And IEC, again, like the researchers, has their own standard operating procedures that are updated from time to time. And believe me, an SOP is not created overnight. It has all consultations from all the stakeholders. And as and when it is created and revised, a lot of thought has to go into how we create the standard operating procedures and then to ensure compliance with that procedure. So one of the enablers of research in any institution, especially in an oncology institution, is to create a tumor tissue repository. Because tumor tissues with linked clinical information that is longitudinal in nature is the sine qua non of conducting important, insightful studies in the modern time. And many years ago, more than 13 or 14 years ago, Tata Memorial Center was the first institution in India to create this National Tumor Tissue Repository. At that time, it was funded by the ICMR. And subsequently, of course, the institution has taken over the running and the funding and the operations of this tumor repository. And now we have tumors that are stored in liquid nitrogen in -80 degrees, DNA, RNA, as well as the germline, along with the linked clinical information. And these tissues and the clinical information is dispersed to researchers, not only from within our institution, but also to other researchers in India, as and when we receive those applications. And this is very important for any modern oncology institution to create this kind of a repository. The number of publications have increased over the years, but the number is not so important. Even if you perform fewer studies, there should be impactful and meaningful studies that make a meaningful change to the outcome. So several of you might have heard of Peter Higgs, who received the Nobel Prize a couple of years ago or 3 years ago for discovering the Higgs boson. And you know, Higgs boson is called the God particle. The total number of papers that he wrote in his life are 5, and he received the Nobel Prize for one of them. So it is not necessarily that, you know, I need to have 800 papers to be able to make an impact, or any institution needs to have 10,000 papers. Of course, if you publish more, the chances are that, but quantity should not trump quality. So let me give you a few examples of the kind of clinical research studies that we have conducted. So I think Dr. Badwe has already told you about some of the landmark breast cancer studies that he has led over the past many years. The paper right on top was whether to perform surgery or not in patients with metastatic cancer. It is not a useful idea. It has been a highly impactful study and has led to defining the practice in these patients all over the world. He told you about the progesterone study. So what I want to show you is that the funding for all these studies has come from the Department of Atomic Energy. And it has come not for 2 years or 3 years, it has come for 10 years or 15 years. And that is what has enabled researchers within our institution to be able to conduct these studies. He also told you about the local anesthesia study on the left. On the right, the yoga trial, a large randomized trial of performing yoga versus usual exercises. And this was presented at the San Antonio Breast Cancer Symposium last year. And this showed that yoga not only improves the quality of life, but also although not statistically significant, you can see the survival curves, the survival is also improved. And then we also presented this study, the first ever practice-defining definitive study of proving that use of platinum in the neoadjuvant setting in patients with non-metastatic triple-negative breast cancer improves the outcomes. In head and neck cancer, the study right on top was conducted and led by the head and neck department, Dr. Anil De Cruz and colleagues, and it showed that performing neck dissection in clinically node-negative patients actually improves both overall and disease-free survival. Below, the best way to use platinum when given as concurrent chemotherapy may be every 3 weeks rather than every week. And then also other studies of how to use metronomic chemotherapy. So Dr. Banavli is sitting here in the audience and he's the overall course director. And he has led a very important thought process within Tata Memorial Center in the past 15 years to show that continuously dosed low-dose chemotherapy may actually be either as effective or in some instances even more effective than the usual big dose every 3 weeks kind of a regimen. But very recently, not very, but somewhat recently in the past 4 or 5 years, this thought process has matured in terms of level 1 evidence to say that this is an appropriate thing to do. So the paper below, also by our medical oncology colleagues from the head and neck group, showed that oral metronomic chemotherapy may actually be even more effective than intravenous chemotherapy in some patients. And then we know that immunotherapy is very important. But our colleagues from the head and neck medical oncology have also shown that low-dose immunotherapy may also lead to clinically meaningful outcomes. So this is the kind of research that will not emanate from many other centers in other parts of the world. Although this is Merck Foundation, but I have to say it will also not emerge from pharmaceutical companies. So this is useful because it gives guidance to physicians all over India as to what can be used in a cost-effective manner to provide clinical benefit to our patients. Below, the opportunity to perform mandibular preservation in patients with locally advanced disease. And again, very important because head and neck cancer continues to be a very prevalent and incident cancer in India and many similar countries because of the widespread use of tobacco and other habits. In cervix cancer, right on top, Dr. Badwe spoke to you about the need for linear accelerators as well as cobalt therapy. Recently, our group from gynec cancers proved that performing intensity modulated radiotherapy results in lower side effects compared to 3D conformal radiotherapy in patients with cervix cancer. Below, we showed that performing concurrent chemoradiation, giving radiotherapy with simultaneous weekly chemotherapy is superior to doing chemotherapy followed by surgery in patients with locally advanced cervix cancer. So these kind of studies tell the policy makers that you cannot say that I will not provide enough radiotherapy equipment and manpower in many parts of India and other parts of the world, because without this kind of infrastructure, these patients cannot be treated. Their outcomes will be suboptimal and not up to the mark. In lung and prostate cancer, so on top, so I'm just showing you a selection of studies. I'm not showing you everything that has been done in our hospital. And as you might have noted, most of these studies are published in the most impactful journals of the world, Lancet, the New England Journal of Medicine, Journal of Clinical Oncology, JAMA, and so on. So giving the tyrosine kinase inhibitor along with chemotherapy results in superior outcomes compared with doing only the TKI. Again, our colleagues from medical oncology have produced a very impactful result. And below, our colleagues from the urology group, the radiotherapy and urology group, showed that when you have a patient with localized prostate cancer, it is useful to radiate the whole pelvis and not just the prostate, because the cure rate is much higher if you radiate the whole pelvis. Now, this is the first evidence that has shown that this is how patients should be treated, and this has defined practice not only in Tata Memorial Center, but all over the world. And these are the kind of studies that we have prioritized over the past 15 to 20 years. And although each paper has one person as a first author or as the corresponding author, you will note that each paper also has about 20 or 25 individuals as authors, because this is teamwork. And believe me, a number of authors, there are clinical trial coordinators, biostatisticians, and others. So what I told you in the beginning, creating a clinical research secretariat, creating a clinical trial center, having all that infrastructure is what is required to be able to create or to pull off the kinds of studies that I have shown you. So in gallbladder cancer, again, a very common cancer in India, how to treat patients with advanced disease. In children, how do you improve the long-term cognitive outcomes in children who need radiotherapy? That was the publication below. We have an extremely active hematopathology group. They have performed some of the most impactful studies on how to diagnose, classify, and prognosticate patients with leukemias and other hematological cancers. And you can see some studies with flow cytometry or with molecular pathology. And these are the kind of studies that help guide our clinicians in appropriate management of our patients. One of the most unique things about Tata Memorial Center within India is that we also have emphasized public health research. It's not just clinical trials for already diagnosed patients or a group of patients, but also what will impact the population at large. And I don't know if somebody has already told you, but this was a large randomized trial of performing screening for breast and cervix cancer, not with mammography and with pap smear, but with techniques that were implemented by 8th or 10th standard pass ladies in the community. And these were clinical breast examination and visual inspection of the cervix with acetic acid. 150,000 individuals in those community, women in the community, 75,000 received clinical breast examination and acetic acid evaluation, and the others were the control group. And you can see that for cervix cancer, there was a 32% reduction in mortality. This was presented at the plenary session of ASCO about 10 years ago. And then for the breast cancer component of the study published in the British Medical Journal a couple of years ago, also a substantial reduction in breast cancer mortality by clinical breast examination in women above the age of 50 years. Now, what this has done is to enable the government of India to implement VIA and clinical breast examination as the actual modalities of screening in the primary healthcare centers and the secondary healthcare centers. So in 21 states of India, where the Anganwadi workers are told to perform screening, these are the methods of screening that they are advised. And if somebody was to get up and say, where is the evidence that you should perform clinical breast examination, then here is the evidence. So evidence-based practice of both therapeutic treatment as well as screening is what we aim at. In some parts of North and Northeast India, gallbladder cancer is very highly incident, and it's still a mystery as to why that is so. There are some thoughts, but what predisposes individuals in some parts of India and in some South American countries like Chile to get a high incidence of gallbladder cancer? So our colleagues from the Center for Cancer Epidemiology performed this study. This is a genome-wide association study, and they showed that some SNPs, single nucleotide polymorphisms, linked to biliary transport proteins, if they are present, then those individuals are at a much higher risk of getting gallbladder cancer compared to others. And now the current generation of trial that we are conducting is to incorporate this information in the risk stratification and then perform a clinical trial on gallbladder cancer. So we have learned several lessons that well-designed clinical trials or correlative studies are likely to answer important clinically actionable questions. And this is not just in cancer, but in all non-communicable diseases. I think cancer is a typical example of a non-communicable disease. The same principles can be applied to cardiovascular, renal, pulmonary, etc., and so on. We need a relevant question. It need not necessarily be something that is exciting Americans and Europeans sitting elsewhere, but it should be exciting to us. It should be relevant to us. It should have the potential to define clinical practice, not only here, but everywhere where such patients are seen. It has to be well designed, including a uh, well thought of statistical plan, and preferably in a randomized manner if we have enough patients to enable randomization. And of course, a meticulous follow-up, funding, and as I said earlier, an appetite for long gestation periods. Believe me, everything that I've shown you today could not have been conducted with a 3-year funding cycle, not even with a five-year funding cycle. It needs at least 8 to 10 years of funding for each project for it to come to fruition. And one thing that I'm fond of saying, that the funders should also have an appetite for failure, because the surest way to achieve success, definite success, is mediocrity. If you don't want to do anything innovative, one is sure to succeed because one is not aiming high. As soon as we embark on things that are innovative, we have to take some risks. And so there cannot be 100% success in what we do. There are some studies that will not be completed. There are some studies which will have negative results. And of course, in that process, there are some studies that will change the practice of how we do things, not only here, but worldwide. So we should have the appetite for risk-taking, for funding, for long gestation period with well-defined studies, and also to be able to create the infrastructure to pull all of this off. And then I think there is definite chance that we will have good success. So thank you very much for your attention.
Thank you very much, and thank you for the change, allowing the change, because Dr. Gupta had to go back to the other center, Kharghar, that is a little away from here. So we'll change gears now. You have heard about more of adult oncology. Now we'll change to pediatric oncology. And maybe I think this is one of the only talk on pediatric oncology, but I think this is the topics have come from you all, and whatever topics have come, I think the Merck Foundation has changed that into this for this meeting. So you heard up till now that whatever I think we do here is not only implementable teachings or knowledge, but also implementable research. And many of these things, when you go back, I think you'll be able to practice this back in your centers also. So how many of you treat children with cancer? Any one of you all treat children with cancer? Okay, one or two. I'm glad there's at least one. But I think what I'll talk is not theory, but most of it will be the practice, the principles behind what we do in pediatric oncology, and maybe that will help you all to do the same thing even in adult oncology, because principles remain the same. So as we know, actually, the outcomes of childhood acute lymphoblastic leukemia have been tremendous. Since in 1950s, 60s, not a single child with ALL would get cured. But slowly over time, you can see right from 0%, it has slowly improved to more than 90% now. And at least in the most of the Western countries, it's more than 90 to 94% of children with acute lymphoblastic leukemia now survive for 5 years. So the overall survival at 5 years has crossed 90% in most of the Western countries. How has this happened? Main thing is because we have now, what we have done is this risk and response adapted therapies. That is the foundation of the principles behind treating children with acute lymphoblastic leukemia. Because as we know, initially we used to be happy that if a child is cured of ALL, we were happy that, oh, we have cured a child, but that's no longer so, because more than 90% children get cured, you have to make sure that this is done with as little side effects as possible, because these children are going to survive for the next 30, 40, 50, 70, even 100 years, who knows, after they have been treated for their leukemias. So we have to make sure that how we can improve these outcomes with as little side effects as possible. And the other important thing that is different between adult and pediatric cancer is that I always say normally children like to play with toys, but our adult, oncologists like to play with toys. And you'll see in adult oncology, every week there's a new drug which comes in the market and they get a new toy to play. But we pediatricians actually do not have this, facility, because as you all know, whenever new drug comes, there is a lot of regulations even today. And the new drug, unless it is proven to be safe in adults, it comes in children over a long time. So we, the pediatricians, don't get these new drugs to play with, and therefore they have to play with the same old toys. And very importantly, actually, by just understanding how to use the drugs, this outcome that we have shown, this has come with the same drugs that were used in 60s, 70s, and 80s, we are using today, except for maybe a drug like, imatinib, which has come for Ph positive ALL. All other drugs, whether it's vincristine, donomycin, all these prednisolone, all these drugs were there in 60s, 70s, 80s. And they are the same drugs that we use. But even using the same drugs, we have shown that we can improve the outcome of the patients if we know how to do this. And this has happened because of this. We have done, basically there have been multiple groups across the world who have done various trials to see what works in these children. And again, like Dr. Sujit Gupta just showed you, this does not happen overnight. This has happened because a lot of these groups have done trials which have been run over years, because it takes in ALL, as you all know, the treatment is for nearly 3.5 years. So to get the enrolled patients, it may take 5 to 6 years, and then you have to see the 5 years outcomes for another 5 years. So usually a trial in ALL lasts for at least 7 to 10 years. So all these groups have done so many trials across the world, and that is how we have learned what works and what does not work. How not only what works, but what works in a good way. That means with as little side effects as possible. And you can see here, very importantly, even though there have been so many groups that do ALL trials across the world, very interestingly, most of these groups, the good groups, have outcomes in the same range of around 85 to 90%. So all these groups have done, but each group has shown us something different. Like, for the BFM group showed that the reinduction is a very important aspect of treatment. St. Jude group showed that the CNS prophylaxis was very important. They showed us the MRD, the minimal residual disease is important. So each group has given us a different thought. But because of these trials which were done across the world, we have been able to improve the outcomes, again, using the same drugs that were available to us. So what are the key components of treatment of childhood ALL? The first one is the empiric, and the most important one is the empiric multi-agent induction therapy. So this is the first treatment. We use the induction therapy. And another aspect, which again, like I told you, St. Jude group gave us way back, was that you have to basically give pre-symptomatic CNS therapy, because if there is no CNS directed therapy, there will be many CNS relapses, and then the outcomes will decrease. So pre-symptomatic CNS therapy has become very, very important part of the ALL therapy. Then is the early intensification of chemotherapy, which is again, either it can be systemic or intrathecal. There is a phase of consolidation, intensification, early reinduction, augmented therapy. So all these are part of or types of early intensification chemotherapy. Then there will be some group of patients, especially the high risk, who will require late intensification also. And that is another aspect of the therapy. And most importantly, as you all know, one of the important aspects of ALL therapy is the maintenance therapy. So that's very important, because there was normally we use nearly 1.5 to 2 years of therapy. So the Tokyo group thought, why 2 years? Why do we have to treat for 2 years? Let us decrease the maintenance to 6 months. And when they did that, there was nearly 40% relapse rate, more than the control group, which received the full 2 years maintenance. So since then, we do what we call minimal residual disease. That means after 1 month, we estimate the residual disease, and even that at that time, or even at day 15, if we see that there is no MRD present, even that there is no group in the world which has the courage to decrease the maintenance therapy, and still we normally now give at least 2 years of maintenance therapy. And very importantly, now in a high-risk group of what we call the PH like ALL, we have even increased the maintenance to 2.5 years to 3 years. So an extended maintenance now is part of the high risk group, which is the pH like ALL. So there is still, this has become the very important part of therapy, is that is maintenance therapy. And the metronomic therapy that Dr. Sudhip Gupta mentioned to you, I think one of the aspect of why we use now even in adults is that this metronomic maintenance therapy is a part of metronomic therapies. And up till now, we used to think that the therapy that we give in maintenance tries to kill the ALL cells, but that is not so. Now we know that many of this work as basically changing the tumor microenvironment, that is anti-angiogenic therapy, as well as immunomodulatory therapy. So this maintenance therapy works in a different way. It not only kills the cell or may not even kill the cell, but it modulates the environment, modulates the body's immunity, and that has helped us to improve the outcome. And this concept, I think, slowly will come even in adult oncology. And next few years, we are already seeing some maintenance therapies being used in different solid tumors. But I am sure that in next few years, it will become an integral part of many of these therapies, even in adult oncology. So these are the main key components of ALL therapy. But very importantly, and I think this is one of the most important, or the most important slide, if you have to take back principles of therapy. And like I showed here, the treatment outcomes normally depends on various factors. We all know it depends on the seed, that is the biology of the leukemic cells. So there are certain this thing like you must have heard hypodiploidy, which don't do well, or hyperdiploidy, which does very well. So the biology of the seed of the leukemic cell is very important. The soil or the tumor microenvironment, as we know, is important. The pharmacokinetics and pharmacogenetics is very important. So we have to understand how to give the drugs, when to give, what dose to give. So that is also important. And now we know that after we started using the minimal residual disease and all, that the response to the treatment, the same principle is in adult oncology also, like we do a PET scan to evaluate the response after say 2 cycles or 4 cycles. So treatment response is important. So all this is important for the treatment outcome. But very importantly, I put up the most important one, and that is the appropriate treatment. So for example, if you treat an ALL patient like with the AML protocol, it's not going to work. Or the other way around, if you have a child of AML and you treat as on the ALL protocol, it's not going to work. And this remains true for any cancer. And that is why we always say that when we train through Merck Foundation anywhere, the pathologist is a very, very important component, because if a pathologist does not give a proper diagnosis to the clinician, whatever the clinician may know the best of knowledge that you have to treat ALL this way, but if the patient has AML, then to treat with ALL, the outcome is going to be 0. So that's very important, that appropriate treatment. And that now has become more refined, in the sense that, for example, lymphomas, once upon a time, we used to treat with a chemotherapy called CHOP. Most of you all must have heard about it. CHOP was chopping, lymphoma was common. So even childhood, everyone used to get CHOP, but now we know that that's not enough. For example, a DLBCL is treated in a different way. Burkitt's lymphoma is treated in a different way. ALCL is treated in another way. So each subtype of cancers also are treated differently. So very importantly, the appropriate treatment is the most important aspect of treatment. And that is why each of your institutions must invest in a good pathologist, in a good lab, so that you get a proper diagnosis. And I think that investment is no longer a luxury. That means getting a flow report or MRD report is no longer a luxury. And I think each center, if not at each institution, at least for your country, you should have one place where you can get this. You can send a sample, get a flow report, get a molecular or a cytogenetic report that will help you in the long run to treat patients properly. So this is a very important aspect of the treatment. So I'm not going to talk about the whole, and there's no time also to talk about each component, but I'll give you some principles of what we do and how we have improved the outcomes in ALL. And the first thing is how to identify. See, ultimately, what is there? We want to prevent failures, and what is failure is relapse. So what we want to do is, if we want to improve outcome, is to prevent the relapses from happening, and how to identify children who are more likely to relapse. That's the first question. See, up till now, we used to do the morphological diagnosis. That means after the induction therapy, do a bone marrow, look under the microscope. If there are less than 5% blasts, we used to say that the patient child is in remission. But this is what happens here. You see the first line up there, that is 5%, this thing. So this is the 5% line where you say that the patient is remission. But that 5% may be sorry about that. So that 5% may be either here or the patient will be here. So the outcomes are going to be different. And how we can see this is by doing the minimal residual disease estimation. And this is what we do. So we can do it either by flow or by molecular studies. But flow is more commonly done because that's easier to do and maybe less expensive also. So when you do by flow, you can see that this patient has this residual disease here, whereas this patient has no residual disease. So by doing the flow, you can estimate whether the treatment response is there or not. So this will help you to identify patients who are more likely to relapse after the induction itself. So rather than waiting for the child to relapse, you identify these are the patients that are more likely to relapse, and we can intensify the treatment at that time only. So after induction, if you basically have MRD positive, you can intensify the treatment further and try to improve the outcome. So one way to do that is by doing the MRD estimation. So this has been shown by, again, St. Jude was the first one to not only show this, but use this in their protocol and say that if you intensify, the outcome will improve. And that is what they've done. And they've even gone further to do it not at the end of induction, but on day 19. And this is what they showed, that if you on day 19, you have basically upper one, you can see those who have negative on day 19, most of them will do well. Whereas those who are day 19, if they have this thing, they go down and do the day 46 MRD estimation and then further this thing. But ultimately, it shows that those who have residual disease, they are the ones who are going to do poorly. And especially if you improve the outcome on day 19 itself, intensify, then you can improve the outcome of patients who have a residual disease there. So the first thing to do is to find out who are the patients who are going to likely to relapse. And that is by doing this MRD estimation. Now we can improve the protocols upfront only, so that helped us to improve the outcome. But the other thing now, understanding that these are not going to do well is one thing. But then what we want to know is what we can do to improve the outcome of these children. And that is what. So ultimately, what is MRD positivity? MRD gives you cells which are present at the end of your treatment in vivo. So what has happened in the body after giving the treatment? So what it signifies is that these are the cells which are resistant to the treatment. So now when you have done the MRD estimation, you have seen it's MRD positive, then you know that these are the resistant cells which are there in the body, and how you can basically study the mechanisms of resistance. So you want to not just know that these are residual cells there, but why are these cells remaining in the body? And that is what we do by understanding the mechanism of resistance. And there is basically, this helps us in different ways. So up till now, doing genomic studies and all was considered to be luxury, but no longer. Actually, now most of the centers, at least wherever possible, we are doing these studies, so that helps us not only to understand the biology, but also to understand how we can further refine restratification, further use more, newer types of therapies, and especially now the targetable therapies which are available. We understand these are the why the resistance happens and how we can bypass the resistance. And sometimes resistance using chemotherapy is one thing, but now that immunotherapy is there, we can use this aspect of therapy and try to improve the outcomes. And this has helped because we have done this type of studies, what we call genome-wise analysis of genetic alterations, how this resistance happens in this group of patients. And one thing, for example, was this patients are children with the pH-like ALL. So pH-like ALL is not the pH ALL. pH ALL is easy, there now that we have imatinib, the tyrosine kinase inhibitors, we treated with that, improved the outcome. But there was another group of patients which were pH-like, though not pH, but pH like ALL. And there we saw that you can see here that as the age increases, basically the pH like ALL increases. And very importantly, actually, the outcome decreases. You can see here that those who have pH like ALL, they used to do poorly, but now understanding that this pH like ALL are the ones which have resistant cell after the induction therapy, they tried to modify the treatment, and with various modifications now, they have shown that basically even if you have pH like ALL, if you modify the treatment appropriately, change the treatment, I'm not going into details because none of you treat children with ALL, but understand the principle that if you modify the treatment, understand the biology, change the treatment, you can see here that the outcome which used to be poorer in patients with pH like ALL, now the outcome is as good as your other regular ALL. So this, basically helped us to understand the biology, understand how to modify the treatment, when to modify, how to modify, and that has helped us to improve the outcome of these patients, even with pH like ALL, is now become as good as your non-pH like ALL. So this is another aspect to say that, when you do this type of molecular studies, you can basically find out which are the patients. For example, if you have the children have ABL classification, ABL class fusion genes, we now add dasatinib, which is a tyrosine kinase inhibitor, as you all know, which is used to treat pH, CML or pH positive ALL. Now we are using this even in patients with ABL class fusion genes. And further down, JAK kinase, if there is JAK stat mutation, then we are using ruxolitinib upfront only, and that has helped to improve the outcome in patients who have this mutation. So that was another aspect that we have seen, that first try to find out who are the children likely to relapse, then how the relapse occurs, or what is the type of resistance in that patient. And the third thing now, which I'm showing you just in one slide, is that, like I told you, the outcomes have increased now to more than 90%. One of the important things that we saw, that when we treat these children with radiation, the St. Jude, initially no one used to get radiation, then all the children started getting CNS radiation. But when you give CNS radiation, there are many long-term side effects of radiation, including what we call cognitive defects, and including other, secondary cancers also. So now we have gone the other way, right from no radiation to radiation to all children. Now we have gone back to that same thing of giving no radiation to any child with ALL. And this is what we have done now, that we have now giving what we call risk adapted therapy. So decrease as much side effect as possible. And you can see as that even without radiation to any, in this protocol, even the CNS positive, that means children who had CNS disease at presentation, were not given radiation. And you can see only 2.2% of patients had isolated CNS relapse. And very importantly, actually, once they were having relapse, once those children who have not received radiation initially, once you treat them at the time of relapse, all of them can be cured of the disease. So again, all the patients who had CNS relapse got cured later. So now we have gone back to that thing of giving radiation to no child with ALL, and that has helped us to decrease the long-term side effects. So this is what I mean to say by risk-adapted therapy and refinement of therapy in the long run, decreasing the side effects. And again, you cannot stop by showing what we do regularly, but now there are novel therapies which have also come and helped us to improve the outcomes. And one of the things, like we all talk about, is the immunotherapy. And immunotherapy is of various types. One of the common immunotherapies that we all know is the antibody therapy. So we had rituximab, then we had basically, CD19 antibodies, then, CD22 antibodies. So you can see that we are now using more and more antibodies in our treatment. And I'll just show you, because of short of time, I cannot discuss in detail. But for example, this is Blina, which is which has double antibody, CD3 and CD19. So what it does is, when you give that, it brings the CD3, which is the T cell, nearer to the cell which expresses CD19, that is your B-ALL cell, so that it will help to kill the tumors. So that is one type. And that it has shown now that patients, this was last ASH, where they showed that basically if you give Blina this antibody, you can decrease these, the intensive therapy, and by giving this antibody, you can basically cure more patients of relapsed ALL with as minimal therapy as possible. So not only improve the outcomes, but decrease the side effects of therapy. And this is what was shown here, that the 2-year DFS and the OS was much better in patients who got the Blina antibody as compared to those who got intensified therapy. So what we have seen is that now we cannot go on intensifying therapy because side effects are there. And this is very important, especially for our lower middle income countries where we have limitations of supportive care, is that if you can decrease the therapy, and today the antibodies are expensive, but tomorrow once you start getting generic antibodies, the cost will come down. And once that happens, we can decrease the therapy and improve the outcomes at a cost effective manner. So people are already using, like shown here, the antibody upfront in that therapy also. Not only the one which I showed you, the paper was at time of relapse, but now we are already using this modalities upfront in the therapy. And that was Blina. The other one, basically, we are even using inotuzumab, which is the anti-CD22 antibody. So that also has been used. So we are now going to use more and more antibodies in improving the outcome of children. And the other aspect, all of y'all must have heard, and everyone is talking about it now, is the CAR T cell therapies, the chimeric antigen receptor, the CAR T cell therapies, which are already there in use outside. CD19 is the commonest one which has been used. And this was the first girl who got this CAR T cell therapy, and she's alive even today. But now this has become basically FDA approved. And this is our own at Tata Hospital. We have developed our own CAR T cell along with IIT, which is another institution. Dr. Gaurav Narula from our institution has done that with Dr. Rahul Purwar of IIT. But this just last week has gotten an approval from our regulatory, like FDA approval. We have the DCGI approval. So that we have got now, and this will be commercially available. Very importantly, this will be at least 1/4 the price of what the CAR T cell you get from the US companies. So, this may help in at least in some of your countries, or you may, want to send some of your patients over here for CAR T cell therapies. This is what, basically I talked about was mostly from the developed countries. But what happens at our level is that we have to understand biology alone is not enough. And many times what happens in India and maybe even in your countries is that we lose patients to toxic deaths. That means because of infection, because of induction deaths, bleeding, we lose patients. So there is limited supportive care. So we have to tackle even the induction deaths, the remission deaths. So we have to make sure that we decrease the intensity of treatment as much as possible. And this will happen once we have the other things in our armamentarium, like the antibody therapies. Improper treatment, again, very important. Like I told you in the beginning, if the diagnosis is not proper, whatever you do, the outcomes are going to be poor. So improper diagnosis, treatment not given by pediatric oncologists. Many patients in our world get the alternative and complementary medicine, so that should be avoided. Not maintaining treatment intensity, that means especially during induction and during maintenance both. So this also affects this thing in the long run. Inadequate treatment supervisions, again, very important. Nutrition is so important in our part of the world that you have to give thought to even good nutrition if you have to improve the outcome. Late presentations, again, getting these children diagnosed as soon as possible helps a lot, because many of the children in the West have improved outcome because they are diagnosed early, whereas many children in our part of the world come to us late with a lot of side effects, infections, so that it decreases the outcome. And last but not important, the drug quality, because in India, for example, you heard yesterday, we are the drug capital of the world. We provide generic drugs to many countries, but very importantly, many of these drugs are not of the same quality that we want them to be. So we have to take a look at that. And that is why, in India, we always say that compared to the Western focus on the risk refinement and adapted therapy, the thrust in low and middle income countries should be on indigenous, regionally relevant interventions to minimize toxic death. So that's a very important part of a thing. and to decrease relapses. And this we have shown that if you, for example, if you there is delay, if there is delay in treatment, it's okay. But if you make significant changes in a treatment protocol, the outcomes are poor. So we have to make sure that we stick to the protocol as much as possible. There should be no major deviations to the delivery of treatment. Again, that helps, that causes more relapses. Because of lack of time, I'll not go in detail, but keep in mind that stick to a protocol, whichever protocol you use. Do not deviate from protocols, even if there is some delay. But this is what I think that's going to be the future of ALL therapy. That means the low risk, actually low intensity remission induction, consolidate with antibodies like inotuzumab and later BiTE, and maybe some of the patients will require CAR T cells. But very importantly, we have to decrease the treatment as much as possible, because still now toxic deaths are more than relapses in our part of the world. And this will help. If the cost is good, this will help us to improve the outcome. The same will be for TALL. And ultimately, we have to, there are many things that we can do. I'm not going in detail, but these are the main components: the induction, consolidation, interim maintenance, and delayed intensification. And this will help us to basically end the maintenance. And this will, refinements in this will help us improve the outcome of our children with ALL. And again, targeted therapy and immunotherapy may be key factors in the near future that will help us to improve the outcome. But at present, our goal should be to decrease the toxicity as much as possible and have a good diagnosis in the beginning. And that is going to further help us give proper treatment to our children with ALL. But ultimately, we say that children with all cancer, whether ALL or any other cancers, are highly curable. But you have to, that comes with an if, and that is provided they're diagnosed early, they're diagnosed properly, and more importantly, they are treated appropriately. Thank you very much for it.
A very good morning. I would like to thank Merck Foundation for giving me this opportunity to be on this very prestigious stage. I will be speaking on triple negative breast cancer. Breast cancer, as we all know, is one of the most common malignancy in women. I can say in most of the parts of the world. Triple negative breast cancer in particular is very important because it has comparatively poorer prognosis compared to rest of the breast cancer patients, and it affects patients almost a decade earlier than other types of breast cancer. That is, these patients are usually in the prime of their life, and the overall outcome is quite poor. So this becomes a very important topic. Covering everything about triple negative breast cancer in one lecture is quite impossible. So what I'll be doing is I'll be just giving a brief overview of this type of disease and how the treatment of triple negative breast cancer is going to be different compared to rest of the patients that I'll be trying to cover. So these pathology is the basic in diagnosing a case. So as we see in earlier days, around 3 to 4 decades earlier, the diagnosis used to be just histopathology. That is, invasive breast cancer or invasive ductal cancer used to be the pathological diagnosis. But as the time passed, the important investigation which got added up was immunohistochemistry. With that, we knew that expression of ER, PR, and HER2 status is very important when it comes to prognosticating the disease. So patients who were expressing ER and PR were better prognosis compared to the patients who were not expressing ER and PR and HER2. But this, in last 10 years, the landscape has still changed, and we have gene expression profiling and now next generation sequencing. This explains why the disease is so heterogeneous, because even the patients who are of the same age group and the same histopathology behave very differently and respond differently to the treatments. And this is explained by molecular heterogeneity, as we see on next generation sequencing. So rather than treating CA breast as a whole, this St. Gallen consensus guidelines, what it did was it tried to divide the patients based on ER, PR, HER2, and Ki-67. That is the proliferation index of the tumor Based on that, it divided the patients into broadly 4 groups. Luminal A and B are the patients who express ER and PR. Then HER2 overexpressing tumors and the basal-like tumors which are which lack the expression of ER, PR, and HER2. So these broad classification did help to some extent to stratify patients into different prognostic categories and treat differently. But luminal subtypes, that is intrinsic subtypes, are just a superficial way of dividing this disease. On NGS, it could be seen that luminal A and B have a different molecular profile compared to the basal-like, that is the extreme. There are 2 extreme ends of the same disease. And as the ER-PR expression goes on decreasing, the prognosis goes on becoming poorer and poorer. Coming to triple negative breast cancer alone, these are around, if we take worldwide data, they account for around 10 to 15% of all breast cancer. But it is quite different in India, because in most of the studies in India, the expression of the TNBCs account for nearly sometimes up to 40% of the patients, and they are younger compared to the ER-PR positive patients. The chances of recurrence even after complete treatment is much higher. The time to relapse, that is, whereas ER-PR positive patients relapse even after 5 to 10 years of treatment, these patients, TNBC patients, relapse quite earlier, that is 1.3 to 3.3 years. And if we see the sites of metastasis, the metastasis is more common in the visceral organs, that is brain metastasis, liver and lung metastasis, compared to skeletal only mets, which can be seen most often in ER-PR positive patients. So all these put together give a poorer picture. This is our own data from Krishna Medical College. This was published last year in Indian Journal of Cancer. We could see that out of total number of patients, 33% were triple negative and nearly 45% patients were below 50 years. We can see the magnitude of the disease. Coming to the prognosis, as I mentioned earlier, luminal subtypes do well, whereas the triple negative, which lack ER, PR, and HER2 expression, they fare very poorly. But one should be very careful when we get just triple negative disease. Not all triple negative breast cancers are aggressive, because there are few exceptions to this rule, like adenoid cystic, apocrine, or low-grade medullary carcinomas. Although they lack expression of ER-PR, still they fare much better than invasive breast cancer NOS. Coming to how we treat these tumors, as we all know, any patient of breast cancer can be put into one of 3 categories. That is, patient who is locally advanced, who is not a candidate for upfront surgery. They'll be receiving neoadjuvant chemotherapy to reduce the tumor burden. The patients who have been operated but non-metastatic will be receiving adjuvant chemotherapy, and the patients who are metastatic who will be receiving palliative chemotherapy. So I'll be just going through how the treatment in TNBC in these 3 settings is going to be different for this particular subtype of patients. The chemotherapy plan overall is same for most of the breast cancer patients, but the sensitivities to the same chemotherapy drugs may be different. Triple negative breast cancers, being very aggressive, are highly chemosensitive tumors. In all the settings like adjuvant and neoadjuvant settings, we mainly depend on anthracycline-based chemotherapy, that is either adriamycin cyclophosphamide or EC for 4 cycles. Dose dense, that is given every 15 days, is better because these are shown to improve survivals. Again, this is followed by 2 weekly or 2 weekly paclitaxel, which is for 4 cycles, or weekly paclitaxel for 10 to 12 cycles. There are many variations in this, but majority of the patients do word over follow the same protocols. And the same protocols can be followed for this triple negative also. But in the adjuvant and neoadjuvant setting, maintaining dose density, that is not reducing the doses, is very important because they do have reflection on outcomes. But when we are treating patients in the metastatic setting, this dose density and intensity need not be maintained. We have to balance the toxicities and the outcomes. Coming to neoadjuvant therapy, why, how is it can be applied to TNBC? What are the benefits of neoadjuvant? There are all theoretical benefits. That is, it's one of the in vivo chemotherapy sensitivity tests. We know which chemotherapy is acting, which is not. It targets micrometastasis early. As we know, CA breast is a systemic disease from the beginning, even earliest of the stages. So by targeting micrometastasis early, we most likely are going to improve the outcomes. In locally advanced disease, we'll be downstaging the primary tumor so that the surgical outcomes will be better. That is, locally advanced can be downstage to operable stages, and aesthetics may be better. One very important marker in when we're giving neoadjuvant chemotherapy is pathological complete response. That is, there is no invasive cancer remaining post chemotherapy after surgery, because this PCR is thought to be reflecting the survival outcomes, as Dr. Badwe sir had recently showed here, that PCR becomes one of the very important landmark to achieve, goal to achieve when we are treating triple negatives. So this was a very big meta-analysis of 13,000 patients, including 12 large trials. This was planned to assess the effect of PCR on event-free survival and overall survivals. And it could be seen from these graphs that there is surely the upper curve is for the patients who have achieved complete responses compared to the lower curves which have not achieved. So the event-free survival as well as overall survival were surely better for the patients who had achieved complete responses. And this separation of curve is especially so for triple negative breast cancer. If we see the chart here, the lowermost red curve shows the patients who have not achieved pathological complete response in triple negative breast cancers. We can see that the survivals is significantly lower compared to rest of the subgroups. Even the ERPR patients, positive patients who have not achieved PCR, they fare much better compared to the patients of TNBC who have not achieved PCR. So it becomes all the more important for triple negative breast cancers to be achieving PCRs. So is there any way, we know that we will be giving AC or EC followed by paclitaxel. Is there any other way of improving these PCRs in this particular subgroup? That we have to see. Based on this, we know that there is sure evidence that in locally advanced breast cancers, patients will be receiving neoadjuvant chemotherapy. But in triple negative breast cancers, where PCR become significantly more important, this is St. Gallen Cancer Consensus and ASCO guidelines. Both the very important agencies do consider that there is a strong consensus that even the early breast cancers, that is T2 to T2 or T3 tumors, even if they are node negative, and all the node positive, even if they are operable, that is early breast cancers also, if they are TNBC, should have received neoadjuvant chemotherapy. There was more than 90% consensus on this guidelines. This is the NCCN guideline. It shows that for patients who are T2 to T4, and even if they are node negative and all the node positives, it is preferable to give neoadjuvant chemotherapy. Even for T1 disease, you may consider in a select subgroup giving neoadjuvant in TNBCs. So can we add something into the chemotherapy to improve the PCRs? As we know, TNBC have a defective DNA repair mechanism. So adding platinum, which causes direct DNA damage, in the metastatic setting, surely it had improved outcomes. So can we add carboplatin in the neoadjuvant setting to improve the outcomes? There were multiple studies like JEPAR-6, CLGB, and brightness trials. The evidence was not uniform. Few of the studies did show improvement, whereas few like CLGB failed to show any improvement in survivals. So in this background, there was a very beautiful study done by Dr. Sudeep Gupta and Dr. Badwe sir at TMH itself of adding neoadjuvant carboplatin. There were more than 700 patients accrued, and what they did was it is a very simple study design. Along with weekly paclitaxel, giving weekly carboplatin for 8 cycles, followed by EC or AC, either 2 or 3 weekly, for T2 to T4 and all node positive patients. It was a randomized trial. It could be seen that 5-year event-free survival, there was 6.6% improvement in 5-year event-free survival. But what was more interesting was all this EFS improvement was driven by patients who were less than 50 years. Less than 50 years patients who had received carboplatin along with the routine chemotherapy, there was 12.5% absolute increase in EFS. Whereas more than 50 years, the difference was not so significant. Overall survival, again, there was to overall ITT population, it was 7.6% improvement. And this was 11% OS difference in patients who were younger than 50 years. PCRs again were improved. In younger patients, that is less than 50 years, premenopausal patients, there was 20% improvement in achievement of PCR, which surely did reflect in EFS and OS data, whereas this was not seen in elderly patients. So based on this, we can, for now, surely with confidence add carboplatin in younger patients, premenopausal patients, and it's relatively very well tolerated chemotherapy, almost available to all of us at very low cost. Just a mention about the use of immunotherapy. Immunotherapy is significantly active in triple negative breast cancers because they have a high mutation burden. They are highly immunogenic tumors. So this Keynote 522 trial is use of pembrolizumab along with chemotherapy in the neoadjuvant setting. Here, pembrolizumab was added to chemotherapy skeleton, and this was compared to chemotherapy alone. Patients underwent surgery after neoadjuvant planned therapy. Pembrolizumab was continued for 9 more cycles, irrespective of the responses in the adjuvant setting also, whereas patients on the control arm didn't receive any adjuvant treatment. It could be seen that pathological complete responses, which are with chemotherapy alone in the range of 40 to 50%, improved to 64.8%, which is quite significant. And also in the recent update of the trial, the event-free survival also is shown to improve with addition of pembrolizumab. Also, although it's a very costly drug, it's not for everyone, but surely we should be knowing the what is happening new in this scenario, so that at least few eligible patients can benefit from this drug. But there is a difference in the background in which this trial was conducted. PD-L1 was positive in nearly 80% of the patients, whereas we see in our setting around 30 to 40% of patients will be PD-L1 positive. But PD-L1 benefit was irrespective of PD-L1 status, and most of their patients were early stage, whereas we see later stages of the disease. And one more drawback here is, what if after completion of pembrolizumab also there was a residual disease? We couldn't do anything much for those. So we don't know what is to be done for those patients who don't achieve a CR after pembrolizumab. So that was for neoadjuvant setting. Coming to adjuvant chemotherapy, if the patient has upfront undergone surgery, is going to be the same, that is AC Taxol. If patient has received neoadjuvant chemotherapy and has not achieved good responses, can we intensify treatment in adjuvant setting? That is one question to be answered. So in this setting, that is patient has received complete neoadjuvant therapy, anthracyclines as well as taxanes in the neoadjuvant setting, but still have not achieved PCRs. By adding one more drug in the adjuvant setting, can we improve the survivals? This was studied in this capecitabine trial. Capecitabine is one more drug which is very useful in the metastatic setting, CREATEX trial. It could be seen here all HER2 negative patients were included. It could be seen from these lower curves, which are for triple negative cancers. it could be seen that the overall survival as well as event-free survival are significantly better if we add 6 months of adjuvant capecitabine for patients who have not achieved PCRs after neoadjuvant chemotherapy. So this most often we are following this regime because capecitabine is again one of the easily available drug, and for locally advanced who have not responded well, maybe adding this drug in the adjuvant setting, which is very well tolerated for 6 months, will improve survival for this young group of patients. But still, there are many unanswered questions in this region. That is, what after pembrolizumab, if they have not achieved PCR, can we add capecitabine in this setting? We don't know. Another subgroup of TNBCs is BRCA positive, germline positive patients. Nearly 5 to 10% patients overall will be BRCA positive. If they are BRCA positive, do we apply the same therapies, same guidelines to those patients? We are still not very sure. And there is one more group of drug which are given for BRCA positive, that is PARP inhibitors. This group has shown some benefit in one of the trials in the adjuvant setting. How do we combine all these data and make sense for the patient is still remains unanswered. Coming to palliative therapy, chemotherapy surely remains the mainstay. Drugs which are used in the adjuvant setting, neoadjuvant setting, same drugs are to be used because they are the most effective ones. There are many other drugs which also can be used. There is always a debate whether single agent has to be used or combination has to be used. This has to be personalized decision based on what is the extent of disease, what is the volume of disease, whether the patient is in visceral crisis, whether the response rate of response is going to be important for the patient. If so, combination is preferred over single agents. There are few newer agents which are being tried. Again, the pembrolizumab in metastatic setting, which is Keynote 355 trial. In the first line setting, if patient was having metastatic TNBC, in these patients, it was a randomized trial with the addition of chemotherapy, pembrolizumab to chemotherapy or chemotherapy alone. Chemotherapy arm did include platinums. And the patients were stratified, the results were stratified based on PD-L1 expression levels. It can be seen that survivals, responses, survivals, disease-free survivals, and overall survivals did improve for all the patients, but the difference was statistically significant only if the PD-L1 CPS score was more than 10. So pembrolizumab has been approved only for in the metastatic setting only for patients who have PD-L1 CPS score of more than 10 and not below. So these are the results of the same trial. Median survival did improve from 16 months to 23 months, which is very important in this setting. Again, as I told, there is a good overlap of patients of TNBC with BRCA. PARP inhibitors act by synthetic lethality. That is, patients who have a defective DNA repair mechanism because of BRCA positivity, they cannot tolerate one more damage which is caused by PARP inhibitors, and the cells with HRD deficiency are more prone for death. So this was a trial which used olaparib in HER2 negative patients who were BRCA1 or 2 germline mutated and who should have received 2 or less lines of chemotherapy. 300 patients were included, and olaparib was compared with treatment of physician's choice, and the same outcomes were measured, that is response rates, PFS and OS. It could be seen that both PFS and response rates were better for olaparib, but overall survivals didn't reach significant levels. Olaparib presently is a very costly drug, not very easily, even we don't use it very often, but surely promising with more of generics coming in. But we need still more data before trying out these. Last but not the least, October is Breast Cancer Awareness Month. Surely increasing awareness and screening is going to improve outcomes for this disease. This is a photograph of breast cancer awareness. We had done a awareness program in our institute. This is one of the largest hand printed awareness ribbon. We had more than 3,000 to 4,000 medical students, staff, and patients participating in it, and we could register this for Limca Book of Records. So hopefully this way, increasing awareness will increase outcomes in these patients. Thank you.
Thank you very much, Dr. Rashmi Kudur, for the insightful presentation and on the topic triple negative breast cancer. So now the floor is open for the questions.
Thank you, Doctor, for the presentation. Dr. Jaita from the Gambia. I just wanted to ask, given that triple negative breast cancer is actually a common cancer in India and in most of our countries, because it's common in Black females. I just wanted to ask, in a scenario wherein you have a patient who has a localized disease and has undergone neoadjuvant therapy, that's dose dense ACE and then weekly paclitaxel, would there be any indication for adjuvant chemotherapy if that patient had complete response, complete pathological response? That's the first question. And the second question is, in that same patient, if there were to be a reoccurrence in, let's say, about 5 years, what would the protocol be, given that triple negative breast cancer has limited treatment options when it comes to hormone therapy? Thank you.
So coming to your first question, that is, if the patient has achieved good response, if it is PCR, maybe we have to stop at that, and local radiation if at all required. There is no role of adding other drugs if patient has achieved PCR. And coming, if the patient, same patient recurs, it depends on what is the duration between the first treatment and recurrence. The later the recurrence, better, because anthracyclines cannot be reused, but paclitaxel, if the patient doesn't have any residual toxicity, it still remains a good drug to be used again. Other drugs like capecitabine, gemcitabine, all these platinums, if they are not used, that becomes a good drugs to be used.
Thank you.
Thank you.
Good afternoon. So my presentation is on radiation oncology in low resource settings. That is basically what we say the low LMIC, that is the low medium income countries. So in this, if you go, if you see by the year 2020, there were 19.3 million new cases, newly diagnosed cancers, and death has been 9.9 million. And in the next 20 years, we'll have in these countries 30.2 million cases with 16.3 million deaths. And as per the data of 2010, there were 7.5 million new cancer cases in LMIC, whereas only 30% had access to any reasonable treatment services. And there is an expected rise in annual cancer incidence, nearly 70% by 2030 over the 2010 figures. And this could be attributed to the increased population age, which has been possible because of improvement in primary healthcare and survival from communicable diseases, as well as adoption of unhealthy lifestyles. And these 40% of these cancers can be prevented, and a third can be successfully treated. So coming to the estimated trends in cancer incidence as per Globocon 2008, for the less developed countries, whereas in 2010, there were 7.5 million cases, by 2030, would expect 12.8 million cases. Whereas the increase in incidence for the high-income countries would be about 43%, with increase in mortality about 59%. For the LMIC, it will be 72% increase in the incidence and 76% increase in mortality. And for these countries, it is that they have a low allocation of GDP spending toward healthcare, despite enormous economic losses of cancer mortality and morbidity. Because if we take care of the cancer, maybe a lot of economic burden could be lessened. And because we have a loss of economic losses because of this cancer, the mortality and morbidity. Radiotherapy is a major part of the investments in fight against cancer, and 50 to 60% of cancer patients would require radiotherapy with or other modalities, depending on the type of cancer. And is for our setups, like in the LMICs, in Asia, Africa, we have a lot of these cases of cervical and head and neck cancers. And most of these patients, they present at a very advanced stage. And for them, radiotherapy may be one of the mainstays of treatment. And optimal access, radiotherapy access and utilization can provide 2.5 million local controls and save 1 million lives annually by 2035. And the total number of cancer patients with indications for radiotherapy is likely to rise from 7 million to 12 million by 2035. So this basically shows the global access to radiotherapy. That shows basically those some places per unit, how many patients are treated in the developed countries. About 5 lakh, 1 unit is available for about 5 lakh population, whereas for sub-Saharan and some of the Asian countries, maybe 1 to 2 million patients, or even more than that. Sometimes 5 million are have just one radiotherapy unit available to them. And even some countries, especially those in the red, they have no access to radiotherapy. And this, depending on the region and particular population pyramid, the average crude rate varies substantially. And in the LMICs, the crude cancer incidence is about 500 to 2,500 per million people. And whereas for these countries, we have 1 to 3 radiotherapy machines available per million population. And whereas for the HICs, it's about 5 to 8 radiotherapy machines per million population. And this again shows, this is one of the recent data from the IAEA that shows the distribution of the number of radiotherapy units available for million population. As you can see in the North America and Europe, they're having 5 or more machines per million population, whereas for the Asian and African countries, sometimes it's less than 1 machine or 1 to 2 machines available for million population. And in some of the areas, they do not have any radiotherapy access. So this basically shows the IAEA recommendation that says that radiotherapy units per million population should be 4, and minimum 1.5 units per million population, and 1 unit should be treating at least 0.6, 0.7 million people. Whereas in the LICs, sorry for the mistake there, that is not LMIC, that is LIC, because I have included MIC and HIC. So for us, it's about 0.01 to 1 unit per million, which is grossly below what the IAE recommends. And 1 unit is able to treat in our setups about 5 million population, whereas for the HICs, it's 0.12 million population. And the megavoltage units available, this is data from 2019, that shows there were 14,875 megavoltage units available globally. And out of these, 63% were available in the HICs, whereas the rest, about 35% were available in the LIC and LMIC. Whereas this HIC has, they account for less than 20% of the global population, but they have 63% equipment available, radiotherapy units available. And in the past decade, the number of units that have increased, that is whereas for the HICs, it has been 73% increase in the availability of units, radiotherapy units. For the LICs, it has been just 8%, and for the MIC, it's just 19%. So the developing countries, they are home to 85% of the world's population, and only around 4,500 megavoltage units are available in LMIC. And that takes care of the less than 35% of the world's radiotherapy facilities. And most cancer patients in our region are without access to potentially life-saving radiotherapy. In Europe, there is 17 times as many radiotherapy units as available in Africa per million inhabitants. Similarly, in Latin America and the Caribbean region, they have just 1/3 of the number of machines available per capita in North America. So this basically is another estimate that was published by Datta et al. In 2014. They have tried to look into the radiotherapy infrastructure and staffing in LMICs. What are the needs for 2020? With regard to this, if you can see that with regard to the in 84 countries, they have analyzed the data, and required by 2020, total needed is a number of is about 13,307 teletherapy units, which is a percentage of additional required is more than 200% additional requirement of the existing at that particular time. Even the other thing, apart from the equipment, we also have a shortage of staff. That is a radiation oncologist. There needs to be augmented by about 102.9% in LMICs, and the medical physicists by 292%, and then radiotherapy technologists by 270%. That is the augmentation required to give at least some sort of semblance in radiotherapy care to our patients. And these radiotherapy needs are higher in LMICs than HICs. And as I already mentioned, most of the patients that present here, they're mostly in an advanced stage. And for these patients, many times it's basically a palliative treatment that is to be done, and maybe palliative RT and end-of-life care is one of the only options for these patients. And we know that radiotherapy has a good role in palliative care, and particularly, and this is particularly relevant for the low medium income countries. And over 80% of cobalt machines in many LMIC are providing palliative treatment because of the advanced stage of the disease that we have, basically head and neck cancers and cervical cancers and breast cancers. So most LMICs have one machine for more than 5 million population. That works out to be less than 0.2 machines per million population. Over 30 African and Asian countries have no services at all. In several others, a single cobalt unit for over 30 to 40 million inhabitants. And few LMICs in Latin America and Asia have one machine that less than 1 million. That is basically in the say Eastern Asia or like in the northern part of Africa, where we have some semblance of a good radiotherapy facility, but still that is not comparable to what we have in the West or in the high income countries. So in many countries, the number of new patients or per machine exceeds recommended number of 500, often reaching more than or equal to 1,000 per machine per year, and with increased shifts. That only is possible if you are treating the machines in more than one shift, which usually in our places, even in India, in many of the centers like our center in Varanasi, we have 3 LINACs working, but we run them in 2 shifts. At least 70 patients are treated on each of these machines. And still currently we have a waiting list of about 2 months to 3 months for radiotherapy. And we are in the process of trying to get more LINACs. And this lack of radiotherapy facility basically reduces the number of patients actually receiving treatment. And as a result, as I said, the waiting periods are increasing. And so this actually seriously affects the what you call the compromises the clinical outcome of these patients, because by the time we are able to treat, the disease must have advanced, and then subsequently the outcome is poor for these patients where we have a waiting list and we are unable to treat patients. So the increasing cancer incidence in past decade, that has widened the gap between demand and supply of radiotherapy in LMICs, because we are not increasing the facilities, but at the same time, the number of cases are also increasing. So as we see, by 2020, 26 of 54 African nations had no radiotherapy machine, whereas in the period between 2012 to 2020, the population growth has been 19%, increase in cancer burden has been 32%, whereas the radiotherapy coverage increase has been just 2.7%. And this is a similar to what we have in many of the Asian countries, South Asian countries, except for maybe China or maybe Singapore or Korea and other places. But this side we have this problem also there. In Indonesia, like for example, there with a population of 267 million population, 8 of 34 provinces had no radiotherapy services, and 10 provinces were to receive their first operational radiotherapy facility by 2023. So this basically, this shortcoming has to be addressed in a very planned manner, that is by implementing cancer care plans at the national level. And this has to, and this basically is helping in increasing the number of radiotherapy units, as is happening in India and some other countries. So because of the shortage of machine and because of increasing patient load, sometimes the staff has to compromise on the quality of treatment that is to be done, or on the simulation, dosimetry, and frequent machine calibration in order to treat more patients. So, and many times it's sometimes maybe the advanced techniques we are unable to do, maybe going for the conventional treatment so that we can treat more patients. And maybe in like in a study from Australia, Sweden, and Canada, for every 1,000 new cancer patients, 52% need radiotherapy. And the retreatment would be about for retreatment with radiotherapy would be for 23% patients who have been treated. Whereas as per the IAE experience, in developing countries, this level is higher. That is those patients needing radiotherapy. So in many of these patient places where we have operational radiotherapy facility, advanced techniques like they have limited capacity to deliver conformal radiotherapy. And as I said, the locally advanced cancers like head and neck, cervix, lungs, and breast, they constitute a large number proportion of the patients in the LMICs. And the mortality to incidence ratio for these cancer sites between HICs and LMICs, that shows that there is a poor survival in majority of patients diagnosed in LMICs, because most of these patients are presenting in an advanced stage, and maybe they have to wait for the treatment because of the long waiting list, less availability of facilities, so and accessibility of the facilities. So for these patients, maybe because of the proportion of patients cervical and head and neck cancer, for these patients, the first step toward improving outcome in these patients would be, we go by the standard treatment techniques rather than aiming for the like high-end techniques like IMRT, IGRT, and other things. Maybe in these advanced cases, simple radiotherapy treatment would be and a brachytherapy like for SCS cervix would be much more useful than trying to, okay, we might reduce the toxicities with IMRT advanced techniques, but what is more important is the disease control. Maybe toxicity can be dealt to some extent, but what is more important is disease control. So EBRT by conventional techniques with telecouple still serve a sizable proportion of RT needs in LMICs. That is basically takes care of 33% in LMICs like India, and only 7% is in HICs. So with regard to the IAEA update, there has been progress in bridging technological gap observed. So it, as per a publication in 2021, 78%, there has been a 78% increase in number of LINACs in Africa, which is encouraging, but still a lot needs to be done. So with regard to the facility in radiotherapy in India, we, recommended is 2040 teletherapy machines, but we have a shortfall about 67%. Brachytherapy 650, shortfall of 44%. And simulators, there's a recommended is 520, still we have a shortfall of 66%. So that is, this is where we stand currently. So, but there has been another analysis by Dr. Munshi et al., but that he has taken into consideration the recommendation with regard to the West. The figure that he has quoted is quite high. So that may not be achievable in the near future, but whatever the previous presentation that previous slide that I showed, that could be achievable, but with a little bit of difficulty. Similarly, the brachytherapy facility, this is again from Dr. Munshi, about HDR units, only 250 are available. And as I said, we have about a 44% deficit of what is actually needed. So we need to have some simple and practical solutions for these problems. So what is that? That is basically appropriate resource stratification. As Dr. Badwe was telling in the morning, like some situations where we have an electricity problem and other things, maybe it will be difficult to run a LINAC. In these situations, maybe cobalt unit would be a good replacement for a LINAC, and we can still do a lot of things or help out patients a lot with even if the cobalt unit, if that is available, and which is less dependent on, say, the electricity, and also maybe has less of maintenance or QA programs that needs to be done. So, and the other thing is that we need to have cost-effective modifications to existing equipment. That is basically like, suppose you can fit a MLC to a cobalt unit, maybe some degree of conformal radiotherapy can be practiced even with a cobalt unit. And then the other thing is that instead of going for the protracted radiotherapy treatment, we can go in for, say, hypofractionated treatment, which have been found useful in many situations, even breast, and reduced number of fractions can be done. That will basically help widen the reach of radiotherapy. More patients can be treated, and then and considerable saving on patients' indirect expenses. That is, if the patient is staying for a lesser period at the place of treatment, because always the treatment is not available close to home, that will save the expenses with regard to travel and lodging. And this will expand access to radiotherapy. And hypofractionated treatment is economically sustainable. And many of the shorter schedules are deliverable with mid-range LINACs. Instead of going for high-end LINACs, many of these short treatment schedules can be delivered with a mid-range or a low energy or single energy LINAC, which will be less costly compared to the high-end LINACs. So, and then apart from that, because most of the treatments that we have, most of the patients that we have, they present with an advanced stage. Instead of going for the fancy treatment like IMRT, IGRT, maybe sometimes, and because many of them are palliative treatments, maybe instead of going in for high-end techniques, maybe a simple simulation 2D planning or a CT simulation and say conventional treatment, that could help many of our patients. So the other thing is that with regard to the availability, other thing is that we have to consider the accessibility. Availability is one issue for the LMICs, then accessibility. Because as we see in many of our situations, what is happening, most of the radiotherapy facilities, they are concentrated in urban areas, and even within the urban areas, like they are located in one part of the country rather than equally distributed across the country. So one is the geographic distribution of the population, and the direct and indirect cost that has to be taken into account while planning the radiotherapy facilities. In Brazil, like we have 250 units treating about 650 patients per machine. And here 86,000 patients, or over 25% of all Brazilian patients, they have no access to treatment each year. That is because of the distribution discrepancies. Here we have half of all of RT units are located in the southern region, and some of the best developed centers are in the private sector, which is not within the reach of the common man in our setups. And some entire areas, just a few machines to treat thousands of new patients. So apart from availability, one is accessibility. The similar situation we have in India, like we have most of our centers, high-end radiotherapy centers located in either the metropolitan cities like Delhi, Mumbai, Bangalore, Chennai, and even across the country, we have more of these centers available in north, west, and south, whereas the central India and even the eastern part of our country has less number of centers. So there has to be equitable distribution of these centers across the country so that it should be accessible to the patients. Then the other thing that comes into picture is the affordability. The present day radiotherapy is quite costly and it's not within the reach of the common man. And so there has to be some arrangement to make this treatment affordable to patients. And this basically requires some form of cost sharing between patient and the government. So the government has to step in, and maybe they have to take measures that the burden is directly based on establishing radiotherapy clinics, which the government has to take over. They have to take care of the procurement and the maintenance of all essential equipment, operation of the facilities, and paying the staff. And then the patient expenditure could be reduced if instead of the entire thing coming to the patient, the cost part has to be shared by the government. So other is the selection and procurement of the radiotherapy equipment. So that is basically we have to have a choice between cobalt machines and the LINAC, and that basically again depends on the country's radiotherapy experience, the financial and other requirements, and the technical capacity and available workforce that we have. Sometimes the cobalt machines will be easier to operate in our setup where they are not very labor intensive, the treatment, and where there's a dearth of adequate manpower, maybe a cobalt unit would be much better serve our purpose than going in for high-end LINAC, and where we have a dearth of manpower who would be responsible for the QA, daily QAs, and then the plannings and other things. So cobalt units are considered more robust workhorses for developing countries. They are lower cost, easier to operate for treatment, delivery, planning, and maintenance, and heightened security. And other thing is that after the 9/11, there is heightened security concern with regard to the disposal of the sources, and sometimes various licenses are required for the transport and the disposal, and even getting a second source, reloading, that cost is additional cost that could come up. So, and some of the LINAC manufacturers, they are providing incentives like participating in investment at country level through joint ventures. That has been happening in Peru, Turkey, and Vietnam. Many countries in Asia and Latin America and a few in Africa are operating LINACs, though with some maintenance issues. We have LINACs in our places, but sometimes the maintenance and the attendance by the companies for the servicing, so sometimes it's deficient, and sometimes the treatment has to be interrupted because of these failures. And the other good thing that is happening is that some of these manufacturers, they have in the market single engine LINACs, and which has a lower overall cost. Then, as I said, the selection of the equipment, the manufacturer and the equipment, the cobalt machine, as we know that we have to replace the cobalt source every 5 to 6 years. Apart from the initial low cost, but the replacement of these cobalt units, cobalt sources every 5 to 6 years, that could add up to the cost. In that place, if you have the LINAC, might cost a little high, costly at the initial stages, but in the long run, if you see taking into account the replacement of the cobalt source, and then for the machines to run about 15 to 20 years, the cost literally balance out. Then the choice of the manufacturer, that also has to be taken into account, because many of these manufacturers, they are remotely located. The manufacturing base is elsewhere, and whereas the supply is somewhere, that could add to the transportation cost, and then subsequent services that need to be done, the maintenance of the equipment, sometimes it's quite difficult. And for this situation, so what has to be done is that the manufacturer has to make it possible that they have some trained people at the place where their machines are located, so that, and all the local people can be trained with regard to the servicing of the equipment, so that there's less of breakdown and less of interruption of the treatment. So, and other thing that we have to do, to take into consideration that has to be a maintenance contract or a warranty clauses have to be, or a penalty clauses, they have to be included while making a choice of equipment or the manufacturer. And unless, and many times it has been seen that in the with the lack of maintenance, sometimes even if you have the machine, subsequently running it has been difficult, and the machines have been lying idle. So the accessibility, availability, then the selection of the equipment and selection of the manufacturer. Apart from that, what is bugging us is basically the manpower issues in the LMICs. That is workforce that is needed for running these services, radiotherapy services. So as per this table, for a basic radiotherapy center treating less than 1,000 patients a year with 2 megavoltage teletherapy, 1 HDR brachy, 1 conventional and or CT simulator, immobilization devices, shielding devices, 1 TPS, and physical dosimetry, a staffing of around 20 has been recommended by IAEA. That includes at least 4 to 5 radiation oncologists, medical physicists 3 to 4, radiotherapy technologists 7, radiotherapy nurses 3, and a maintenance engineer. So, and this manpower issue is one of the things that is a major problem in NMI sites. So, and especially the staff requirement would also increase in case we are trying to look into special or advanced techniques such as 3D planning or CRT, IMRT, IGRT. So for this, to take care of these things, the manpower issues, it's always good that we should try to develop our manpower system or training system in-house, so that, and that is what is happening in many of the centers, like the TMC centers in India. We, apart from the service component and the education components, we are also running some courses where, like the radiotherapy technology courses or the medical physics courses are running, so that even post-basic diploma in oncologic nursing courses are running, so that at least these manpower issues are sorted out to some extent. Like the radiotherapy technologies we are training, in the OT technologies, like for the surgical oncology, we are having the OT technology courses, then the post-basic diploma in oncologic nursing courses. So that this in-house training is something that we also need to encourage on or try to develop in our places. So as I mentioned in the one of my previous slides, there's an acute shortage of medical physicists and oncologic nursing in our setups. So that this is basically for Africa, Latin America, and Eastern Europe, considering the number of patients that we are treating and the required staffing that is needed. So if we have, if there's a lack of well-trained staff, there would be inappropriate or underutilization of the scarce radiotherapy facilities. So for this, there have been some international programs which have been supported by IAEA and ISRO, that is fellowships for education and training and continuous professional development that are there. Apart from this, we have to have this education and training of oncology professionals. This is an urgent need for that. So new and innovative approaches can be taken up, like use of e-learning and online learning that has to be taken up. And the IAEA expert panel, they have said that the personal requirement be adjusted for LMIC. There has to be increased because of the increased ratio of palliative to radical cases and simpler or shorter treatment. These protocols may reduce duration of professional involvement to each patient. So it's always better that in our setups, we try to take up simple techniques rather than going for the high-end techniques, which is more labor intensive and it's difficult for us to actually execute with the shortage of manpower that we have. So because of the lack of resources and prospect of better pay at in the high income countries, there's an attrition, and many of our trained manpower, they are leaving for greener pastures. And this loss of trained medical professional in RT is an increasing problem for African and parts of Asia. And this actually affects the services that we are able to deliver. So, and what is happening is that with this, what is happening, the small workforce that is remaining, they are overburdened and they have to do multiple tasks. And as a result, maybe the quality of work would also be suffering. And as I said, the manufacturer, with regard to the maintenance of the equipment, the manufacturer has to take upon themselves to train specialist people or local engineers who will be responsible for the servicing of the equipment at their place where they're based. So what is the way forward with all the problems that I have mentioned, all this manpower, accessibility, affordability? So what is the way forward? So what is more important is that first we have to assess what is the estimation of the cancer burden, that is basically to generate ground level evidence of infrastructure needs. Unless we assess our needs, we will not be able to plan for it. So total megavoltage radiotherapy units that are needed by 2035 to be nearly quadrupled from 1,303 to 5,200 in LMICs. So that is what is the need that take into consideration the increase in the cancer load. This would be the requirement, and how we do it, that is a big problem and question mark for us. So to enable access to radiotherapy for cancer patients, existing lacuna and desired goals to be identified and defined clearly. Cancer be delinked from other non-communicable diseases in the LMIC healthcare program, because with the we have been able to take care of the communicable diseases. So now, and they are on the decrease, whereas the cancer burden is increased. We have to delink. We just can't club it with the communicable diseases and plan the healthcare resources of the country. So we have to delink cancer from non-communicable diseases. And it has to be a mandatorily notifiable disease that has to happen in many of the countries. And depending on the local needs, we have to prioritize what is the major chunk of cancer that we are seeing, and we have to prioritize that, and we have to prioritize and then accordingly plan our radiotherapy facilities. And we have to generate proper population-based cancer registry data. And because currently what is happening in many of our countries, we have population-based cancer registry, but they are mostly located in the urban centers, and the data that we get is basically skewed towards the urban population. Like in India, we have just 2 out of 28 PBCs they are located in the rural areas. That doesn't give a data that applies to the entire country. So that has to be taken into consideration. And also, this cancer mortality in LMIC is also underestimated. So many times we just say that any deaths, we just say cardiovascular accident or cardiovascular vascular cause or respiratory cause. We don't actually identify them whether it's because of cancer death or not. That data also has to be generated properly. So because with the government getting involved in the national cancer control programs, what has to be done is that basically we have to use the economies of scale to negotiate buying and maintenance of new equipment. Like it's happening in TMS, because we have so many centers across the country. Suppose we are buying, 5 Linacs or 10 Linacs in one go, we can negotiate better with the companies with regard to the pricing and the after sales service. So this is the same thing the government has to do at their level. Because of the economies of scale, we have to negotiate hard with the manufacturer with regard to the terms and conditions and the pricing of the equipment. And as I said, local solutions for manufacturing radiotherapy equipment and accessories can add to the cost savings. So if we try to develop, say, local manufacture or adapting the equipment to the local needs, instead of going for the high-end equipment, maybe some equipment that could be best suited for our conditions, that could lead to a lot of cost savings. Then collaboration between global and indigenous entities, that is manufacture, installation, operation, and maintenance of radiotherapy infrastructure be incentivized to have sustainable investment. Then innovations in technology focusing on improved efficiency and adaptability. That is less complex single energy linear accelerator could better meet our needs rather than going for the high-end Linacs, which are not only costly, but even difficult to operate with the less number of manpower that we have, and the maintenance and the QAs that will be much more labor intensive compared to the low-end linacs or the single energy lines, which could meet much of our demand. Then developing a PPC model, that is a public private partnership that has to be done. That is to build, operate, and transfer models. That could be that is a good model that is happening in many of the setups in India also. Like the government takes part partially, and then the private companies, they take partially and they share the revenue. That has been a good thing that is happening in many of the centers in India. And then apart from that, the national schemes have to be developed. Like we have had the tertiary care cancer center projects in India that has basically been started initially with the cooperation of WHO, with a lot of inputs from WHO and IAEA. And that has actually helped us develop many of the cancer centers across the country. Then other things that are happening, because as I said, the radiotherapy treatment is quite costly, and many times it's needed that there has to be some subsidy with regard to the treatment for the patients. So we have some state-sponsored health insurance schemes for patients and with cancer, that is like the Ayushman Bharat and the PMJ program that is running. So some health insurance policies should also be available for these patients. And educational exchange programs, that is the mentors could be in the leading countries and the mentees could be in our LMICs, and that could basically help develop the standard of care or the training and teaching, and ultimately it will help the local population with regard to the radiotherapy that is delivered. And other thing is a hub and spoke model. That is basically, instead of having all the centers with all the high-end equipment and techniques, maybe we have a hub that has high-end techniques available, whereas there are peripheral centers where not all patients would be needing IMRT, IGRT. Some basic techniques can treat these patients in the peripheral centers, in the spokes. And then if they need some special SRS, SBRT, if that is needed, maybe they could be sent to the specialist, that is the hub. So the long-term goal should be to strengthen preventive and screening measures, because unless we take care of prevention of disease or screening for early detection, most of our patients will be presenting in an advanced stage, which would be difficult to treat, and most of them would be ultimately given only palliative treatment. So we not only need to reduce the burden of cancer, also catch them early so that we can increase the survivorship. Scaling of therapeutic facilities to improve delivery of quality cancer care. And what has been the role of IAEA? Over past 50 years, IAEA has developed strong technical expertise and acquired experience in working with LMIC to build capacity at national levels. They have used several mechanisms to provide assistance in all relevant aspects, like the needs assessment in many of these centers, the planning, training, econometric analysis, the implementation of many of their programs, then development of radiation protection, safety and security infrastructure. And they have given assistance far from adequate to respond, but these assistants are far from adequate to respond fully to growing demand caused by looming cancer epidemic. Although they have been trying, but then because of this increased number of cases, so sometimes these assistants that they have been inadequate, but still it's a way forward that the IAEA is doing. And this has enabled many countries to gain experience in providing higher quality cancer treatment and care to at least a portion of their patients. In 2004, they have a program, established the program that is basically the Program of Action for Cancer Therapy, that's PACT, that is in collaboration with the World Health Assembly. And PACT has been IAEA's umbrella program for combating cancer and builds upon IAEA's extensive experience in radiation medicine know-how and technology. And this, as I said, it works closely with WHO, and they have set up, IAEA and WHO have set up a joint IAEA joint program on cancer control. As per the joint program, the purpose is to enable LMI member states to improve cancer control and care capabilities by integrating radiotherapy and nuclear medicine investment into a comprehensive NCCP. So these programs, NCCP has been National Cancer Control Program has been running in India, and as a result of that, we have set up many TCCs, tertiary cancer care centers under the National Cancer Control Program. And this has actually over the last few years, a number of centers have come up in areas that were inaccessible or that they didn't have adequate facilities, and still we are working on it. And PACT has launched an open forum called the Advisory Group on Increasing Access to Radiotherapy Technology, that is AGAT. So AGAT has been bringing together radiotherapy manufacturers, regional experts, and international organizations worldwide to find affordable, suitable, and sustainable solutions to address shortfall of our radiotherapy machines in LMICs. They have been also addressing the issues of accessibility, affordability, suitability, and sustainability. We have a unit, but if it's not sustainable, if we have it running for 5 years and then after that it just without maintenance, it runs idle. Sits idle. That doesn't serve our purpose. So it has to be sustainable. So increase the cost effectiveness and feasibility of providing radiotherapy treatment and assist LMIC tackle their cancer burden in a practical way. So that has also support long-term sustainability of radiotherapy units and encourage provision for whole of life support packages from radiotherapy suppliers. Once we are buying an equipment, we have to ensure that it has to run for the lifetime of the equipment. It cannot happen that they sell the equipment and then after 5 years, we are struggling to keep it running. So this in summary shows what has been happening and what is the principle of global access to radiotherapy. So this basically takes place at individual country levels, where we have to have a periodic updated databases so that we can plan our infrastructure. Then we have this estimate the future radiotherapy needs. We have to plan for 10 years from now. We have to plan today so that we can get the funds and we can plan it with regard to what is the cancer burden that is going to be there in after 10 years or 5 years. We have to plan from today itself. Then radiotherapy capacity building, as I said, with regard to the infrastructure, the manpower, that also has to be taken care of. Then radiotherapy networks, that has to be established so that the training and teaching that also can take place in collaboration with the centers, the advanced centers. Then preventive oncology, that is basically to reduce the cancer burden so that the available facilities are not overwhelmed. Then we have to make it affordable radiotherapy, and that has to be taken care by user fees, low user fees, and social security or the government insurance policies. And we have to establish center of excellence, as I said, the hub and spoke models, where we have a few advanced centers and a number of centers which are basic centers that will basically take care of the cancer burden to a greater extent. And then with regard to that, we have the national regulatory bodies for radiation and radiation safety, National Cancer Control Program. Then comes into picture the IAEA, WHO, and the manufacturers. So joint program has to be there by IAEA and WHO. Then the other bodies like Globocon, IASC, they come into picture. Then technical assistance and advice is provided by WHO because they run so many other global action plans. Then training and teaching, that is taken care of by them. And other thing that you can think of is that feasibility of having refurbished Linacs. Suppose what is happening in the Western countries, many times they have new technologies. Some of the equipment that we might be using for 10, 12 years, they use it for 3, 4 years and then they send it, they don't use it. Maybe some of these refurbished units can be put up in our place. That could help us. So these are some of the major selected references that have taken help from in preparation of this presentation. And then thank you very much for your patient listening.
Good afternoon. Okay, so quickly I'll let you know that I have no conflicts to declare. Now, oral cancer is the commonest cancer in India. it is the commonest cause of cancer-related death in Indian men. So oral cancer, since it is a very common cancer, and surgery is the mainstay of the treatment. For oral cancer, the best treatment, if possible, is surgery, followed by, if needed, adjuvant treatment. And in adjuvant treatment, either you can give radiotherapy alone, or you can add chemotherapy to radiotherapy if the prognostic factors are more on the bad side. Now, one of the part of the surgery is neck dissection. So apart from removing the primary tumor with wide margin, you also need to address the neck, that is called neck dissection. And in neck dissection, you take care of any possibility of metastasis or already existing metastasis. Now, when I say possibility of metastasis, because sometimes when we see cancer patients in a very early stage, there radiologically, clinically, there is no metastasis. However, there is a 20 to 30% likelihood that there could be metastasis. Now we know that if there is a node positivity, our clinical oncologist will tell that if node is positive, they would like to give radiotherapy. If node is negative, they might consider, if the depth of invasion is less than 9 millimeter, they may not give radiotherapy. So you can imagine that having positive nodes is such an important thing. And the best way to know the neck node metastasis is neck dissection. And why it is so, I will let you know. So to know the neck metastasis rate, multiple prognostic indicators, risk factor scores have been done, but none are found suitable. So for for management of the neck, in clinically N0 means that you are not able to palpate any neck. You have 4 options. The first option is elective neck dissection. That means when you are doing surgery, at that point, you dissect the node. Second, you observe. Don't do the neck dissection. Observe, put the patient in close follow-up. Whenever the node will come, we will do the neck dissection. Otherwise, we'll continue the observation. Third option is elective neck irradiation. That means I do the surgery for the primary, but for the neck node, I don't do any surgery. I just do neck irradiation by radiotherapy. That is one option. And the last is sentinel node biopsy, something new which has come. Now coming to whether to do a neck dissection or observation. And many of you please understand what a blunder sometimes we do by relying on the retrospective data. And this is one such example. And all of you should understand, science and evidence is not retrospective data, case study, cohorts, or some basic analytical study based on your audit. When we did retrospective analysis of our data, whether to observe the neck or do the neck dissection, we proved and we published, and a lot of people may have based their evidence on that, that observation and neck dissection are same. So actually we published that whether you observe or neck dissection, it is same. And what is very scary, that when you observe the neck without a neck dissection, and if future neck metastasis comes, it comes in a very advanced stage. It does not come at a very early stage, and that is one of the studies. Then this quandary was there, this dilemma was there. So we did a randomized control trial. Now in Tata Hospital, advantage is that you see, we are a country of 1.4 billion people. And we have 1 million new cancers in the country. And in our hospital, we treat 80,000 new patients every year, of which around 10,000 are head and neck cancer patients. Of those 10,000 head and neck cancer patients, 6,000 are oral cancer patients. Now you can imagine that we have such a huge load of cancer patients in our hospital that we can do randomized controlled trial in our own hospital with good sample size without requiring multicentric involvement. So we can conduct the entire randomized control trial with 1,200, 1,700 patients So this was one of the randomized control trial where randomization was done. One arm received the observation and the other arm, they underwent elective neck surgery. What did we do on retrospective study? What was the outcome of our retrospective data? That elective neck dissection and observation, they are same in survival and outcome. But our randomized control trial proved us wrong. And it showed that by doing elective neck surgery, you are improving the survival by 12.5%, and disease-free survival is also improved. So this is what happens. A randomized control trial gives a result which can be completely different from the retrospective study. And that is why please look at the quality of evidence before you embark on adoption of that. The other very sensational part of the study was that we all employ sonography of the neck for assessment. In this study, we found that sonography does no good. That means it's a completely wasteful expenditure, and time and energy is completely wasted when you are using sonography for assessment of the neck metastasis. And this shows that patients who underwent sonography or did not go under sonography, they had this equal survival. Now, if sonography is not working, can I use any other tool? So MRI, CT scan, PET CT scan, and all that, in one line, I can tell you all of them are useless. What is most important is clinical examination. And the second is depth of invasion. If you can palpate the lesion, if you feel that the tumor is thick, that itself mandates go ahead and do the neck dissection. Do not rely on any of those investigations which are there, but they serve no benefit to the patient. Now, why we need to do neck dissection if it is having a clinically non-palpable node? We can just observe it. We did a study and found that even 5 millimeter node can have extracapsular spread, which is not good. So now let us talk about something. Surgeons, they are always like children. They always need new toys to play with. Sometimes robotic surgery, sometimes laparoscopic surgery, then ultrasonographic guided surgeries and all that. So the new toy on the block is the sentinel node biopsy. Now, everybody is talking about the sentinel node biopsy and lots of studies have been done on that. So basically, there are 4 components, as I told you. One, I'll be talking about the elective neck irradiation. Wait and watch. I have told you it is not good. Elective neck dissection is also morbid in the sense that if we do for every patient, it leads to spinal accessory nerve injury. It leads to injury of some nerve. And therefore, can there be something which is between wait and watch and elective neck irradiation, elective neck surgery? That is called sentinel node biopsy. Now, how sentinel node biopsy work? Our pathologist friend will tell that the progression of the lymph node metastasis is stepwise. It starts from the primary tumor, comes to the first echelon node, then second echelon node, then third echelon node. So if you can identify the first echelon node, biopsy it. If it is positive, then only there is a chance of lymph node metastasis on the down the basin. Otherwise, nothing is there. So sentinel node biopsy is one such way of using the scintigraphy and gamma probe, identifying the positive node, which is hot on scintigraphy, removing it and subjecting it for the further processing. But sentinel node biopsy is something that Europeans and the Americans are using to complicate a simple surgery. The simple surgery is 15 minutes of or 30 minutes of neck dissection. When you have finished the primary tumor, just do 30 more minutes of time on the table, OT table, and do the neck dissection. If you do sentinel node biopsy, it's a 7 days procedure, and then you have to recall the patient for surgery. And the cost of the entire sentinel node biopsy will be upward of $10,000. And if you do this just 30 minutes of extra surgery, that's it. One-time surgery, you are out. So the low and middle income country, and all of us should not adopt what West has done, because their entire practice is insurance driven. It is commercial, whereas in most of our country, it is the government funded institution where every pie that you spend, every penny that you spend have to be spent judiciously. And that is why we always say that have your own research, have your own data, and base your research, base your evidence based on your own data and research, not on the Western. Quickly, Dr. Pradhan has already told you that elective neck irradiation is one such possibility. But if you are doing the primary for the primary tumor removal, just do another 30 minutes of excision of the neck nodes. That's it. Why to waste radiotherapy? You already have a waiting list and you want to waste it for something which may not be very, very important. So most important slide, the final slide, conclusion slide, so that you can go for food. So elective neck dissection is good for any oral cancer which is more than 3 millimeter. There is no evidence that sonography and sonography FNAC does. Thickness, depth of invasion is very, very important. Sentinel node biopsy is technically feasible, but it is not implementable. Thank you so much.
Is there any question?
Listen, I'm Dr. Kinkar from Mauritius. This is the ideal setup where you have an intersection. You should be aware that in our setup, unfortunately, we don't have surgical oncologist or head and neck specialist for these type of treatment. So we end up immediately almost and inevitably having patient. And to add cherry on the cake, we have 2 people disability.
Oh.
So is it necessary for all these patients to receive radiotherapy? We try to avoid. Basically, the patients come late. The good thing is because of less smoking is quite high, but because of less of tobacco chewing and pan and everything, we have very few. It's only about 5% of the people and population that would be suffering from an oral cancer.
Yeah.
So at least it's giving us some kind of buffer for these patients. So in this, what would you think or what would you advise in this kind of setup? That's my first question. And the second question would be, what is the role of neck section in this thyroid cancer?
Good question. So there is nothing like a very straight jacket approach for management of cancer. Yesterday also I told the standard of care is one, but each one of us in our OPD does not always follow standard of care, but we have to standardize care according to the patient who is sitting in front of me. Now, if you do not have head and neck surgeons, and if you are having, you yourself are able to look after the patients by giving chemotherapy and radiotherapy combination, I won't argue with that. But tomorrow, I think the day has come when we know the evidence, and here every patient is seen by every oral cancer patient is seen by the radiation oncologist, the medical oncologist, and the surgeon. And our own radiation oncologist will advise surgery and preserve radiotherapy for adjuvant treatment if needed. So I would urge that we should try to do capacity building of the surgical oncology services, because as you rightly said, that there is already a waiting list of patients who truly need radiotherapy, and we should concentrate on that. Similarly, the neck node dissection or something, actually it is very small surgery. It is not very complicated. So with the MOU that we are currently having with the Mauritius Government Tata Memorial Center, we'll be more than happy to train people on that. Having said that, for early oral cancer, T1, T2 cancer with N0, surgery or radiotherapy is almost equal in terms of survival and disease-free survival. The only thing that worries us is that most of these patients have second primary tumor after 1% per year, and it goes on increasing. My worry is that if we have given radiotherapy and tomorrow they come back with the oropharyngeal cancer or piriform cancer or base of tongue cancer, then we are stuck. And then again, we have to rely on the surgeon who is non-existent. because we can't give radiotherapy within 4-5 years, and if you have given the radical dose. Now, thyroid cancer, yes, there is indication that neck dissection should be done for T3 onwards tumor, or those tumors which are aggressive histology, like poorly differentiated tall cell variant, Hertel cell variant, and we should do that.
Thank you very much, Prof. A general surgeon from Malawi. My question is about the level of dissection in clinically negative nodes. In your practice, are you doing a modified radical neck dissection from level 1 to level 5? Or is this dependent on the site of the tumor, whether it's in the lip or the mucosa or the tongue? Are you able to tell it maybe a supra omohyoid dissection? And my second question is on the patient satisfaction. One of my drawback currently to do node dissection is one, back home, I don't have many cases for oral cancers. The prevalence is so low. But for the few patients, I ask myself about the prophylactic outcome, if they'll be satisfied, if they have clinical negative nodes, for me to convince them for neck dissection. Thank you.
So the first question is that if you have decided to do a neck dissection based on the tumor characteristics and all that, for N0 neck, level 1 to level 3, that is the supraomohyoid neck dissection for N0 neck. N plus neck, level 1 to level 5. Now, level 5, again, we can go on debate whether we should do or not, but level 1 to level 5 is the standard that we have to do it. Now, regarding your fear of doing, why don't you extend your visa and spend some time with us? Every day we operate 4 or 5 oral cancer patients. In 1 week, you will be able to see so many of them. And the neck dissection, to be very frank with you, is done by the youngest in the team. So the neck dissection is done by the resident doctors, and the bosses come for the primary tumor. So what I mean to say that it's a very easy procedure. And once you are confident that I will not damage the nerves, vessels, and all that, you will be able to convince the patient.
Thank you, sir.
Yeah.
Thank you.
So thank you, Dr. King. So as you can see, I'll be speaking on prognostic markers and targeted therapy for the management of cervical cancer. Cervical cancer is very much prevalent in our setting, especially the low middle income countries. And if you go by the WHO call, it's a 90% of our girls should be vaccinated by the age of 15 years. 70% of our women should get the high sensitive test at around 35 to 40 years and 45 years. And 90% of these women suffering from cervical cancer or pre-invasive lesion should be treated. Now, the problem is that when you are aiming at managing 30% or 90% of these women with cervical cancer, most of these comes in advanced stage. And most of the advanced stage disease comes from these low middle income countries. Now, the topic, as you can say, the targeted therapy, which fits in the algorithm of the management of cervical cancer, you see, it can be given only in the metastatic setting or in the recurrent setting. So my talk will be basically on those women who have presented to us either in a metastatic setting where you cannot offer them any localized treatment, and also in those patients who have already received the treatment, now they have recurred, and it is in multiple sites. Now we have to give them something systematic. So now if you see the trajectory of the treatment of cervical cancer in the metastatic setting or in the recurrent setting, you can see that until 2013, we could not breach the 12 months survival time, overall survival time. Until 2013, when there was this trial called GOG 240, where we have added bevacizumab along with chemotherapy. That was the time when we could reach the 12 months gap, and we reached 16.8 months. And this led FDA to approve this bevacizumab in cervical cancer in the recurrent or in the metastatic setting. Okay, so let's just now stop here and go back to some of the prognostic markers, because that was also one of the component of my talk. So just to be well, if you can see the prognostic marker, it begins with the surgery. Some patient comes in early stage. Now we have operated. What are the things that will decide that whether this patient, how prognostically this patient will behave? If you see in the surgical part, we know the Sedley's criteria and the Peters criteria. If they fulfill those criteria, Peters criteria basically the 3 Ps. If the margin is positive, if you have a positive node, if you have parametrium positive, then you need to give them adjuvant radiotherapy. And if you get a margin which is less than 3.5 mm tumor-free margin, then also that patient doesn't do good. So these are basically the surgical aspect. Now let us see what are the things that you can find in the blood that you can tell that, well, this or in the tumor that this tumor is not very good. So this is a very good article. If you get a chance, you can go through this article, molecular markers to predict prognosis and treatment response in uterine cervical cancer. Well, there are some things which we can do from our end. Very simple thing, as we all know, that the level of hemoglobin, when you are treating a woman with radiation therapy or whatever it is, we know that if the level of hemoglobin is maintained above 10, those patients do good, compared to the woman whose hemoglobin level is less than 10 when you are treating. Then again, the NLR ratio, it is said that if the neutrophil to lymphocyte ratio is elevated, then those patients doesn't do good. They have a decreased overall survival and PFS. This has been proven by various studies. Then if you see the squamous cell carcinoma antigen, it is said that those women, if you measure this, those women where this squamous cell carcinoma antigen is elevated, this is a poor prognostic factor. It is said that the cutoff value will be around 1.5 nanogram per ml. If it is more than that, this woman will be a bad prognostically. Then again, we know that more than 90% of the cervical cancer will be HPV dependent, but there are some cervical cancer which may not be HPV dependent. So, and we know that the HPV dependent the cervical cancer do good. HPV independent, which are not HPV related, which is very less, but that doesn't do good. It also is correlated with the HPV viral load. If the viral load is less, then these patients have a poor outcome. This is also important. Well, now there are some molecular markers. If you see, if you go and see the VEGF overexpressed cancers, cervical cancers, they are poor prognostically. Then if you find out the PD-L1 expression, it's very important because much of our talk is dependent on this. In PD-L1 expression, if you monitor, if it is overexpressed, then they show impaired OS. But then there are some studies which have shown the opposite thing. So what we can see is that this PD-L1 expression is calculated by the CPS score. Okay, that CPS score, I'll come to that next. So CPS score, if the CPS score is marginally expressed, then these patients do well. If the CPS score is not expressed or is very overexpressed, then this patient may not do very good. So that was the few studies that was what we could find. So these are just the meta-analysis which have shown that the prognostic role of vascular VEGF in cervical cancer, which I have already told you. There are these 14 articles and this meta-analysis reported that finding. So other just tumor microenvironment. If you see the tumor microenvironment, it is seen that those patients where the CCD8 plus, CD4 or CD3 plus is expressed, these are the tumors which do good prognostically. So now I'll come to the therapy, targeted therapy. There are various targeted therapy available in our hand at present. We just discussed some of the important trials or important molecules which are effective in cervical cancer. So why is the need for this targeted therapy in cervical cancer? If you see over the past 3 decades, the median overall survival of patients with stage 4B or recurrent disease has not vastly improved, despite multiple studies with single agent or combination chemotherapy, which I've already shown you. Even with the availability of cisplatin plus paclitaxel and bevacizumab, the overall survival we got is around 16.8 months or 17 months. So there is a need to better understand the genetic and molecular pathogenesis of various subtypes of cervical cancer. And these are some of the targeted therapy that is available with us right now. If you see as per the pathway or the target, it is VEGF or VEGFR, where you can see bevacizumab, the pazopanib, sunitinib, nintedanib, brivianib, and cediranib. Out of that, bevacizumab has proven, FDA has given approval for that. Then we have the PDL1 pathway, where you can see that immune checkpoint inhibitors, mostly the pembrolizumab. Then we have the semiplenib. I'll come to that. Then we have some group where it is HER2/neu expressed group, that is lapatinib. Then we have some tumors which acts on the EGFR pathway, and the molecules which are approved or in trials are in cetuximab, gefitinib, erlotinib. mTOR pathway, we have temsirolimus. Then HDAC pathway, have valproic acid, non-cancer drug. Then PARP inhibitors, olaparib and velaparib. Now, these are the various drugs which are in trial or some approved. Now, what is the rationale behind targeting the VEGF or VEGFR? You see, tumor-related angiogenesis leads to more disorganized vasculature. Whenever there is a tumor, neovascularization happens, all the vasculature are deorganized, and this drug, bevacizumab, it organizes this vasculature so that more chemotherapeutic drug can enter into the molecule, into the tumor, and we get a better response. So this is the basic concept. So now, as I have already told, GOG 240, it was done by Tiwari et al., reported in 2014. Bevacizumab plus chemotherapy. One group will get chemotherapy, basically cisplatin paclitaxel or cisplatin etoposide. Other group got chemotherapy plus bevacizumab. It was given as a second line in metastatic or recurrent unresectable disease, as first line unresectable disease. So what they saw is that the results of this trial, if you can see here, at the end of if you see the overall survival, at the end of you can see they have reported the overall survival with bevacizumab group as 16.8 months versus 13.3 months in the only chemotherapy group, and the PFS was 8.2 months versus 6 months. So the results of this trial led the US FDA approval of bevacizumab in first-line management of advanced cervical cancer in the year 2014. It also came in the NCCN guideline in 2015. So this is one of the important landmark when we have reached the 12 months break. Then just I'll go back and you can see the other drugs, sunitinib and pazopanib. There are some trial around 2010, but they could not show significant results. So as of now, bevacizumab is good with us. Then if you see the trials which is associated with EGFR or HER2/neu in cervical cancer, gefitinib, I've told gefitinib, people have tried with gefitinib, people have tried with erlotinib, cetuximab. All, as you can see, there was minimal activity or no meaningful benefit. Then there was this trial by Monk et al. In 2010 with lapatinib. Lapatinib as a single agent failed to show benefit, but when it was compared with pazopanib, it caused excessive toxicity and recruitment closed prematurely. So we do not find anything. So there are now some few other trials which are combining lapatinib with trastuzumab and all those drugs. So these are going on. So actually, if you see literature, you'll see numerous drugs, numerous trials, phase 1, phase 2, which are being conducted for cervical cancer in the recurrent or metastatic setting. This is another drug with neratinib in patients with HER2 mutant metastatic cervical cancer, findings from the phase 2 basket trial, where they have shown the median PFS of around 7 months and median OS of 16.8 months. So a lot of these drugs will come up in the literature. Now, let's go to the principles of immunotherapy. Now, let us see what immunotherapy has to do with cervical cancer. So if we discuss about immunotherapy, we must take the name of Professor Allison and Takasu Honjo from Japan, who won the Nobel Prize in 2018 for their work on immunotherapy. What is this? Basically, as you all know, it works on the principle that body's immune system has certain regulators, better known as immune checkpoints, which recognize the self-antigen as harmless and foreign antigen as harmful. So cancer cell, however, possesses the ability to outsmart these immune checkpoints and escape the immune system's T-cell defense mechanism. So the development of specific antibody that can revive the suspended immune system of cancer patients and help T-cell carry out the anti-cancer attack is termed as immunotherapy. And as you all know, the hallmark of cancer is evasion of immune surveillance. Immunotherapy works by reactivating those latent host immune responses. So now the immune checkpoint inhibitors PD1 and PD-L1 expression on cervical cancer infiltrating T cells and dendritic T cells respectively has been reported to be associated with high-risk HPV positivity and increasing the CIN grades. There are several scoring criteria for PD-L1 and expression of CPS score, so which I was discussing. Basically, the CPS score is the combined positive score, which is expression defined by total number of stained cells, that is tumor cells, macrophage, and lymphocytes divided by the number of all viable tumor cells. The pathologist will tell you into 100. They'll tell you what is the CPS score of your sample. So now, how does this PD1 therapy in cervical cancer works, or what is the rationale? Actually, if you can see that they have this PD1 ligand in the T cell and PD-L1 in the tumor cell. When the tumor cell and the T cell combines together, and if the PD-1 and PD-L1 is connected, then the T cell becomes inactivated. Whereas if we can put a anti-PD-1 or anti-PD-L1, these receptors are blocked, and then these T cells gets activated and kills the tumor cells. This is just in short. Similarly, in the CTLA checkpoint inhibitors also, the same thing happens. There is the CTLA antibody which comes in and blocks, and this happens. The same thing. So there are 3 single agent anti-PD. Initially, when we started with this targeted therapy, it was basically, as I've told you, it is used in the second line. Basically, you have exhausted all your modalities of treatment. Now, the patient has come, and in the second line setting, initially with single agent pembrolizumab, it was started. Then people have tried with semiplimab and balstilimab. In pembrolizumab, that is basically the Keynote 158 trial, 98 patients they got a overall survival ORR of around 14.3%. The thing is that in the PD-L1 expressed patients, there was the effect, whereas those patients where PD-L1 was not expressed, less than 1, the CPS score, there was no effect. So you know that if you are giving pembrolizumab, that they told that it has to be given only in those patients where the CPS score is more than 1. And in semiplimab trial, 304 patients in each arm, they have given semiplimab, other arm is the chemotherapy. So in those patients, they have shown that ORR of around 16.4%, and it worked when the CPS score is less than 1. So semiplimab works in both the groups. So this is the trial, Empower. That semiplimab trial is the Empower Cervical 1 GOG 3016 and got CX9, an open label multicentric phase 3 trial. So this. So now single agent didn't do much. So what we need now, we wanted some combinations. So PD1 as monotherapy has modest activity we have seen. Now combination is likely to enhance that broaden the anti-tumor activity. So there came the Keynote 826, where pembrolizumab was added with chemotherapy. And there, if you can see, it was a follow-up, the latest follow-up, which came just in the month of, I think, July, 39 months follow-up, and they had a OSS, the overall survival median OSS of around 28.6 months and a PFS of around 16.8 months, quite a good improvement. And so this was again approved by FDA as pembrolizumab used in the first line setting. Patient presented with you. Previously, if you see, pembrolizumab was approved in 2018 for second line metastatic setting, but in 2021, it was approved as a first line in recurrent, in metastatic setting. So, so this is actually my presentation. I have sent one presentation which is not given here. My last presentation. This is the I have corrected my presentation few slides, but the old one is you have projected anyway. So now we don't have time also. So basically this part. So now we know that in cervical cancer, we know bevacizumab we give, then became pembrolizumab, 2018 metastatic setting, 2021 first line setting. So now can immunotherapy move even upfront? Even upfront means whether it can be given in a neoadjuvant setting, concurrent setting, adjuvant setting, or both. So so this is anyway. So basically, so there are some now people are trying to add this pembrolizumab in the neoadjuvant setting also, along with, let's say we give targeted therapy followed by CTRT. Did you manage to get that? My last one. But then telling all these things, the thing is that in a country like ours or yours, thing is that putting the patient on targeted therapy is a very difficult. A majority of the patient cannot afford these treatments. So as the developed country are doing research on finding out, on improving the survival by putting these patients on immunotherapy, and then the other further research they are doing on immunotherapy plus immunotherapy. They're putting 2 immunotherapy. 1 is not enough, putting 2. Then immunotherapy with ADG, the antibody drug conjugate. That is a new thing which has come. Then some vaccines has come, immunotherapy with vaccine combination. So they are trying to do all this research in the development. But in a country like India or in the LMIC, what we need to do is that we need to work on finding out alternative solutions like metronomic therapy, which has a similar activity like the VEGF. So we can work on those metronomic therapy, which gives, anyway. So basically, we need to find out some alternative solutions. So people have tried with metronomic therapy using low dose cyclophosphamide, tamoxifen. So these are various metronomic therapies that we are using. So maybe we can use these in combination with immunotherapy. We can reduce the dose and try in our setting. So that is the way in our country. Otherwise, targeted therapy in LMIC or even in India, hardly there will be patients who will afford targeted therapy unless it is by any insurance company. Otherwise, it is very difficult. So I think in our setting, as I have already told, let us go back and work on those low dose oral chemotherapy along with, even I don't know whether it will be available in our country. In our country, in my setting, I can tell you hardly 10% of the patient really ultimately gets recruited for these treatments. 90% of them cannot afford this targeted therapy. Bevacizumab in our country has come down. The price has come down. The people are affording. But then pembrolizumab will be difficult. So along with all those newer molecules, it is bound to be, because these are all research-oriented drugs, and it's very difficult for countries like India or even Africa. So we need to find out our alternative solutions, that how we can improve the survival of these metastatic cervical cancer or recurrent cervical cancer patients using this. What we are using is that most of the patients, when they just tell that we cannot afford any more thing, then we put them on this not working. Next slide. Next. So it is the same, so no more problem. Let us leave it on there. So basically, what we are doing is that we put them on tamoxifen, 20 to 40 milligram continuously, give them oral cyclophosphamide, 50 milligram, 21 days, 7 days break. That they can continue till disease progression. Most of them, we have given patient even for 2 years, they are continuing. So that is one. Yeah. Then sometimes we give this tamoxifen along with etoposide. 14 days, 7 days gap. So these are some of the alternatives that we have found out. If they can, so we need to do research on this setting using this, plus maybe some low dose of immunotherapy if they can afford. So these are things. So basically, these are things we can do. So if you have any query, sorry, there are a few slides which I could not okay. So this was around the ADC. Same thing, basically, this was this Innova 204 trial, and FDA has given approval for this in recurrent and metastatic setting. This has shown positive result. Next. Then therapeutic vaccine has come. This is also same thing, basically, combination of therapeutic vaccines and immune checkpoint inhibitor is being explored to overcome the immune tolerance. Next. Then T cell therapy, this CAR T cell therapy is very expensive. But then, as Manuel sir was telling, we have found out we are finding a cheaper version on that. Basically, we take the tumor cell and it is treated with interleukin-2, and then it returned back to the patient. The whole cycle takes around 20-21 days, and then we have seen wonderful results, good results with this CAR T cell therapy. Next. So as you can see, in distant and metastatic disease, in as more as for 2023 guideline, if you see the red ones, the addition of bevacizumab to platinum-based chemotherapy is recommended when the risk of significant genitourinary or gastrointestinal toxicities has been carefully assessed and discussed with patients. The addition of pembrolizumab to platinum-based chemotherapy, bevacizumab, is recommended in patients with PD-L1 positive tumor assessed as combined positive score of 1 or more. Patients who progressed after first-line platinum-based chemotherapy should be offered treatment with the anti-PD-L1 agent semiplenib, regardless of PD-L1. I told you, if it is less than 1, then also you can put on them on semiplenib. Next. So this is the update. You can just go back and check with the in the net. Next. So as I've already told, this is the situation. This what do you say? Immunotherapy, targeted therapy. These are like Lamborghini, but our road is not suitable for driving the Lamborghini. Okay, so that is the most important thing. So we need to find out things differently. Okay, next. So we think next. So as you know, India, we reached the moon. We have spent 1/6. We have spent only 75 million to reach the moon. How we did that? We did not send our Chandrayaan-1, that was our vehicle, directly to the moon. We made in fifth attempt. Every time it circles, and we put little bit of an injection of the fuel and go little up. Same thing is the metronomic therapy. We give little dose and try to carry forward the patient. Next. So this is there comes the role of this combination metronomic therapy and checkpoint inhibitors. Okay, we need to go back and think what we can do for our patients. Okay, next. So I've already told, for the developed nation, ADC will come, antibody drug conjugate will come, the immunotherapy will come. They will combine ADC with immunotherapy, with immunotherapy. All these things will go on. But in country like ours, we need to do the drug repurposing. The drugs which are easily available, affordable, and maybe we can mix it up with this low dose immunotherapy in a low dose so that it becomes affordable and can go ahead. Thank you so much.
Thank you. Good afternoon to all of you for a post-lunch session. So my job is to discuss about the oncological emergencies. So if I say oncological emergencies, there are many, but I have to focus on certain important ones to looking at the duration of the talk. So what I've enlisted is few common emergencies that we deal day in and day out in our oncology practice. So these are the 7 oncological emergencies that I'm going to discuss today. So first and the most important is, as all of you know, is febrile neutropenia, which is one of the commonest oncological emergencies that we are going to encounter when we use intensive chemotherapy. So there are certain standard definitions when we say neutropenia. When absolute neutrophil count is less than 1,500, and based on that, you can grade it, whether it is mild, moderate, and severe. So besides that, there are 2 important other terminology that I want to bring to your notice is profound neutropenia. That is when you have an ANC or absolute neutrophil count of less than 100. So that is few settings where you use very high intensive chemotherapy. Why it is important? When you have such low levels of neutrophil count, the risk of infections are pretty high, especially the resistant infections. A second terminology is functional neutropenia. So some patients may have a normal neutrophil count, but still their functionality of neutrophil is hampered because of the underlying disease. So there, even if the neutrophil count is normal, there is the connotation of that is they suffer same kind of complications in terms of fever, infection, everything. So they function. So essentially, this will also be labeled as febrile neutropenia. And typically, it happens in settings where patients received purine analog-based chemotherapy like cladribine, fludarabine, and sometimes in AML patient and leukemias where you have functional neutropenia. So what I will do, so there are certain guidelines how to manage febrile neutropenia. So we have IDSA guideline, we have NCCN guidelines. So these are the important definitions that they use when we say febrile neutropenia based on the ANC count, and these are the organisms that we commonly encounter. So for us in India, it is the gram-negative bacilli, which is the most common bug, and I have enlisted the organisms. It is the E. coli, Klebsiella, which is the predominant ones. And patients who remain neutropenic for more than a week and those who have gut infection, they are prone to develop invasive candidiasis. And patients who are neutropenic for more than 2 weeks, they are prone to develop infections like mold, aspergillus, zygomycetes. So these are the infections, mucor, which are common in patients who are neutropenic for prolonged duration. So all of you know the reason why we should know febrile neutropenia and treat it urgently or emergency, because every hour delay in giving an essential and empiric antibiotic can lead to increasing mortality. So you can see here in the x-axis time to give the first antibiotic dose, and the y-axis is the patients who are surviving in toto. And if you see as every hour delay of giving antibiotic leads to substantial decrement in terms of survival. So time is most important in patients who are febrile neutropenic. So if you see a patient with febrile neutropenia, what should you do in next 15 minutes in your emergency room is these things. So we do a basic laboratory, including a blood culture. And typically what you take here is 2 sets of aerobic blood culture. We don't take anaerobic because we don't see anaerobic organisms in our setting. So we take 2 sets of aerobic blood culture, 10 ml in each, and we give the first dose of antibiotic there itself. And then subsequently we examine the patient and then decide whether you need to image the patient by doing an ultrasound abdomen, by doing a CT scan. So all these things will depend on what user examination finding. And then you look at what was the previous infection or previous antibiotic received. So these all things will help us in guiding for the treatment. So few important points when you examine a patient neutropenia is that patients of neutropenia, they may have very subtle signs of inflammation. Like a patient may not have florid in erythema or florid raise in temperature, pain. So something which will be very subtle. For example, cellulitis, erythema, these things will be maybe absent, because they have very less neutrophil. They may not produce significant inflammatory response. So that's become very important when you examine these patients. You should keep this thing in mind. And sometimes patient can present without fever also. If they are very neutropenic, they can directly present with hypotension or hypothermia as well. So these are important things when you see a febrile neutropenic patient, or you examine the patient, you should be pretty sure that they have low neutrophil count, so they may have less inflammatory response as opposed to an individual with normal count. So what I will show is, recently we have updated our guidelines of febrile neutropenia. So I will give certain slides how we manage. So every hospital should have their own guideline or empiric guideline that they want to give. So for a patient who is febrile neutropenic with the blood culture positivity, the choice of antibiotic is pretty clear. But those who are culture negative, where you're treating them empirically, how do you treat them? So we have divided this based on host factor, disease-related factor, and also the infectional factor. So based on that, what we do typically is that we classify these patients, whether this patient comes into high risk or low risk category. So if a patient is low risk, that is, they don't have any high risk feature based on host factor, disease factor, or comorbidity or focus on infection, because of a limitation of bed, we usually manage this patient on OPD basis. We give single agent antibiotic and monitor them daily. If the patient has any of the high-risk feature that I have listed, then they receive dual antibiotic cover with an cephalosporin, sulbactam, and amikacin and aminoglycoside, because in our setting, the sensitivity to single agent cephalosporin is only 60%. And if we combine an aminoglycoside to that, then the sensitivity of the combination will be almost 80 to 90%. So that is the whole point of combining 2 antibiotic agents as a first line empiric drug. So after 48 hours, we relook at it, we decide what to do. So we have laid down certain guidelines in our setting, and then we relook at it and we see whether these guidelines are followed appropriately as we have done. So after 48 hours, we see if the patients are afebrile, the culture is negative, even if they are neutropenic, we de-escalate and stop antibiotics. But sometimes when patients have persistent fever without any focus, neutropenic, so that is a case-to-case decision where we take to escalate antibiotic based on the clinical situation or clinical need of the patient. Now, coming to the duration, this is important when we decide the duration of antibiotic. It depends on the focus. If the patient has no focus, then we see how was the presentation. If the patient presented with a septic shock-like presentation, then we give at least 7 to 10 days of antibiotics. But if the patient's present with some focus like GI, chest, or positive blood culture, we have defined our durations. So the basic purpose of listing all this is that you should have your own guidelines. We should have your own way how you manage febrile neutropenia empirically. And then this is not the end of it. We have to relook at it. We have to do monthly audits or monthly stewardship program to look at whether things are going in the right direction or not. Now, next common emergency is malignant spinal cord compression. Now, among all hospitalized patients of cord compression, if you see, majority, almost 60% will have either lung, prostate, or breast cancer. Lymphomas and myelomas will constitute 10% of the entire lot of cord compression, but they are not typically included in those studies of spinal cord compression. If you see the studies done in spinal cord compression in terms of role of radiation, surgery, or steroids, they will not include myelomas and lymphomas because they are usually chemoresponsive, and most of the time they do respond to chemotherapy. They may not need radiation or surgery. So when it comes to malignant cord compression, we usually typically mean the solid tumors. Now, importantly, the presentation is very classic. They have pain, which is constant dullacking. Typically, it is worse in the night because it is a malignant pain on early morning. And whenever there is an increased pressure like coughing or sneezing, the pain gets aggravated. And typically when the pain aggravated when they lie down. So the investigation of choice is MRI spine, which has a good sensitivity and specificity of more than 90%. Sometimes you end up doing MRI whole spine because almost 30% may have multiple vertebral involvement. So you have to look at, or you have to screen the spine in toto. CT scan is not the investigation of choice at the first hand, but when MRI is contraindicated, you can do CT scan. It has low sensitivity. PET scan has very poor resolution for MRI. So a negative study by PET do not rule out the possibility of cord compression. Now, important is steroid. All of you know that steroid is the treatment of choice for cord compression. The issue is what is the dose and how long to give. So there are a couple of studies to address this question. So first is there is a randomized study done comparing 96 milligram of dexamethasone versus nothing along with RT. And if you see that randomized study, there is a higher rate of ambulation at 6 and 9 months with steroid. So if you use steroid along with RT, pretty hefty dose, 96 milligram, as opposed to no steroid, you get better neurological recovery at 3 months. But the problem with such high dose of steroid is toxicities in terms of infections and neurological complications. So then there is a second study which was done to address this issue, and they compared a 96 versus 16 milligram for 3 days and then taper. And there was no difference in neurological outcome at 1 month with a less toxicity. So that's how 16 milligram became the de facto standard of care of steroid dose. So what we typically do is we give a bolus of 10 milligram and then give 8 milligram 12-hourly steroid, and then that is tapered over 2 weeks as tolerated. Usually we complete the radiation and then taper the steroid gradually. Now, coming to radiation, the dose of radiation used is 8 Gray single fraction or 20 Gray 5 fraction. So where 8 Gray and where 20 Gray depends on whether there is any soft tissue or not. Sometimes when there is soft tissue along with the vertebral involvement, we give little higher dose of radiation, or maybe a little prolonged. But if it is predominantly vertebral body involvement, single fraction is the what we practice here. So now where do you place surgery? So we have discussed about radiation, we have discussed about steroid. So where do you involve your surgical colleague in the management of cord compression? So whenever there is an instability of the spine, so there is a role of spine surgeon. The basic purpose is to decompression and stabilization or fusion of the vertebral bodies. So there is interesting score called spine instability score. So you can use, it's pretty easy to do. If you have an MRI of the patient and you have symptomatology that you are assessing, you can exactly get this score. And if there is pretty much spine instability, then surgery is something which is needed. And if there is low risk, the score is low, only RT is fine. When it is in between, you have to monitor the patient closely. So there is a randomized study done whether we can do surgery in all your patients along with radiation. That is RCT done surgery with RT versus RT alone. And they found that more patients became ambulatory if you do surgery early in patients of cord compression. But there were a couple of criticism in that study because the study took 10 years to accrue, and most of these patients had instability to start with, which could have favored the surgery arm. So the bottleneck is that if you have instability of the spine, that you can judge by doing a scan, and also or the symptom of the patient. Typically when there is pain, when the patient moves around, when there is a pain due to increased motility, it gives an indirect indication that probably there is some instability in the spine. That's why the pain is getting aggravated because of little bit of movement. So these are small indicator which can help you that there's some bit of spine instability, and you should consult a surgical colleague at that time. So that's how we have to manage cord compression. Now coming to tumor lysis. Now, tumor lysis, most of you know tumor lysis is because when you have a rapidly proliferating tumor and there is rapid tumor lysis, that leads to release of cytokine, that leads to release of electrolytes, and it can cause kidney damage, arrhythmias, and cardiac arrest as well. So typically, this is the pathophysiology that I have shown you here. Tumor cells, when they receive chemotherapy or cytotoxic drugs, they release uric acid, and these uric acids gets deposited in the kidneys, and that can cause acute kidney injury. And increased lysis of the tumor cell can lead to increased potassium levels, low calcium level, and high phosphorus level. So this is how a tumor lysis will present to you. Typically seen in two situations in oncology. When it's rapidly growing tumor, like an acute myeloid leukemia or acute lymphoblastic leukemia, where the WBC counts are pretty high. Second is in situations we have bulky disease, that means large bulky nodes where you give chemotherapy, like in patients of lymphoma, germ cell tumor, where there is probability of rapid downsizing of tumor. You can have tumor lysis when you give even radiation, embolization, radiofrequency ablation, and steroid as well. So there is a definition called Cairo-Bishop definition, which takes into consideration about the values of uric acid, potassium, and phosphorus and calcium to give you a definition of when to call tumor lysis. So you can see this definition here. So you have an abnormality in any two of the following can define called as something called as laboratory tumor lysis. So there is a laboratory tumor lysis syndrome and there is a clinical tumor lysis syndrome. When we say laboratory tumor lysis syndrome, we should have two lab values abnormal out of the four. You can see potassium, uric acid, phosphorus, and calcium. Any two abnormality will lead to laboratory tumor lysis. Apart from that, if you have one more clinical parameter, like either high creatinine, cardiac arrhythmia, or seizures, will lead to a clinical tumor lysis syndrome. So this is how you define your tumor lysis. And as I was alluding, there are four important abnormalities that occur in tumor lysis: is hyperkalemia, hyperuricemia, hyperphosphatemia, and hypocalcemia. And these are the clinical feature that you see in the patient. If you have an hyperkalemia, you can have EKG changes, you can have myalgia and muscle weakness. Hyperuricemia, I told you, it can cause renal failure. Hyperphosphatemia is very notorious in tumor lysis. It is a very resistant abnormality to treat. Sometimes patient may require dialysis as well. So it can cause renal failure and secondary hypocalcemia. Hypocalcemia can cause muscle spasm, tetany, altered mental status, and also seizure. So you have symptoms in each abnormalities. So how do you treat? So the treatment of tumor lysis is pretty standard. So the first and important and most important treatment is IV hydration. And that is the terminology called aggressive IV hydration. So what do you mean by aggressive IV hydration? So you have to ensure that the urine output of the patient has to be at least 2 ml per kg per hour, except they are oliguric or congestive heart failure, where you may not go to that high level of urine output. But whenever the patient had good cardiac function, their young age, no oliguria, we should target at least 2 ml per kg per hour output, and that is called aggressive hydration. You can use loop diuretics if they are volume sufficient, right? Now, second important thing is you have to reduce the uric acid levels, because that is the more important culprit in mediating kidney injury. So first is urine alkalinization. So this was something which was historic. It is no longer recommended because it has been found that if you alkalinize the urine, it can precipitate calcium phosphate, and that can cause more injury. So no more urine alkalinization for tumor lysis. Now there are two important drugs which are used called allopurinol and febuxostat for decreasing the level of uric acid. So we prefer febuxostat in India because it is cheaper and it is a good alternative without any dose modification needed in renal or hepatic dysfunction. Now, the third important drug is rasburicase. So rasburicase, so what is the difference between the second drugs and third drug? So allopurinol febuxostat will prevent further development of uric acid, but rasburicase will lyse or will kind of degrade the already formed uric acid. So that is important in situations when you have very high level of uric acid and AKI. So now the dose that is recommended is 0.2 milligram per kilo for 5 days, which is a very, very costly affair in India as well. So we have a study done in this setting. Can we use slow dose single vial rasburicase and get the result done? So this is a single arm phase 2 study done in Tata Memorial Center. So the rasburicase vial comes in 1.5 milligram vial. So what we did is that we gave only single dose of 1 vial and we looked at 48-hour normalization of uric acid level. So you can see median value of uric acid was 11 in our study, and 12% patient, almost 1/10 of the patient had acute kidney injury at baseline. And what we found was that 50% patients had normalization of uric acid, and almost 80% of them had normalization by 5 days. 20 out of 60, that is 1/3 patient required additional doses of rasburicase. Only 3 patients out of 60 underwent dialysis. So you can see that using a very, very low dose of uric acid, rasburicase, a single vial will save a lot of money and it can give good result in tumor lysis, which is very, very important in low medium income countries. Now, coming to 3 important other abnormalities which we deal is hyperkalemia, hyperphosphatemia, and last is decision on hemodialysis. So hyperkalemia, most of you know how to manage. You need to give insulin, hypertonic dextrose, albuterol, sodium bicarbonate, loop diuretics, and dialysis. Now, hyperphosphatemia is sometimes difficult to treat. So treating hyperphosphatemia will automatically correct your hypocalcemia. So that means you do not need to give calcium separately. If you correct your hyperphosphatemia, calcium gets corrected. The only situation where you need to give calcium is when they're symptomatic in terms of tetany or, imminent seizures. But the only situation where we will look for dialysis in tumor lysis when there is severe hyperkalemia and hyperphosphatemia, oliguria. So whenever you are doing an intermittent hemodialysis, you should always look for something called as rebound hyperkalemia that can occur just after the hemodialysis. So that's why sometimes if you can do a continuous CRRT kind of dialysis, that is preferred over doing an intermittent hemodialysis. So if you're dialyzing intermittently in these patients because of so indications, you have to look for, or you have to monitor your parameters quickly after the dialysis, because there will be a situation, there will be a rebound of increasing potassium and uric acid levels. Third important thing is cancer-associated thrombosis. So the important thrombosis at one side, that is embolism, is a medical emergency in oncology, and we see it often. So when you classify pulmonary embolism, there are multiple ways how you can classify, based on the origin, based on the location, and based on the severity. So why it is important? The first thing is, say, let's based on origin. So you can have an embolic event, so something we have a DVT and there is a clot migrating to the lung, and that is an embolic phenomenon. You can have in situ thrombosis as well because of some local inflammation in the lung. Best example is COVID-19 thrombosis. You can have small microthrombi throughout the lung. So that is an in situ process. Now, coming to based on location, there is something called saddle thrombus. Okay, so saddle thrombus is typically described for thrombus when you have at the bifurcation of the pulmonary artery to right and left, major pulmonary arteries. Now, second is sometimes the saddle thrombus is loosely defined. You have to ask your radiologist that whether you are talking about the saddle thrombus on the bifurcation of right and left pulmonary artery, because usually saddle thrombus is associated with hypotension and can lead to 5 to 6% of complication or death. Now, lobar thrombosis is something is one of the 6 lobar arteries. If there is a thrombus, it is called lobar thrombosis. And subsegmental is when you have one of those 17 small branches, we have subsegmental. So you can have based on the location. So important thing is that whether it is based on the site or on the location, it usually do not matter in terms of treatment. The treatment is important. What is the severity? So severity is most important. So how it is important, whether it is a massive, submassive, low risk, that will decide what treatment to offer to the patient. So that's why to remember what is important for classification is what is the severity. So whether it is a massive one, submassive one, low risk. Whenever you talk about massive pulmonary embolism, there is hypotension, low systolic blood pressure. If the blood pressure is fine, then it is not massive. Then there is something called submassive. How do you define that? Either the patient should have a strain in the right ventricle that you do 2D ecography, or they should have an elevated markers, cardiac markers. So either of the two will tell is submassive. None of this is low risk. So why it is important to classify? Because your prognosis, treatment, everything will change at the day 1. Okay, so presentation, all of you know, it is chest pain, shortness of breath. ECG, you can see tachycardia and pericardial leads, T-wave inversions. Remember, 25% cases ECG can be normal. So you have multiple criteria whether to evaluate a patient for pulmonary embolism by doing a CT pulmonary angiography. You have criteria called as Wales Perk criteria used in settings to screen the patient, which patient should merit the CT scan. But these are criteria designed when you have patient which is a low risk for pulmonary embolism, negative D dimer, you can decide whether to go for or not. But most of the time, if the suspicion is pretty high, we usually do a CT pulmonary angiography. So if you're managing a pulmonary embolism, you should have a bedside 2D echo, which is very, very important. Specifically in ICU setting, that helps a lot. And it tells you that what is the probability of this patient going into massive thrombosis, like developing hypotension or right heart failure. So there are three important things that people look at 2D echo is that the diameter of right ventricle. Usually the ventricle, right and left ventricle is 1:1 is the dimension. But if the right ventricle is more, then that can lead to right ventricular dilatation. Decreased TAPSE, that is something called as tricuspid annular plane systolic excursion. And third is McConnell sign. So these important signs are important when you are dealing with a patient with PE. So typically, as I said, CTPA is not recommended in low risk patients. So what will you do if you have a patient who have high creatinine and you want to do a CT pulmonary angiography, which is contraindicated? You end up getting a ventilation perfusion scan, which is not available in many centers, but that is something you should know. So how do you manage? So as I said that massive pulmonary embolism is when there is hypotension. So there is a decrease in the preload of the right heart. So then fluid resuscitation is most important. So if you give a fluid bolus, it will increase the preload and that will improve the blood pressures, because massive meaning hypotension. So that means first component of that is decreasing preload. So giving fluid will increase the blood pressures. But remember, there is something called PE death spiral. So if you give more fluid, that can compromise the left ventricular diastolic volume, because it will push the ventricle, it will push the septum towards the left ventricle, and that will decrease the left ventricular filling. So you have to remember that you can't give fluid beyond certain extent. You have to monitor the fluid status of the patient very meticulously. Systemic thrombolysis should be attempted. There is something called as half dose protocol. 100 milligram of RTPA is something which is recommended. You can use 50 milligram and see, especially in situations where you have high risk of bleeding. There is something called as catheter directed thrombolysis, where you cannot thrombolize. You cannot give systemic thrombolysis. You can use a catheter and then thrombolize a clot then and there. So there are certain recommendations how to proceed for it. But remember, systemic thrombolysis is always preferred over a catheter guided thrombolysis, unlike in certain situations where you are dealing with a patient with very, very low platelet count and low, very high INR, you can do that. So this is a recent update by ESMO group in 2023, published a month back. They have updated the guidelines and recommendations for thromboembolism. You can look at that. So now we have something called as direct oral anticoagulation, that is DOACs, so which are the newer anticoagulants which are available in generic form in India. So now they have come into the standard recommendation in oncology. So if you see, the standard recommendation of using anticoagulation is the low molecular weight heparin and the unfractionated heparin. But the data of using DOACs in oncology was limited. But lately, in last couple of years, you have multiple studies which address this issue. And now, except from GI malignancies, like CA stomach, esophagus, or CA colon, where the risk of bleeding is high, if you use a DOAC, pretty much DOACs has replaced LMWH or low molecular heparin in many settings. So you can start with an acute phase where you give low molecular heparin and then gradually shift the patient to a oral form of anticoagulation. And typically in oncology, at least 6 months of anticoagulation is something which is recommended. There can be an extension beyond 6 months based on the case-to-case scenario. Now, there is an issue that comes up, is that how to manage thrombosis or a pulmonary embolism or a severe thromboembolism in a setting of thrombocytopenia, because that is something which we deal and see in patients with hematolymphoid malignancies, where you deal with thrombocytopenia at the same time there is a thrombosis also. So what typically happens is that you have to gauge that what is the risk of a thrombosis progression. So if you have a dealing with a proximal thrombosis and proximal pulmonary embolism in a major vessel, and or a history of recurrent thrombosis, then you have to give anticoagulation even if there is thrombocytopenia. You have to maintain the platelet count of more than 50,000. If the platelet count is less than 50,000, but still there is risk of thrombus formation. Then in that case, you have to give platelet transfusion and then maintain platelet count above 50,000 and then give thrombot and then therapeutic anticoagulation, because that is something which can save the patients, can prevent the progression of thrombosis. Especially this is applicable when they have pulmonary embolism or cortical venous thrombosis in the brain. Now, there is another important complication is Superior-Vanakava syndrome, or this is a very important oncological emergency where almost so 90% of the cases are due to malignancy. You can have smaller 15% cases, which are mostly because of lymphoma. Predominantly, it is because of solid tumors. Now, something interesting is that whether it is an urgency or emergency. So what is the difference? So emergency is something which you need to act urgently. Urgency is something which you can evaluate and have some time before you act. Think about hypertensive emergency or urgency. So typically it was found that you need to act ASAP, as soon as possible in Superior-Vanakava syndrome. But lately it is found that if you have Superior-Vanakava syndrome, specifically for patients who present little early, you have time to evaluate. So evaluate meaning to understand what is the cause and what is the biology or what is the pathology of the disease. So you have time to do a biopsy and find out what is the histopathology. So now symptoms in Superior-Vanakava syndrome depends on the rapidity of progression. So you may have a situation with a very big mediastinal mass, but the patient is still not having Superior-Vanakava obstruction symptoms. But you may have a situation where there is a smaller mass, but they will have symptoms. So why this difference? Because it depends on how fast the mass has grown over time. If the mass has grown over time very, very slowly, then there are chances of developing collaterals around it and it supplies blood. So that's how the body is compensated. But when the mass has grown rapidly, typically in Burkitt lymphoma or something in a mediastinal blastic lymphoma, you have less time. So there is less chances of collateral. The patient becomes symptomatic faster. Now, most common symptoms as I said, it is the dyspnea on exertion. Because of compression, there will be headaches. Typically, the headaches are more when they lie flat on the when bend down, because while bending down, there will be compression of the major vessels and they will have headache. Now, there will be swelling in the face, neck region, and typically they are worse in the morning. The typical symptom that you see in early Superior-Vanakava syndrome is facial puffiness early morning. And as the day by, the swelling goes down because overnight they have slept flat. So that's why there is more accumulation of blood supply to the brain and towards the upper part of our body. And that causes facial swelling more in the early morning. So you have grading of Superior-Vanakava syndrome. I can see I have enlisted the grading grade 0, 1, 2, 3, 4. So how do you use this grading? So if you see a patient with grade 1, 2, 3 with symptoms, you have time to evaluate doing a biopsy and look at what is the biopsy. So if it is a lymphoma, chemotherapy in lymphoma is very, very effective, and you can use chemotherapy to relieve the symptom. If you get a solid tumor, say example lung cancer, thymoma, there also you have their chemo-responsive tumor. So if you get a chemo-responsive disease in a biopsy, you should start the treatment as soon as possible, and that will relieve the Superior-Vanakava syndrome. If you are dealing with a situation where patient presents with grade 4 Superior-Vanakava obstruction, where you have no time to evaluate like an emergency, in that situation, you can think about giving steroids, radiation, and stenting is something which is done, but endovascular stenting, where you have to stent the Vanakava vessels, and that can relieve the symptom. But that is something which is seen very rarely. Now, next important emergency is hyperleukocytosis. So what happens when you have a WBC count of, say, in lakh, 50,000, 1 lakh, 2 lakh? You might have seen in our acute leukemias when the WBC count goes beyond 1 lakh to 2 lakh also. So, and there are two other important complications that are usually associated with this hyperleukocytosis is tumor lysis, which comes as a as a add-on problem, and also concomitant DIC. So you have to deal with multiple complications at the same time when you deal with hyperleukocytosis. Typically, the symptoms pertain to the site of involvement. If there is more accumulation of vessels or blood cells in the lung, it will cause congestion in the lung, cause breathing difficulties, cough, hypoxia, diffuse alveolar hemorrhage. If there is more accumulation of cells in the CNS, in the brain, you can cause confusion, altermentation, and neurological deficit. Similarly, in the eye, ear, so it can have symptoms based on which organ is affected more. Okay, sorry. So what do we do in our setting is that we send a manual differential count, that is peripheral smear examination, and we see what is it, either whether it is an blast cell or you're looking at a mature B cell. If you're looking at a blast cell, that is an acute leukemia, an immature cell, then you look for what is the MPO, that is myeloperoxidase. If they're myeloperoxidase positive, likely we are dealing with an acute myelogenous leukemia. So what we typically do is give cytarabine boluses, we give hydroxyurea, and sometimes you do leukapheresis. If it is negative for myeloperoxidase, then it can be an acute lymphoblastic leukemia, where we give 1 dose of L-aspergillase, that is 10,000 international units. So why we use L-aspergillase in our setting, that we have found it that if you use L-aspergillase, the risk of tumor lysis is less as opposed to using steroid prephase, because L-aspergillase act gradually and there is a relative gradual decline that we see in WBC count. That is the reason probably there is less probability of tumor lysis, and we are pretty sure and it is pretty useful in our setting. So if you see mature cells in the peripheral blood, then we look for whether they are myeloid or lymphoid. If it is myeloid, that is likely a CML, which can cause symptoms of hyperleukocytosis. There we do leukapheresis as our first option, and then you use hydroxyurea. If it is lymphoid cells, then it can be something chronic lymphoproliferative disorder like mantle cell lymphoma, CLL, where the role of leukapheresis is important, and as well as to start the treatment as soon as possible. Now coming to cardiac pericardial effusion. So this is something which is not very common, but you see it sometimes, and malignant pericardial effusion occurs in almost 10% of all solid tumors. And remember, there is a difference between, the difference between pericardial effusion and tamponade. So pericardial effusion is a radiological diagnosis. You do a CT scan, you do an echo, you do an X-ray and make a diagnosis. But tamponade is a physiology. Okay, so we have to decide whether the patient is on tamponade based on the clinical examination and certain echo findings. So tamponade is a physiology, and pericardial effusion is a radiological diagnosis. So your symptom and your clinical examination and certain certain investigation will tell you that whether patient is tamponade or not. Why it is important to know or differentiate these two is that you have to do something urgently. So remember, pericardial effusion is not an emergency, but tamponade is a medical emergency or oncological emergency. So when you have symptoms of pericardial tamponade, you will have palpitation, orthopnea, which is typically not seen much when they have only pericardial effusion. And clinically, you will find muffled heart sound. There is something called backstride. Most of you will be knowing it. What is backstride? When you have muffled heart sound, hypotension, and distended neck veins, it is called backstride. It is seen only in very few patients, but mostly you will find muffled heart sound and distended neck veins commonly. So this is important. Sometimes when you have pericardial effusion, you also have pleural effusion. Both comes together sometime, and you have to differentiate whether the patient is breathless because of a massive effusion or a massive pericardial effusion or a pericardial tamponade. A 2D echo in that setting will be very, very useful to differentiate and to see whether the patient is pericardial tamponade or not. So if you see this 2D echo, as you can see, is that there is a collapse of the right atrium when the echo was taken, on the screen was taken during early ventricular diastole, and that is a sign that the patient is in tamponade. And that ECG is very, very specific. This is one setting where ECG is very, very specific to give you an answer that the patient is in tamponade or not. So 3 findings are most important, and they go hand in hand, is that low voltages, electrical alterance, and sinus tachycardia. If you get these 3 things in the ECG, rest assured, this is almost 100% chances that this patient is in tamponade. Okay, so these are important investigations that will help you. And pulses paradox is something which is very, very sensitive sign for diagnosing pericardial tamponade. Okay. So now to conclude, I have discussed almost 6 to 7 different types of oncological emergencies. But as I said, that first thing you have to understand is that whether it is an emergency or urgency, because in oncology, you have to treat the emergency, but at the same time, you should have a plan what to do if the patient comes out of that, and you have to treat the patient as well. So specifically in lymphomas and leukemias, where you end up giving something and then you don't have a diagnosis after that. So that you have to keep in mind, that whether you have time to investigate or you have to treat the symptoms as soon as possible. Typically in situations like supravenous cava obstruction, cord compression, where patient is coming with lower limb weakness. So these are the situations where you have to deal and you have to decide how much time you have to spare for doing an investigation and then treatment. Now, certain emergencies can be the presenting complaint of the patient of the cancer itself, and where the diagnosis becomes more important. And for countries like us, and for every center, you should have some degree of short algorithms for all the emergencies. They have enlisted common ones for your emergency physician, that what are the steps that they need to look at. So for every emergencies in next 15 to 30 minutes, what are the things that you want your emergency physician to do before an oncologist arrive at that place. So this is very important when you deal with emergencies in centers which are high volume, and that will be very, very useful. So with that, I conclude. Thank you, and I'm happy to take any questions. Thank you so much.
All right. Thank you very much for that presentation. I assume these were medical emergencies. I think sometimes you do have some surgical emergencies as well, such as obstruction. But all the same, I think it was an excellent presentation. My question is on febrile neutropenia. You did mention the fact that it's time sensitive, and it's quite important to count the number of hours because your mortality increases with that. Just looking at the fact that you have two elements, that's a fever, and the fact that you have a low level of white count, especially the neutrophils. Are there any particular subset of patients that you're going to be particularly watching out for, knowing that you don't usually take dosages of your white count, or maybe you're taking the temperature, it might not be ever so often, and given the fact that you're actually counting the number of hours. So do you have a particular subset of patients who you would be monitoring closely to make sure that you don't have that? The second question would be, is there any type of chemotherapy agent that is much more susceptible to give you that kind of complication? So just to know how in practice you're able to monitor these patients so that you'll be able to actually give them the treatment they need at the right time.
Yeah. So very, very important question. So what you wanted to know is, if I can understand, is that the time to give the first antibiotic dose from the start of fever is important, but there are certain situations and certain chemotherapies where this becomes paramount importance. Is something, for example, if I give an example like anthracyclines, okay. So neutropenia can be caused by many drugs, right? And there are chemotherapy drugs, there are some targeted treatment also that can cause neutropenia. But if a drug is causing neutropenia and at the same time it is causing mucositis, for example, methotrexate, daunorubicin, doxorubicin, where you have a neutropenia and you have a mucositis going on simultaneously. So what happens is that whenever there is a breach in the mucosal barrier, you have more chances of infection, and the patient is already neutropenic. So that becomes a double whammy. So these are the patients where my R counting starts very, very early. But there are certain situations where even if the patient is neutropenic, but they may not be that, that had a higher risk to develop an infection. And that typically happen in solid tumors. We have drugs, something called a CDK4 inhibitor, which causes neutropenia, but they don't develop febrile neutropenia. So neutropenia and febrile neutropenia is not something which are, it also depends on what disease you have and what other side effect apart from neutropenia the drug cause, and that increases the risk substantially.
Thank you for this excellent presentation. Dr. Swan, clinical oncologist from Mauritius. My question is regarding SVC syndrome.
Yeah.
So we have cases coming with SVC syndrome, but we don't have the diagnosis. So patients are started on medical treatment, steroids and prophylactic Lovenox and all, and they also go for emergency radiotherapy. My question is, do you have any recommendations regarding radiotherapy and the time we take to get a biopsy? Because in these cases, most of the time we need a CT-guided biopsy. And this is not readily available as a procedure. We have a lack in interventional radiologists. So to get a CT-guided biopsy takes time.
Yes.
So do you have any recommendations regarding timing of radiotherapy, CT and
biopsy?
And biopsy. So once we start the radiotherapy, eventually we will have a response and all.
Yeah.
So anything to
I mean, see, this is so so this is not that no, we also face this kind of problem. This is not unusual. So, but as I have shown in my lecture that most of the Supravanakawa syndrome will not be grade 4, grade 5, right? You will have some kind degree of time to evaluate these patients and get a biopsy first. So now what to do if you are landing up in a situation where it is grade 4, grade 5, the patient is hypoxic, we have to give something before you do investigate. So what we do is that as soon as the patient is better, you take the biopsy. Now, typically in lymphomas, it is difficult because lymphomas melts faster as opposed to solid tumors. So there you get difficulty in getting the tissue. But what typically we do is that if you are already given radiation and you want to do a biopsy, then we repeat a PET quickly and see is there any other FDG avid area. Yeah. So in that case, what I can suggest you is that do the biopsy, and because there is no time. The more you delay, because radiation, unlike chemotherapy, the more delay you do, the more chances that you'll get nothing, right? Chemotherapy you can still have, if you wait and get a time window and wait for the tumor to regrow and then do the biopsy. But what typically we do is, what I will suggest is that you do the biopsy as soon as possible, and specifically when you're given radiation, you have to do biopsy early.
All right, thank you. I just want to follow up on the question he asked.
Yes.
With reference to the febrile neutropenia.
Yes.
And he asked specifically about drugs that could cause it. Can you preempt and maybe give prophylaxis like colony stimulating drug ahead of time so that you don't wait for this emergency to occur?
Yeah.
If it's a high probability that a certain drug will cause that. That's the first question I will ask. Then the next one is, what dose of the hydroxyurea will you recommend in case of hypoliposis? Yeah.
So coming to the GCSF thing, so we use GCSF in patients where the risk of developing febrile neutropenia is more than 20% as a prophylaxis. That means if 1 out of 5 patients is going to develop a febrile neutropenia with this chemotherapy regimen, then I have to use a prophylactic GCSF. Now, what is the reason behind it is that there was a study done to address this issue that if you give prophylactic GCSF, logically speaking, it should not cause neutropenia, and there is chances that the patient may not develop infection, and that can improve the survival as well. But the study didn't show any survival benefit if you use prophylaxis. So what it did show though is if you use prophylactic GCSF in patients who have more chances of developing neutropenia, you reduce the duration of hospitalization. That is something which is important for us and for you as well, where you are suffering or struggling with admissions, and that is something which you can do. Now, if the patient has already developed neutropenia, you have given chemotherapy, and you want to now give GCSF because their count is low, that may not help every time, because that is something which is like a treatment, right? So that situation is not useful and you don't use it often. So as I said, we use prophylaxis only in regimens where the risk of neutropenia is more than 20%. Now, coming to dose of hydroxyurea, the recommendation starts from 500 milligram to even 3 gram per day. So the maximum you go up to 3 gram per day, and it depends on what is the count and what is the response. Now, typically you should remember is that when you start hydroxyurea today, you expect the response after 3 to 4 days. So the median onset of action is 4 days. That means you can't see a response tomorrow, right? And you start increasing the dose because the patient is not responding. So as it takes time, so we have to have patience and wait for that time, right? So if the patient is not responding, there is a count is high, you have to find an alternative rather than increasing the dose of hydroxyurea, because it takes time to act. So the standard dose, what we start is 500 milligram thrice a day, and we increase to 1 gram twice a day, and then 1 gram thrice a day. So that's how we increase in the gradual fashion based on the response. But as I said, that the response you have to see after a time. You can't see response daily. If you need urgent reduction in the WBC count, the best option is leukodepletion. The second is you can give chemotherapy based on the type of blood count. If it is lymphocytes or lymphoblasts on the morphology, you give L-asparagine, as I have discussed. and you can give one sort of aspergillus and that will take care. But if it is myeloid, that is myeloblast, like myeloid leukemia, cytarabine is something which we find it very useful. You can use cytarabine.
So my question is for the spinal cord compression.
Yeah.
So for centers where you don't have video therapy facility,
Yeah.
which means your mainstay will have to be steroid. And if you decide to use steroid, for example, let's say because you give two doses, one is 96 mg, and the other one is 10, and then you take it down.
Either.
If you decide to use 96 mg, so how long will it go? Will you give it, and what's going to be the frequency? Is it going to be 96 milligrams per day, and for how long? And for centers where you have the therapy facility, are we going to be worried about the long-term complications of irradiating the spinal cord?
So now coming to the steroid question that I have already shown you, that the earlier study of 96 milligram was compared with nothing, no steroids. That was 96 plus radiation versus nothing versus radiation. So when the second study was done, because when that 96 milligram steroid study, what they found was that though there was more better chances of recovery, the toxicities were pretty high with 96 milligram. So the second study was done, which was with 96 versus 16 milligram per day, and that showed non-inferiority. That means 16 milligram per day is as good as using 96. So that was the study based on which the practice changed all over. And at our center, we use 16 milligram per day. So that is 8 milligram of steroid morning and evening, twice a day. You can use oral as well as IV, both have equal efficacy. Now coming to the duration, we give total 2 weeks from the day of starting. And that by that time, your radiation also will be over, in the first week itself. And after a week, we taper it gradually and stop it in 2 weeks. Now coming to the long-term impact of radiation, of giving out long-term complication of the dose of radiation, if you see the radiation dose used in cord compression is not very high. So it is single fraction. If you're using, they use 8 gray. If you're using 5 fraction, you use 20 gray. So that is a small dose of radiation to have long-term impact in terms of complications.
Yeah. Thank you.
Thank you.
Thank you, Dr. Lingaraj, for addressing the questions.
Thanks for the kind invitation, and I think it was a very interesting talk on the emergencies by my colleague, Dr. Lingaraj. I'm Dr. Bhausab. I'm a medical oncologist working here for past few years, and I guess we are a mixture of oncologists. So how many of you are surgical oncologists? Or yes, very good. And radiation oncologist, anyone? No, so that's the one thing, and rest of the people are medical oncologists, right? So the reason is we're talking about adult hematological malignancies, and as such, hematological malignancies, they stand apart from other malignancies for, I feel, 2 reasons. One is most of them are curable, so we need to be very careful when we treat these people, when we approach these people. And second thing is rapidity with which the things can change, right? So this is a bit different topic from the solid malignancies, and let's see. The goal is to give you an understanding of what are the advances in the management of hematological malignancies, and I recommend whoever deals with hematological malignancies start with getting a correct diagnosis, and this is like a Bible for us, WHO diagnostic criteria. It is important that we diagnose disease correctly, we stage disease correctly, or we get the prognostic marker very correctly. And we get every now and then the diagnostic criteria is updated, and reason being the pace of change in the field is so rapid that every 5 years the diagnostic terminology themselves change. I will just start with an excellent example. We had CML for years together, and we had these 3 phases: chronic phase, accelerated phase, and blast phase. And as the treatment of CML evolved, as we got new drugs, this phase in between, the accelerated phase, has been completely obliterated in the current WHO classification. What it says is this phase loses its prognostic significance, that we have so powerful or so good drug that we don't have to diagnose this phase of CML, chronic myeloid leukemia. accelerated phase, no more. So the point here is with changing treatment, we are likely to have changes in the classification, and it is important to be updated. The next excellent example is refinement in the diagnosis of acute leukemias. And here example is a new subgroup called as early precursor TALL. This is a TALL subtype, but they tend to do badly as compared to the ALL. And when they looked at gene expression profiling, this group came out as a different group. We have markers to diagnose this on flow cytometry. But the point here is how diagnostic advances are leading to change in the newer disease subgroups, and hence their management is important to be aware about this. The next example is okay. So the next example is PH like ALL. This is a ALL subtype which has come just because it looks like a Philadelphia chromosome on gene expression profiling. But the use of this subclassification is it is targetable like a Philadelphia in certain subsets. So it is important to be aware about these newer subtypes when we treat our patient. And we have this new diagnostic criteria. I'm struggling here with the slide. So excellent example would be how we diagnose acute myeloid leukemia. So we olden days, we used to have a FAB classification, morphology, etc. But the things are changing now. Now we look at blast, and if they have any of these abnormality, they become a AML with a certain subtype. The goal here is that the way we diagnose the disease, or for per se acute myeloid leukemia here, is changing. So it is important to be thoughtful about these classifications and subtype. Let's move on to some advances in the prognostication. So this is one example which I think is important. So we always had 3 subcategories of AML: favorable, intermediate, and unfavorable. And as the advances occurred, the intermediate risk category started narrowing down. Now that means we have more granularity, we have more information on individual patient, and it is important when you design treatment for these people, it is appropriate for him. The next advance probably in leukemia was something called as minimal residual disease. So when we look at response assessment, we look whether the patient has gone into remission or not. But I think it is time to look beyond that, because people who achieve this MRD negativity, or where they don't have any residual disease by these methods as of now, they have excellent outcome, and that is becoming a goal, and that is becoming a target of current treatment. And why this is important? This is important because this is looking like a good prognostic markers across the types of leukemias. It considers all the 3 factors: host, disease, and treatment related factors. And important, it is actionable. If someone remains MRD positive, you could change his outcome by looking at the MRD and treating it. And this is irrespective of the treatment type. So this is one example where we treated our patient with our protocol. This is going to be different from what is done in the Western countries, or because of various reasons. But it still works. Our people who achieve MRD negativity, they do well as compared to people who are not achieving this MRD negativity. That means some of these things are actionable, and some of these things are applicable across the spectrum of patient we see. Now we move on to changing therapeutic landscape. It is difficult to cover each and everything, but I just brought some action points. And this is a timeline of FDA approval for acute myeloid leukemia. And if you look at the last 7 years, we have more approval than at any time before that. That means we are getting newer drug very rapidly to treat our patient. And some of these treatments are very handy. For example, this chemo-free approach. So you imagine a person who is, let's say, 65 years, has a follicular lymphoma, and he will be treated with this chemo-free regimen of R² for a follicular lymphoma, and he can enjoy years of life without any chemotherapy. So this is the kind of advances we are seeing in hematological malignancies. The next excellent example is treatment-free remission in chronic myeloid leukemia. If someone is in remission for a few years, and if he satisfies all these criteria, a careful decision can be made to stop the treatment. So definitely we are moving not only from a safer treatment, but we are also looking at limited duration treatment in many diseases. And what you can see is roughly half of these people don't require these drugs. That means if you have good monitoring, if you have good initial treatment, you could keep this patient off treatment for long. We'll see some of the lessons from the myeloma story. So myeloma still remains incurable, but now we speak of long-term cure, median survival crossing more than a decade. And if someone is living more than a decade, is probably as good as being cured, right? Coming to diagnostic criteria, so we always used to insist that people should have CRAP criteria on diagnosis. But what has happened now is people are treating based on the biomarker-based definition. That means before someone has fracture, someone has renal failure, someone has anemia or hypercalcemia, these 3 things at the bottom: bone marrow plasma cell more than 60%, involved light chain, involved on involved light chain more than 100 and a lesion on MRI. This will give an idea this person is likely to develop myeloma within next few months, and it is best to treat rather than waiting for this patient. So the point there was that no, the time we treat these people is also treating. Look at these FDA approvals for multiple myeloma. If you could see, in the first decade of this century, we had 4 drugs being approved. In the next decade, we had 8 drugs being approved. But since in the last 3 years, we have 13 drugs been approved for multiple myeloma. And all these are not me-too drugs. So let's look at the responses. All the previous drug used to have response rate in terms of 30%, 40% at the max. But if you look at the last 5 approvals, all of them are crossing the response rate more than 60. So that means we are having a very good drug to treat these people. Our prognostic stage is constantly a chase. So we used to use Salmondiviry, we moved on to ISI, we have RISS now, and RISI 2 also has come. So this is a moving goal to re-stratify these people. Some of these are targetable. An excellent example is these few drugs for this specific subtype. That means we don't treat everyone like a garden variety patient. The person has to be given a drug which he is likely to be responding and sensitive to. Again, MRD is coming. So this graph very beautifully shows if you achieve MRD negativity, even if you don't undergo transplant, your outcomes are good. That means your response matters rather than what treatment you do. Another example of a drug adding to cure is quadruplet regimen with Cassiopeia. So some of these drugs are difficult to access as of now, but look at the beauty. A disease which has a lifespan of 10 years, and this study is showing at a very early time point a survival advantage. Means people are living longer with this kind of drugs. Now, I will give you 2 examples of drugs in multiple myeloma. So look at this graph. This is a graph of a relapsed refractory patient survival. So their disease is controlled for 4 to 6 months. Their lifespan, once they become refractory, is roughly around a year. But look at this drug. This is a CAR-T therapy, CAR-T, which was approved a couple of years back, and hopefully all of us would have access to this. But this control is for 3 years. The survival is not reached. So the kind of drug we are getting nowadays are they're completely different from what we are getting using earlier in our practice. And these drugs are coming in the front line. So that was for relapsed refractory patients. And this study beautifully shows that if you use this drug in earlier line of therapy, you are getting much out of these drugs rather than waiting when the person becomes relapsed refractory and many times not eligible for treatment. And even at this very short follow-up, this CAR-T versus a relapse regimen is showing overall survival advantage. So this was all what we had done in terms of diagnosis, in terms of our prognostic ability and our drugs. But does this work in real life practice? And I will give you a few examples which probably would be encouraging for you. For example, treatment-free remission in chronic myeloid leukemias. Imagine these are middle-aged ladies who want to plan their family, and because of things like this treatment-free remission, they are able to have babies and complete their families. And this is a result from our small series we did in our hospital. And this is really heartening to see that our patients are getting this kind of treatment for their optimal outcome. Coming to cost of the drug, so there are ways to handle. We look at generic. So we use a lot of generic in India, and we're fortunate to have a very good pharmaceutical industry. But the question is, are these drugs as good as the drugs we get outside or innovated drugs? And this was our attempt to look at what happens with the generic pomalidomide. I will just tell you, pomalidomide and lenalidomide are marketed or they are owned by a same company, and they don't pitch these drugs one against another. And this looks a very promising drug. And if you look at these outcomes, they are at par to the registration study, which was for pomalidomide, not only in the very early cases, but even in the relapsed refractory cases. So definitely we have to find our ways and means of getting access to drugs, and some of these can be examples. And lastly, like for example, MRD, we hear about MRD, but are we going to use in your practice? So definitely the time is there. We are currently running a study of MRD guided therapy in multiple myeloma in our institute. So definitely, I hope with this, I have showed you that the future for our patient looks much brighter. And this is a time, I'm not sure whether you can see this, but this is a video kill the radio star moment for at least oncologists in our era. So with this, I will stop and take any questions if there are.
Good afternoon, everyone. So just a disclaimer, I'm not the head of pediatric oncology, but I am part of the pediatric oncology department. So as a follow-up to what Dr. Bhausab asked, how many of you are pediatric oncologists? I see one person here. Two. Okay. Yes, I remember you. So I'll be briefly touching about the management of central nervous tumors in children. And I'm aware that we're running a little late and it's been a long day. So I think I'll just keep to the points. I'm sure all of us know that as an entire group, central nervous system tumors are the most common group, large, broad group of malignancies seen in children. And of these, the gliomas, especially the low-grade gliomas, are the most common amongst these. The second common group of CNS tumors in children are the embryonal tumors, of which the most commonly seen one is medulloblastoma, but the other tumors such as ATRT and the formerly called PNET, the brain peanuts, are also treated the same way as medulloblastoma. The other tumors that are commonly seen in children are germ cell tumors and ependymomas. So what's really important, and probably the reason that we're having this talk today is now that just as we heard in the previous talk, the paradigm of treatment is now completely changing in pediatric brain tumors, because there's been a lot of understanding regarding the molecular biology of brain tumors, and that is shifting our focus off the risk stratification as well as treatment. So because of an improved understanding of what causes these diseases, we really need multidisciplinary management. So that is very key to the management of children with brain tumors. And because the molecular biology is so well understood now, or rather it's being increasingly understood, it's being incorporated in the even in the classification of tumors. So I'll give you an example. If you talk about ependymomas, previously we would just refer to them as ependymoma based on the location. So it was just the radiological location as well as the histology. But now, when we talk about ependymomas, the molecular classification is also included when we talk about it. So I think we all know about the presenting features in brain tumors. Intracranial pressure is really an emergency. Increased intracranial pressure is an emergency. And depending on the location, we may have a varying degree of neurological deficits, epilepsy, or behavioral issue. And in children, we really need to look out for neuroendocrine manifestations. And we need to make sure that there are no issues with growth and nutrition. So how do we work up a child with suspected brain tumors? Brain tumor, I think you all know about it. So it starts with clinical evaluation, especially to look for any of these emergencies. Managing those emergencies while doing the workup side by side. So imaging followed by baseline investigations need to be done at the same time. And once we have some sort of a diagnosis, we need to discuss this in our multidisciplinary team, which is very, very important before deciding on the definitive treatment. So what's the diagnostic imaging that's preferred in children with brain tumors? The best imaging is MRI with contrast and including the brain and the spine. So that would be the standard form of imaging. However, that's not always easy to get because MRI takes a long time to do. And in small children, sometimes general anesthesia may be required, and that may not be possible in all situations. And sometimes it might be preferable to do a CT scan for a quicker diagnosis because they're also more easily available. CSF studies may be required in a large number of tumors, especially in medulloblastoma and ependymomas. And rarely there may be genetic syndromes. So around 10% of brain tumors may have underlying genetic predisposition. So depending on what kind of presentation it is, you might want to test for genetics as well. We already discussed emergencies a little earlier today, but I'm sure you know that management of increased ICP this is a potentially fatal emergency and it may be rapidly fatal. So we need to recognize it early and also initiate prompt treatment. Medical management includes dexamethasone, which is the mainstay of medical management. And we could do CSF diversion procedures. However, most of the increased intracranial pressure is because the tumor is blocking the CSF flow. So if we are able to do surgery of this tumor safely, then that might actually be the best option that's possible. So surgery is often the treatment of choice in most brain tumors, and complete resection if possible, while causing minimum morbidity. So that's key. So do not try to completely resect a tumor if you feel that the child is going to be debilitated after that. If resection is not possible because the tumor is in a very bad location, then we may actually end up doing only a biopsy. And if the child is in an area where surgery is not immediately possible, and the child has got refractory increased intracranial pressure, then VP shunt is an option, and it is often done when patients are referred from outside to a larger center. So surgery needs to be done in several tumors. So especially in the embryonal tumors that I mentioned, surgery is crucial. And ependymomas also, surgery is a very important form of treatment. But like I mentioned earlier, if the location is in is unsafe for resection, for example, in the brainstem or in the optic pathway, where the surgery would be extremely morbid, we would not do surgery. We would look for other modalities of treatment. There are also other tumors like germ cell tumors and lymphomas, which are exquisitely sensitive to chemotherapy and radiation. So you would actually try those modalities of treatment rather than doing surgery. Radiotherapy is a very important component of brain tumor therapy, and I'm sure you've heard about the several techniques, especially proton beam therapy, which is increasingly preferred in children with brain tumors, and intensity modulated or conformal radiation is what is really preferred in children with brain tumors if proton beam is not available. So radiation can be of various types. Also, you could either give focal radiation, that is only to the location of the tumor, and that can be given in gliomas, ependymomas, and if you don't want to radiate large parts of the brain, for example, in very young children. But craniospinal irradiation, that is the whole brain plus the entire spinal axis, that is required in embryonal brain tumors, which is probably the most common indication in which almost all children require radiation. So what is the problem with radiotherapy? It's a very important modality of treatment in brain tumors. However, it can cause a whole range of long-term effects, not just short-term. The long-term effects can be devastating. The younger the child, the worse the side effects. So because it directly involves the brain, there could be neurocognitive issues, there could be endocrine problems, both of these which can significantly impact the life. There can be problems with hearing, problems with growth, depending on how much of the spine has been irradiated. So a lot of problems can occur after giving high dose radiation to the brain and spine in children, especially if they are young. So radiation for brain tumors in children is usually limited to older children. As you can see here, it's usually given in children more than 3 years or in most diagnoses. And in low-grade gliomas, you could even give it in children who are above 7 years of age. Chemotherapy is an important modality in certain kind of brain tumors, which are mainly embryonal brain tumors, germ cell tumors, and in areas of the brain where actually surgery cannot be done. So you would, although chemotherapy is not the ideal form of management in these tumors, you would still do it because you cannot do radiation or surgery in these areas. There are a lot of chemotherapy agents which are used, but they all need to be able to cross the blood-brain barrier. So that is crucial when you are selecting agents for chemotherapy in brain tumors. And there's also the concept of giving high-dose chemotherapy. So if you give a very high dose of chemotherapy, it can potentially cross the blood-brain barrier and be more effective inside the brain. So coming to the different types of brain tumors one by one, I'll be very brief. I won't go through all the content that's there. But I will just touch upon the very basics. So medulloblastoma, we know, is the most common malignant brain tumor in children. And to a medical oncologist, this is probably the most important pediatric brain tumor that you would see, because all children with medulloblastoma end up receiving chemotherapy. And what's important is that a large number of them, at least 1/3 of them, can spread through the CSF. So what has been conventionally the risk stratification of medulloblastoma? We would look at the age. So in children less than 3 years of age, it's always high risk. if there is a large amount of residual tumor post-operative. So surgery is the first treatment. And if after surgery, we were not able to remove the tumor and left behind a large part of the tumor, again, it would be high risk. And if there was metastasis of the tumor, again, it would be high risk. So this is a conventional risk stratification. But like I mentioned earlier, there's a lot of understanding of the molecular biology, and at least 4 different types of medulloblastoma are recognized, actually more than that, but commonly we use 4 types with very different kind of prognosis. So in the Wind type of tumors, they have an excellent survival, whereas in group 3, they have a very poor survival. So that has now helped us really refine the risk stratification. So now in risk stratification, apart from the conventional features that we used to use earlier, molecular risk stratification is being increasingly used. And this is just to tell you that we use it routinely in India. Several centers in India are now able to use it. It's not just, a theory right now. It's possible to do it by various methods practically. I think I would not go into detail about this, but including immunohistochemistry can be used for risk stratification. So I think whoever is treating children with brain tumors should strongly consider doing molecular risk stratification as well. So just very briefly, the treatment of medulloblastoma in a child more than 3 years would be to do surgery, as complete a resection as possible, followed by radiation, followed by chemotherapy. But in children less than 3 years, as I mentioned earlier, we try and avoid radiation because the radiation involves whole brain plus the entire spinal axis, which can have a lot of long-term consequences for these children. So once you do surgery, you try to give different forms of chemotherapy, which could be high-dose chemotherapy, or you give it intraventricular so that there is a very high concentration of chemotherapy that goes inside the CNS. So that's what you do in younger children. In older children, depending on whether like the risk stratification I showed you earlier, depending on whether it's average risk or high risk, we would give different doses of radiation. So you would give a lower dose of craniospinal radiation in what is known as average risk, and a higher dose of radiation in those who are known to be high risk. But then in both cases, it's followed up with adjuvant chemotherapy. In children with average risk medulloblastoma, even in settings like ours in India, the survival is quite good, whereas it's not as good in high-risk medulloblastomas. So these are the doses and volumes. These are very standard. The drugs which are commonly used in adjuvant chemotherapy in medulloblastoma include cisplatin. Cisplatinum drugs are extremely important in brain tumors. Cisplatin, cyclophosphamide, and vincristine can be used as the adjuvant therapy in medulloblastoma. So what are the other options? There is the concept of using radiosensitization. So when you are giving craniospinal irradiation in a child with metastatic medulloblastoma, you could also give small doses of carboplatin. So you give small doses of carboplatin along with radiation, and this has found to have a very good effect in metastatic medulloblastoma. There's also the concept of giving high-dose chemotherapy. You give it in infants, of course, because you want to spare radiation, but you could also give it in older children. And the St. Jude Research Hospital in the US uses high-dose chemotherapy, which has yielded excellent outcomes. But that's actually not very feasible because of the logistics, as you know. So that's probably not a very good option for people like us. So metronomic chemotherapy is something else that we use. I'm sure all of you have heard about metronomic chemotherapy, which targets not just the cancer cells, but also the microenvironment of the tumor cells. And we have been using it as a maintenance therapy in very high risk medulloblastomas and embryonal tumors. And it's been found to be effective. Currently, we are actually running a trial to look for it. Something else that's very, very important. So I just mentioned about how harmful it is to give radiation in children with brain tumors. So there's now an increasing recognition that you can actually decrease the treatment in what are the molecular good risk medulloblastomas as well. The next group of brain tumors is low-grade gliomas, which is a very heterogeneous bag of diseases, and it's not a single disease, it's a chronic disease. So ideally, you need to completely resect the tumor. And if the tumor is completely out, you could consider that the child is, no further treatment is required. So if it's not completely resected, you may either give chemotherapy or radiation as adjuvant treatment. So in conventionally, radiation has been given all these years with excellent outcomes. But then we know that radiation has got multiple long-term side effects. So now there is an increasing trend towards giving chemotherapy. So once a surgery is done, if there's a residual disease, you would actually give chemotherapy in children with low-grade glioma. And unfortunately, giving chemotherapy means that only half of the children have a response to chemotherapy. So that again is not the most optimal way of doing it, but still you can avoid the long-term toxicity that is there with radiotherapy. So something else that's coming up is again a molecular targeted treatment in low-grade glioma that's really up and coming. And there is this molecular pathway which is almost universally seen in children with low-grade glioma. That's known as the RAS-RAF MAP kinase pathway, and targeting these are the BRAF inhibitors and the MEK inhibitors, which have both been found to be highly effective in children with low-grade gliomas. In some cases, they've actually been found to be much more effective than chemotherapy itself. And in some cases, they have been found to be equally effective. But what is the advantage? The advantage is that they are all oral tablets and they can be taken by the child at home. But they're extremely expensive. There are no generics available as yet. And probably when the generics are available, we could actually consider giving targeted therapy to a lot of children with low-grade glioma. This picture just shows how well the child responded to targeted therapy. So the other set of tumors is childhood ependymomas, again, which needs to be treated with complete surgical resection and followed by focal radiation. And chemotherapy has a very limited role here. However, in very small children whom you cannot actually give radiation to, you might give chemotherapy after surgery. So that may be one indication. Again, here, there are a lot of molecular prognostic factors which are being recognized, and we know that some of these molecular groups are very good and some of them are very bad. So they are used for the molecular prognostication in ependymomas. While surgery and radiation are really the key treatment modalities in ependymoma, there is some role for chemotherapy. The last group of tumors that I will talk about is intracranial germ cell tumors. Here, again, they are a very special kind of tumors because they arise in the midline structures of the brain, and they almost invariably present either with hormonal or visual problems, depending on where they arise from. And there are a lot of commonalities with the extragonadal germ cell, cranial germ cell tumors, the ones which are found in other parts of the body, because tumor markers may be elevated. Here again, surgery is very important. They are extremely chemosensitive, and we can also, and almost always they end up getting radiation as well. So this is a very special kind of group of tumors. Probably one of the most important parts about pediatric brain tumors is the long-term sequelae. So even if you don't give radiation, more than half of children have long-term sequelae just because of the location of the tumor itself. So because a lot of them have undergo morbid surgeries and they have long-term neurological sequelae as a result of the surgery, or chemotherapy itself, which can cause hearing loss or visual problems. And radiation, of course, can cause a lot of problems. So this slide just shows that multimodality treatment is extremely important. And the reason that we use multimodality treatment in children with brain tumors is to decrease the role of each modality of treatment so that the side effects that are caused by each modality are minimized. To summarize, there are several types of pediatric brain tumors. There are far more than I mentioned, of course, and the management is complex. It requires a specialized team. So I think that is probably one of the most important things that I would like to emphasize, that it really requires a specialized team who works as a team. And the timing of treatment is extremely important. Risk stratification is very, very important. So we need to be up to date with what is the risk stratification because it keeps changing as well. Molecular subgrouping within our capabilities is also very important to try and set up and to perform. And the therapeutic implications are, of course, evolving, and it has a lot to do with the improved understanding of the disease. So that's all. Thank you.
Thank you, Dr. Prasad. Is there any question from the audience?
It's more of a contribution than a question. For our center, we don't have neurosurgery practice. So we do get patients with masses in the posterior fossa sometimes. Yeah, we usually suspect medullo, but then we don't know what to do. So usually the pediatric oncologist we have, we just manage symptomatically and then allow the patients to go. But I don't know what's your take to this one, where there is no neurosurgery.
Yeah, so that's, I think, very unfortunate that there is no access to a neurosurgeon. I mean, that's surgery is crucial, especially in posterior fossa masses. It's critical, and all these tumors would need surgery. So, I mean, I think it's very easy for me to stand here and say that expertise needs to be built, but I think that is probably the only way to do it.
Thank you.
Thank
you, Doctor. Thank you.
So there are a couple of, so the question was if whether some of these tumors can be managed with chemotherapy alone. There are a couple of tumors which could be managed without surgery, and those would be the germ cell tumors that I just spoke about because they respond so well to chemotherapy and radiation. The CNS lymphomas and some of the gliomas which are in certain areas which you just cannot do surgery to. So potentially a lot of these tumors could be treated with high doses of radiation if you cannot do surgery, but the chance of cure is very less.
Thank you, Doctor.
Okay, thank you very much. Very good afternoon. And thank you, Merck Foundation and Dr. Banavli for having me here. In fact, it's a great pleasure, and it was so nice to meet Dr. Daniel and Dr. Mahmood after post-COVID. So they were trained here, and I was so happy to learn that actually training in Tata Memorial Hospital indeed helped them, and they are now practicing gynec oncology. So thank you, Mark, again for this program. So coming to the topic, ovarian cancer. Little bit on epidemiology, early diagnosis, clinical management, and prevention. So if we see globally, ovarian cancer is, we see nearly 313,000 new cases worldwide. And what is also important to remember that ovarian cancer amongst all gynecological cancers have highest mortality, essentially because women present at advanced stage of disease, there is, early diagnosis and screening is still not effective in this cancer. So the more than 207,000 women die of this disease every year globally. When we talk about India, it is the third most common cancer in Indian women after cancer of breast and cervix. And in Africa, it is the total number of new cases seen are 24,000, more than 24,000 new cases annually, and 17,000 women they die of the disease. So Africa contributes 7.7% of global burden of ovarian cancer. And that's why I think it's very important, and every oncologist must have some idea of on the disease biology. So when we say ovarian cancer, actually it's a very heterogeneous group because a variety of cancers can happen in ovary. The most common type of tumor what we see is from the surface lining of the ovary, or also known as epithelial ovarian cancer. But we do see other tumors, although to a smaller extent, like sex cord stromal tumor and germ cell tumor. So we just heard pediatric germ cell tumor happening at various locations, but the most common site for germ cell tumors we know is gonads, both in males and females. And within epithelial ovarian cancer, also you have a variety of tumors. The most common is serous. This is important to know the subtype because treatment and outcomes are slightly different. So within serous also you can have low grade, high grade tumors. So for a pathologist, it's so important to give exact subtype of ovarian cancer and because treatment and outcomes are different. So if we look at, as I said, unfortunately, we do not have any ways to pick up these cancers early. Majority women are diagnosed with advanced stage of ovarian cancer. In less than third, it may be picked up early. And the early ovarian cancer, they present as suspicious adnexal mass. So I don't know if any gynecologists in the auditorium, but these cases generally go to gynec. As complex adnexal mass or complex ovarian mass. So how do we manage? The biggest question is if this mass benign or malignant. So this is overall, once a patient comes with an adnexal mass, we have to consider patient's clinical profile and investigations. The most important investigations are imaging and as well as tumor markers. But what is important to remember that if this mass is confined to ovary is abnormal, it is big, a biopsy is not recommended. If it is confined to ovary, if disease has spread everywhere, there is no problem doing the biopsy. But if it is early disease, not spread beyond ovaries, a biopsy is not advisable. Certain clinical features which we need to take into consideration include patient's age and menopausal status, because the chances of an ovarian mass being cancerous is higher at extremes of ages, very young or postmenopausal. If there is a family history of breast or ovarian cancer or another cancer associated with Lynch syndrome, if women have suffered infertility or have taken treatment for infertility, these individuals are at higher risk of developing ovarian cancer. While oral contraceptive pills protect against ovarian cancer. So once we suspect ovarian cancer, as I said, imaging and tumor markers. So what imaging? The first, generally we do a sonography or ultrasound, including a transvaginal sonography. MRI is not essential, but if it is available, it gives little more information on what we get from sonography. CT scan tells about the spread, especially in the abdomen. PET CT, don't worry if you don't have, it is not recommended in these cases. So this is just to show how ultrasound can tell that mass is suspicious of ovarian cancer. If you see solid areas, if there are growth within the mass. So ultrasound is a good imaging modalities. CT scan, especially when disease has spread beyond, then it is a good test to tell if there is a free fluid or lymph node or disease in the upper abdomen. Now coming to tumor markers, and I'm sure you all know CA-125, but important to remember that CA-125 is not a very accurate tumor marker. It can be normal in nearly half of ovarian cancer patients. So a normal CA-125 does not mean that patient doesn't have ovarian cancer. And it is also not specific. That means elevated CA-125 does not mean patient has cancer. And this is important because patients also think when there is elevation in CA-125 that they got cancer. So a number of other malignancies can cause elevation in CA-125 as well as benign conditions, which we have to remember, which can cause elevation of CA-125. And I would say these three conditions, they mimic ovarian cancer. Endometriosis, pelvic tuberculosis, very common in India. I don't know about your countries, but it's very common in India. And we do see a lot of patients who have been referred as ovarian cancer and turn out to be pelvic tuberculosis and pelvic inflammatory disease. There are certain other markers which you may like to do depending upon patient's age and clinical scenario. These are germ cell markers, alpha fetoprotein, beta HCG, and LDH. inhibin for granulosa cell tumor, and CA19-9 and CEA can be elevated in mucinous tumors. But if these are elevated, we need to rule out gastrointestinal cancers, because these are primarily marker for GI malignancies. So once workup is done, the next step is to do surgery. Surgery does not confirm the diagnosis of ovarian cancer, but it also tells the extent of disease. It is the main treatment modality and also prognosticate the patient. And it's important that this surgery is performed by someone who is trained, like Dr. Daniel or Dr. Mamadou, doing these surgeries, because studies have shown that when surgeries are performed by experts, outcomes are better. Patients live longer if surgeries are done properly by experts. So this is just to show what are steps of ovarian cancer surgery. It is just not removal of ovarian masses, but we also do other things, including omentectomy, random biopsies, lymph node dissection, etc., to know the exact extent of the disease. One question, I don't know how many of you are surgeons here, but what we do see, and how common laparoscopy in your country, but what we do see, a lot of these patients have been mismanaged outside by laparoscopic surgeries. And what are the issues when we do laparoscopy for ovarian cancer? There is invariably spill of the tumor, spread of the tumor. There can be metastasis, port site, like, where you put ports. Surgeries are often inadequate. There is limited visualization, and there are many, many issues with laparoscopic surgeries. So I'll show you a video, and even if you are not a surgeon, as an oncologist, you will realize what should not be done. So this was a young patient who has a well-confined adnexal mass. A gynecologist thought of doing laparoscopic surgery. So you see a puncture, a spillage, a rent was made in a mass which was intact, and you see a lot of solid areas. But still, surgeon did not think of it being malignant. They removed the ovary, but then look what was done after removal: morcellation. So this is something what, we have to remember what we should not do in oncology. First, we learn what to do, and the next step is what we must not do. So the whole mass was morcellated. And that has, all this will lead to spillage, upstaging of the disease, which adversely affect patients' outcome. So as I said, even if you are not a surgeon, you can appreciate this is something one should never do. Surgery alone may not be adequate for all cases. What is important to have a proper histopathology report, and it's extremely important to develop pathologist, oncopathologist, or surgical pathologist, because surgery is all, oncology is all about pathology. So based on final pathological staging and features, we decide whether to give adjuvant treatment or not. So patients who are very early stage, confined to one ovary, very low grade tumor, a proper surgery done, they do not require any additional treatment. All other patients, we do chemotherapy in the form of paclitaxel carboplatin. This is the standard for most gynecological cancers, a combination of paclitaxel and carboplatin-based chemotherapy. Quickly, I've moved to the more common scenario, that is advanced ovarian cancer. So these patients are also treated by a combination of surgery and chemotherapy. The standard is to do surgery first and then give chemotherapy only when you can remove, or you think you will be able to remove, most of the tumor. However, if patients, patients who are with very advanced disease, we do give chemotherapy first, that is neoadjuvant chemotherapy, to downsize the tumor, to make them little better, and then do surgery. So how do we select patients for surgery versus chemotherapy first? The multiple factors we take into consideration: the extent of disease, patient's performance status, albumin, overall general condition, and I think very important in our kind of setups is availability of infrastructure, including just not surgical expertise, but anesthesia, ICU facility, interventional radiologists, patient's financial status. All of these things we do take into consideration. So whether we are doing surgery first or after chemotherapy, Generally, patients require, because this is, a disseminated kind of stage. So patients would require multiple organ resections. So omentectomy, this is, you can see diaphragm, which is studied with the disease, but with surgery, you can remove the entire disease. This patient had a diaphragmatic deposit, which was going towards the pleura. So we had to resect the diaphragm, part of diaphragm, you can see lung there, but then you can close it. If a complete resection is possible, aggressive surgery is indicated, provided you have expertise and infrastructure. So liver surface deposit, at times if there is disease at splenic hilum, splenectomy, bowel resection and anastomosis, and generally one patient may require multiple of these surgeries. So just a video again to show this patient, actually this is post-chemotherapy. Neoadjuvant chemotherapy was given, 3 courses of paclitaxel and carboplatin, but still she had a lot of disease. You can see this is essentially to show how we remove a diaphragmatic peritoneum. So we use cautery, monopolar cautery. You can use bipolar or any other advanced energy device. So you can see, this is diaphragmatic muscle and the peritoneum has been removed. There was some deposit over the surface of liver. Again, these can be removed easily. I want you to appreciate that in ovarian cancer, generally it doesn't infiltrate very deep. So you can remove all these surface deposits easily. What I'm using is monopolar current. Of course, proper exposure, proper infrastructure is absolutely essential to perform these kind of surgeries, and patients should be fit to undergo these surgical procedures. One should not, venture if you do not have infrastructure and facilities. So this is falciform ligament, which was also diseased. So we removed the entire falciform ligament. If you have ligashore or harmonic, just to show it, advanced energy sources can be used. Otherwise, a monopolar cautery or a bipolar cautery is good enough. So this is the entire falciform ligament. Continuing dissection, you will see a nice plane between diaphragmatic muscle and the peritoneum. But I want you to appreciate that we are using Thomson retractor. So that's extremely important to have proper exposure. Our assistants can't lift the abdomen for that long, abdominal wall. Even if there is a small rent in the diaphragm, you can always suture it, or part of diaphragm can be resected also. So this is the entire diaphragmatic peritoneum. There was some more disease which we removed. So the entire parietal peritoneum actually can easily be stripped. Even peritoneum from the mesentery of small bowel and large bowel can be removed. Liver surface deposits can be removed easily, and you don't really need a hepatobiliary surgeon for this purpose. You can do it yourself. Non-anatomical resections can easily be performed, small site tumor. So this patient also had little Gleason capsule disease, liver capsule, again to show how easy it is to remove. What I'm using here is a right angle instrument known as mixture. So you just have to be in the right plane. And then on the liver, you can use higher cautery setting. But this kind of surgery is useful only if we can achieve complete R0 or complete resection elsewhere in the body, in the abdomen. And also important to have a chemotherapy backup. As I mentioned, combination of paclitaxel and carboplatin is the most effective chemotherapy in ovarian as well as other gynecological cancers. So this is the protocol what we follow at Tata Memorial Hospital. Also, if you have facility, because many of these ovarian epithelial tumors have hereditary predisposition. So if facility is available, try to get testing for BRCA1 and 2 if available, because one, it has therapeutic implications. We have PARP inhibitors. Of course, patients may not be able to afford. Many of our patients also can't afford, but it also has implications for future generation because risk reducing or preventive surgeries can be done. So after your treatment is over, after, if you have done surgery, first give 6 to 8 cycles of adjuvant therapy. If you have done neoadjuvant chemotherapy surgery, and then more chemotherapy, followed by surveillance. So this is what we generally follow: 3 to 4 monthly for first 2 years, 6 monthly for up to 5 years, and then annually. And at every visit, a good clinical examination, tumor markers if elevated, and ultrasound and CT scan are not required on every visit. These are done only if patient is symptomatic. So you don't have to really ask for sonography or CT scan at every visit. A last bit about preventive strategies. So unlike breast or cervical cancer, so ovarian cancer, there is not much for, in general population, there is not much of prevention. So what we have recommendations are for screening, chemo prevention, and risk reducing surgeries in high risk populations. So women who are either known germline mutations or who have very strong family histories are the one where these things are recommended. So what screening part is both for breast and ovary, because women who have genetic predisposition like BRCA1 or 2 mutations, they are more prone to develop breast as well as ovarian cancer. So screening for breast cancer as well as for ovarian cancer. So ovarian cancer screening is generally started at around 30 to 35 years of age, and it's by clinical examination, ultrasound, and CA125. Although ovarian cancer screening has not found to be very effective, it does not always lead to early detection. Chemo prevention in the form of tamoxifen and oral contraceptive pills have shown to be effective. But what is the most effective way to reduce the risk of ovarian cancer is by prophylactic surgeries. So risk reducing prophylactic self-ingo oophorectomy in individuals who have genetic predisposition is recommended, and it's done usually around 40 to 45 years of age. So we all know the story of Angelina Jolie, who underwent risk-reducing, just not self-ingo oophorectomy, but also bilateral mastectomy and reconstruction, because she is a BRCA carrier. And another thing which is getting popularity is removing only fallopian tubes in individuals who are undergoing hysterectomy. Say you are doing hysterectomy for fibroid, because there are some thoughts that primary ovarian tumors, they have origination in fimbrial end of the fallopian tube. So if you are doing hysterectomy for benign indications, it is recommended to remove bilateral fallopian tubes, but not ovaries in young individuals. The other way is, if you're, if local law allows, you can do self-injectomy as fertility, as infertility or as sterilization procedure. So that is not allowed in our country. I don't know what's the rule there. So to summarize, majority of patients with ovarian cancer, they present with advanced stage disease. Unfortunately, we do not have any cost-effective screening preventive strategy for this disease. Treatment is by a combination of surgery and chemotherapy. And surgical training for ovarian cancer surgery is extremely important. It has shown to improve patients' survival. Genetic testing facilities, if available, must be done. Targeted therapies, they have shown to improve survival, but the backbone of treatment is chemotherapy, combination of paclitaxel and carboplatin. And prophylactic surgeries can reduce the risk of ovarian cancer in individuals who have predisposition. So with this, I'll stop. Thank you very much.
Good afternoon.
Good afternoon.
Very insightful presentation.
Thank you.
I think I've got a couple of questions for you. The first one is pertaining to interval debulking surgery, the one that we normally do after giving 3 to 4 cycles of chemotherapy. But there is this concept where let's say there is a delayed interval debulking surgery, not the usual interval debulking surgery, especially when you find that imaging is showing that the patient has got a high volume of disease in both the upper abdomen or the abdomen and the pelvis. You as the head here at Tata Memorial, what is your thought on delayed interval debulking? The reason being is that for us, I think in Africa, where we have a lot of issues, I think it can help us, especially if we can give outright 6 cycles of chemo, then we operate. I think I wanted your thoughts on that. Then the second thought is pertaining to lymph node dissection in these patients who have got, of course, extensive ovarian disease.
Right.
Then we are thinking of lymph node dissection. Again, what are your thoughts on lymph node dissection in extensive ovarian disease?
Okay.
Then again, it has to do with another thought, especially where we require to make cell counts for us to come up with a diagnosis. Again, in Africa, we seem to have a lot of problems. You know, sometimes we do not have cytologists. Even if we are going to get a cytic fluid to make cell blocks, who is going to make? So in such situation, when even if CA125 is non-specific, but we have got a high index of suspicion looking at the imaging saying we are dealing with ovarian cancer. Is there a role in that situation where him can be used as MSET without coming with a diagnosis in terms of cell blocks that have been made? Then the last one, the final last one is with regard to PARP inhibitors. Because PARP inhibitors, with you here, and probably I've seen this in the European States, it's one thing that is gaining ground, especially as a maintenance clause. But where we are coming from, we do not do genetic testing. But there are some patients who are able to afford PARP inhibitors, although it's quite expensive, without genetic testing. Would you advise for such patients to go ahead in receiving PARP? Thank you so much.
Okay, so thank you. Let me start with the last question. PARP inhibitors without genetic testing. So current approval is for niraparib, which can be used regardless. But I would suggest no. A patient who can afford PARP inhibitor can, I think, afford to send sample to another country to get test results. Because one, it is expensive. The therapy is expensive. Second, it is not without toxicities. So the maximum benefit from PARP inhibitors have been shown in patients who have germline BRCA1 or BRCA2 mutations, or who have HRD positive, homologous recombinant deficiency in tumor. So I personally would say it's not a good idea to use PARP inhibitors without having either somatic or germline testing. That's my take. I don't know. We don't have, I mean, medical oncologists can opine for other sites because and I think niraparib is the only one who got approval regardless of BRCA status. You can use it, but we don't use it ever without HRD or germline. The second question is whether we should give neoadjuvant chemotherapy without having cytology or histological diagnosis. I would say no, because we have seen many cases of tuberculosis, of endometriosis, of pelvic inflammatory disease, who actually mimicked, and we have published our results with abdominal tuberculosis. I didn't show that slide here. It's more than 300 patients. CA-125 was to the tune of median is around 900. All were referred to us as case of advanced ovarian malignancy, turned out to be tuberculosis. So I would say no, it's not medico-legally also correct. We in fact had a patient who had actually right-sided heart failure, and she had ascites, and cytology showed some atypical cells. She was given chemotherapy, and when referred to us as platinum refractory ovarian cancer, when we investigated, we found her actually having just heart failure and there was no cancer. So I would say no, we should try to develop pathology or cytology, or if you think cytology is not there, get a biopsy. Cell blocks, it may not be possible, but at least cytological evidence of ovarian cancer or some malignancy is required. So I won't recommend that. It's not legally correct also to give chemotherapy without having either histological or cytological diagnosis of cancer. Coming to the question of lymph node in advanced ovarian cancer, either upfront surgery or after neoadjuvant chemotherapy, our policy is if nodes are enlarged, then we do remove them. But if nodes are not enlarged, and if we cannot achieve a complete cytoreduction in the intraperitoneal compartment, we do not remove lymph nodes for all cases. So we remove if nodes are enlarged, and if we are able to remove disease from everywhere else, we do lymphadenectomy. But patients where if disease is not completely removed, or if nodes are not enlarged, we do not remove normal looking nodes. There is a trial, Alliance trial, which showed there is no advantage of doing lymphadenectomy in patients who do not have enlarged nodes. In fact, it just adds to the morbidity, because retroperitoneal lymphadenectomy is a morbid procedure and it causes a lot of post-operative complications, including lymphoria, ileus, bowel obstruction. So we don't do if nodes are not enlarged. And coming to the first question, what was the question? I forgot. Delayed, yeah. So in fact, yesterday only my junior faculty was discussing, and we are, Jaya is not here, but we are looking at our data where we have given 6 cycles, but normally our practice is to give 3 cycles. We do not routinely finish all chemotherapy and then do surgery, but there are patients who have partial response, who do not have very good response the way you describe. You know, there is still a lot of disease in upper abdomen, some ascites, some response. CA-125 has come down, say, from 3000 to 200, but still a lot of disease. These are the patients we would continue 6 cycles and then plan surgery. And the other scenario can be if there is no response, then we would, one, confirm the diagnosis that it is indeed ovarian cancer. We are not dealing with some other cancer. And secondly, if there is no response or if progressive disease, we would change to second line of chemotherapy. But if there is some response, but not a very good response, we would continue same paclitaxel carboplatin to 6 cycles that we do. But as a routine, if there is either complete response or partial response, which we think is good enough to undergo surgery, we plan surgery after 3 or 4 cycles. But what you are saying is, I think Yale's University has this protocol. They routinely give all 6 cycles and then plan surgery. We do not do that. But our medical oncologists, actually, we are looking at our data. How is the outcome of these patients who have received 6 versus 3 cycles of surgery? Yeah.
Thank you, Professor.
So our practice is 3 weekly. There are trials which showed initial ones, you know, that Japanese study showed weekly is better, but then subsequent studies showed weekly is no better than 3 weekly. So our standard practice is 3 weekly. We do practice weekly only in patients who are in poor performance status, where we think full dose weekly is 3 weekly is patient may not tolerate. There we do use weekly AUC2 carboplatin many times as single agent. That's generally first cycle. Once patient is little better, we move on to 3 weekly. So 3 weekly is our current practice. 4 weekly, no, 4 is not required. So if we are using lipodox, then 4, but paclicarbo, if counts are okay, patient is fine, then 4 weekly is not required. No, 3. I mean, that may be if patient's condition does not, otherwise it's 3 weekly. Sorry, I mean, it is 3 weekly. We practice 3 weekly.
Thank you, Professor, for the very good talk.
Thank you.
We've had one point to add. So there's NACT. I've tried adding some monoclonal antibody for the young ladies, and I think there are no studies against, but it works perfectly to reduce the burden of disease, and it gives you a good outlook when you go into surgery.
Right.
Coming to my question, let's start with the case actually. The two discrete tumors, one in the ovary, one in the uterus, both of them endometrial type. How would you think, and what would be the state of the way forward for this patient? And I tried to do an NGS to get the right diagnosis, but it was not coming up. The IHC didn't prove anything. The NGS is on the way, but we're trying to get the right diagnosis. Is it an ovarian tumor or is it an endometrial carcinoma?
Or it could be 2 separate. So it's possible that one we are thinking in terms of metastasis, or it could be 2 separate tumors. We do see patients who have, primary endometrium and primary ovary both. So if you see newer endometrial cancer staging, they have included a condition where just one ovary is small as part of early.
2 separate cases. One case where there is discrete anatomically, and one where it's stuck together.
So the general, this thing is, of course, we have to wait for NGS report, but the general is if both are very early, endometrium, low grade, superficial or no myometrial invasion, and then ovary also. So then we would think in terms of 2 separate primary, but can happen. And we have, in fact, recently operated. It was endometriosis in that ovary, and she had endometrioid carcinoma in endometrioid. In endometriosis and also uterine cancer. So we do see both endometrioid. Of course, it's easy if histologies are different or if grades are different, but if both are same grade, it is, yeah, I agree, it's difficult. I think he's just looking at his watch repeatedly. I think, we are running short of time. So if you have done surgery, we would, generally intraoperative, we wouldn't have diagnosis whether these are synchronous, 2 separate primaries or metastasis. We would treat as primary ovary, primary endometrium. We would do, if fertility is not a concern, we will do a comprehensive surgical staging. In this patient, it will be total abdominal hysterectomy, bilateral salpingo-oophorectomy, pelvic and para-aortic lymphadenectomy because ovaries are also involved, and omentectomy. You will say that for endometrium, it is overkill, but for ovary, this is the thing. So that's what we would do. And that's what we did actually. Last week only we operated. Yeah, so. So chemotherapy, right. Endometrium is 1B, yes. And also important to have molecular profile. So especially now MMR IHC for this patient, P53 also, and ERPR, ERPR. So this is bare minimum. Pole we may or may not do. So yeah. And there are reports suggesting that primary ovarian endometrioid, they may have molecular profile like primary endometrium. So it's recommended to do pole and MMR on primary, even if you have just ovarian endometrioid tumor without endometrium having cancer, molecular profile is more like primary endometrium than primary serous ovarian. So that's what we would do. Definitely, if it's both are very early, we may not give any adjuvant, but if there is indication, it will be a combination of chemotherapy. I don't know whether we will give pelvic EBRT or we may just give wall brachytherapy and chemotherapy.
Thank you, Professor Amita. I just have a quick question. I just saw the videos that you projected on the surgeries. And I would say that, for ovarian cancers, it's quite extensive in terms of cytoreduction. For those of us who do GI surgeries, we don't go that extensive, or we just think that it's probably beyond any curative intent. So just a quick one, given that type of extensive surgery that you do in trying to debulk the tumor burden, I just wanted to know what the prognosis and the 5-year survival rate would be, for such tumors after such extensive surgery. obviously given the differences in terms of histological subtypes?
Right. So if you are able to achieve complete cytoreduction after extensive surgery, the 5-year survival rates are to the tune of 30 to 40% in these patients. And GI, of course, generally speaking, you won't do, but I think one scenario where you would do such extensive surgery is
Appendix, I think.
right, pseudomyxoma peritoni or, a mucinous tumor. So with HIPEC, of course, we are doing a trial. I didn't mention here, we are doing a trial on HIPEC in advanced ovarian cancer. We are comparing HIPEC, that is hyperthermic intraperitoneal chemotherapy. The other arm is normothermic intraperitoneal chemotherapy. And the third arm is nothing, the standard of care adjuvant chemotherapy. So this is a 3-arm randomized trial we are doing at Tata Memorial Hospital, because role of HIPEC in ovarian cancer is currently controversial. We really don't have the answer. So I think we do offer these surgeries to patients, as I said, good performance status and where we can achieve complete cytoreduction. And it has shown to improve their survival. And especially if you have given chemotherapy, these are essentially chemo-responsive tumors. So yeah, we do offer. Right, I think. Yeah. Thank you very much.
Thank you very much, Dr. Amita, for addressing the questions.
Good afternoon, everyone. And I'd like to thank the organizers at the outset for inviting me to this. So over the next 15 to 20 minutes, I'll try and cover colorectal cancers in patients with FAP and HNPCC. The management of the oncological aspects is actually not much different than the sporadic aspects. So I will go into the genetics a bit and briefly touch upon how we manage these patients. These are some of the subtopics that I will cover in the management of FAP and HNPCC. The basis for almost all colorectal cancers is the APC gene, indirectly or directly. And for FAP, it is directly linked to mutations in the APC gene. A few small pointers on FAP. It's located on 5q21. It's a tumor suppressor gene. It has autosomal dominant inheritance at nearly 100% penetrance, which means that if you have this mutation, you're likely always going to develop colorectal cancer. You can test for germline, but usually this is a diagnosis made by family history and a colonoscopy. It's responsible for a very small proportion of colorectal cancers, just about 1%. And there are some similar syndromes like AFAP and MAH. Diagnostic criteria are pretty straightforward and they've been well characterized over the last 30 to 40 years. You have more than 100 colorectal adenomatous polyps, a germline mutation, a history of FAP with colorectal adenomas in patients less than 30 years. And you have some of the desmoid tumors or osteomas. The conditions mentioned in the italicized version, they are not classical for FAP, but if you have any of these conditions, you might want to consider testing for FAP. These are some of the associated tumors in FAP. So it's just not colon cancer. You have a number of facial abnormalities, thyroid carcinomas, and the other important bit which requires a fair degree of multidisciplinary management are desmoids. While being benign, they do cause issues with surgery as well as management. The classical teaching is that you see a carpet of polyps in FAP, and this is what you see on a colonoscopy or a resected specimen. So some of the features associated with FAP, they're usually diagnosed on family screening, as I had said earlier, or in 20 to 30% of patients, they are a de novo presentation. And in these cases, when you don't have a family history, the diagnosis is often delayed. Polyps usually develop in late childhood, and if you don't treat them with prophylactic surgery, you will develop a colorectal cancer in almost 100% of cases. So screening, essentially, we start at the age of around 12 years because ethically there are issues if you start screening before 12 years. And some guidelines actually say even less than 10 years, but that is a difficult decision to make. The primary treatment for these is essentially surgery once you've taken a call to do a surgery. And these indications for surgery are when you have a suspected colorectal cancer, when you have a number of polyps which cannot be adequately removed by polypectomies, and you have very large adenomas. Essentially, the management of FAP, the colon cancer aspect, is 3 surgeries which are largely self-explanatory. In earlier times, the standard surgery was a complete removal of all bowel mucosa with a permanent ileostomy. Nowadays, you largely do not do this. It is very rarely required unless you have a low rectal cancer where you need an abdominoperineal resection. Otherwise, this is not a surgery that is done now, but it was a traditional surgery for these patients. The major highlight of this is that it's almost completely protective against colon cancer. So there are 2 surgeries that are now considered. One of them is a total proctocolectomy with IPAA, or what is also called a restorative proctocolectomy. The key thing is this is that you don't need a permanent stoma. Although in 10% of people, because of recurrences or non-functioning temporary stomas, you need a permanent stoma. The problem with this is, 1, it cannot be easily done in all areas. And 2, it has effects on fertility as well as erectile or ejaculatory disturbances in men. So patients need to be warned about this. The surveillance is not as extensive unless you preserve the rectum, but there are case reports of developing adenomas and carcinomas in the pouch. The other surgery is the total colectomy with ileorectal anastomosis, where you allow the rectum to remain. The key feature of this is that you can avoid a stoma, a permanent stoma at least, but you need to have surveillance every 6 months to 1 year because the rectum is retained. So a lot of the management of FAP is based on surgery. No great medications have known to reduce the incidence of adenomas or the rate of conversion of adenomas to carcinomas. These are some of the drugs that have been tried, but none of them is really used. In terms of management of these cancers, once they have been diagnosed and resected, you almost always treat them like sporadic cancers, because there is almost no data comparing the outcomes for these patients compared to patients who have sporadic tumors. So we follow what we do in sporadic tumors. In stage 1, you observe. In stage 2, you consider observation or 5FU. And stage 3 would be 3 to 6 months of K-pox or FOLFOX. Coming to the next part of the talk, it is the HNPCC, also commonly known as the Lynch. And again, indirectly, it is related to the APC, but the key is that you have mutations in the mismatch repair genes, and then you have downstream effects of the same. Although Lynch syndrome and HNPCC are used interchangeably, they're not actually the same. HNPCC only refers to the colonic aspect, while Lynch is more a familial thing and has a number of other associated tumors. As I said, it's you have inherited mutations in the DNA mismatch repair. There is autosomal dominant inheritance, and it's responsible for a slightly higher proportion of cancers, around 3 to 5%, according to Western data. And the initial method of diagnosis is either by IHC on MMR or a microsatellite instability by PCR. And it's important to remember that not all MSIH is actually Lynch syndrome. This is a list of the genes which are associated with the Lynch syndrome. There are around 8 of them, but it's important to remember that mutations in MLH1, MSH2, MSH6, and PMS2 are largely responsible for around 80% of these cancers. In around 20%, we are not able to identify a mutated gene. As I said earlier, if you have 100 colorectal cancers, around 15 of them will be MSI high, 5% of them will actually be Lynch or HNPCC, and 10% will be sporadic. And one of the easiest ways to direct us towards Lynch is if you do protein analysis by IHC and MMR. So if you have a loss of MLH1 and then look at BRAF, that will direct you towards how to diagnose a Lynch. This is an easy to do test. It has very high concordance rate with the PCR that is more expensive. So there are two screening criteria that are often used interchangeably when we talk of Lynch. One is the Amsterdam 2 criteria, and the other is the revised Bethesda. What the Amsterdam 2 criteria looks at is if you're in a family with a number of people with Lynch, then should you be tested for Lynch? That's what the Amsterdam 2 criteria looks at, and it is easy to remember. If you remember 1, 2, 3, you should have at least 3 relatives of 2 generations, and 1 should be a first-degree relative, along with some other features, of course. What the Bethesda criteria does, or the revised Bethesda now, is that it looks at people who should be tested for MSI, and then you go on to Lynch from testing for MSI. So the revised Bethesda criteria looks at people who are less than 50, who have presence of synchronous or metachronous colorectal cancers, if they have features on their pathology suggestive of an MSI-H, and if you have 1 or more first-degree relatives with HNPCC. These are some of the screening guidelines for HNPCC. They're not cast in stone, but the ones that are followed quite well are those for colon and gastric cancer. For colonoscopy, you start screening at 20 to 25 years with a scopy. And for stomach cancers, you start at 30 to 35. It's important to remember that this is more dependent on when the first person in the family was diagnosed with an HNPCC. And you generally start screening approximately 5 years before that if you're suspecting a patient with Lynch syndrome. The diagnosis is by MSI, and that is the gold standard. You classify patients as MSI high if you have 2 or more markers showing microsatellite instability. And for practical purposes, MSI low and MSI stable are considered together. The other option is to do an IHC, and this I had previously talked about. Of course, you can do an NGS as well and pick up MSI. This is a list of the cancers associated with HNPCC. The commonest, of course, is colorectal. The next common is endometrial cancers, and you have a host of other cancers which are related to HNPCC. Coming to some of the common features that you see in patients with colorectal cancer in Lynch syndrome, they're more commonly right-sided. They have poorly differentiated cancers or mucinous histology, and they have a high number of tumor-infiltrating lymphocytes. It's important to note that as your stage of tumor increases, the proportion of patients with MSI high decreases. So if you have a stage 1 cancer, the chance of MSI high is around 20%, but in MSI high is only around 3 to 5% in stage 4 cancers. And probably stage for stage, MSI high cancers survive longer, though this is not wholly without controversy. Surgical aspects, essentially you treat them the same. The only thing is that in these patients with Lynch syndrome, you have a high chance of having a metachronous cancer. And the proportion of this is almost 20% at 10 years. So the idea is that if you do a segmental colectomy, then these patients need complete follow-up. However, if you do a full colectomy, then the regimen for follow-up is slightly better. However, there is no difference in overall survival, and this is based on a meta-analysis, so either option is actually appropriate. Adjuvant therapy, again, follows the treatment for sporadic cancers. The only thing here to note is that in stage 2 cancers, you probably will observe these patients as opposed to giving them 5-FU, because there is some suggestion that these cancers are intrinsically resistant to adjuvant 5-FU. So in stage 2 cancers, you would lean towards observation as opposed to 5-FU. And in stage 3 cancers, the same dictum is followed. Now, coming to the last bit, these MSI high tumors are heavily immunogenic, which is why checkpoint inhibitors are the current standard of management in these tumors. The reason for this is that these tumors have a very high neoantigen burden, and that allows greater expression of these neoantigens PD-1, PD-L1, and allows checkpoint inhibitors to act well in MSI high tumors. This is the mechanism of action of the 2 most commonly known monoclonals that we have. It's either PD-L1 or PD-L blockers or CTLA-4 antibodies. In advanced or metastatic colorectal cancers, In the era before immunotherapy, these patients probably had lesser survivals. They were more resistant to chemo. But currently, there is enough data to show that in patients with stage 4 cancers, you should consider first-line immunotherapy. And pembrolizumab is one of the accepted options for this. And you have survivals greater than 3 to 4 years, something that was unheard of in previous times. To conclude, FAP and HNPCC are rare causes of CRC. The key is screening and early identification of therapeutic approaches. Managing CRC is only one aspect of treating these syndromes. And the primary therapeutic approaches for these tumors remain surgery and the types of surgery, while in stage 4 cancers, you will treat these patients with immunotherapy with good expected survivals. With that, I'd like to thank you for your attention. Thank you.
I would like to invite the panelist for this session. The panelist, Dr. C.K. Kazuma, Dr. Sapausi Victor Nicholas King. You can take your seat, sir. Dr. Judith. Dr. Musana Othinel. Dr. Kim Quran Vikram Singh, Dr. Said Ahmed Muhammad, Dr. Kisama Taure, Dr. Magasoba Mamadou, Dr. Sadao Achatao, and yes, you can be seated.
Okay, I think it will be good that we all introduce ourselves, starting from the right.
My name is I'm a consultant, neurosurgeon and surgical oncologist from Zambia. I am based in Ikwe at Ikwe Hospital.
Good afternoon. My name is Dr. Said. I'm from Kenya. I'm doing my master's in internal medicine. I'm currently based in Alexandria, Egypt.
Bonsoir, moi c'est Dr. Sadou Aïchatou, gynécologue, obstétricien, oncologue, chirurgien malade. Je viens du Niger, Centre national de lutte du cancer.
Good afternoon, everybody. I'm Dr. Kim Kuran, consultant clinical oncologist, and I'm from Mauritius.
Myself, I'm Dr. Sokwasi Victor Nicholas King. I'm a consultant gynecology oncologist, head of unit at the John F. Kennedy Memorial Hospital in Monrovia, Liberia.
I'm Othniel Mosana, a consultant gynecologist with a private, not-for-profit, faith-based hospital, oncology center. I'm also the current president for our Society for Obs and Gyn in the country. I'm also standing to become the president of all the doctors in the country, but I also do a lot of service design in the private sector, talking to investors to invest and then set up hospitals.
Bonsoir, mon nom c'est Mamoudou Magassoua from Guinée. Je suis gynécologue oncologue et je travaille dans le plus grand hôpital de Conakry, le CHU d'Onka. Donc, nous pratiquons la chirurgie gynécologique et oncologique.
Good evening. I'm Dr. Judith Nkwaira. I'm a consultant general and oncosurgeon from Malawi. I'm based up north of Malawi in a central hospital that takes care of 6 other secondary level care hospitals. I head the surgery department of the hospital, and also I head the clinical section of the hospital. I'm the current president for the Surgical Association of Malawi. Thank you.
Good evening. My name is Dr. Kisima Tuli. I'm a family medicine registrar, also a fellow in medical oncology at Edward Francis Moore Teaching Hospital, Banjul, the Gambia.
Thank you everyone. The first question goes to Dr. Siki. Dr. Siki. Yes, the first question. So can you please tell us the impact of the Merck Foundation training in your practice back home? And what are some of the major conditions that you have been managing since your graduation from the program?
Thank you very much for that question. First of all, I am not just a consultant surgeon and surgical oncologist. I am also heading a regional hospital in Zambia. I'm the director or senior medical superintendent at the hospital, while still being the president of Central Site of Zambia and country representative for the College of Surgeons of East Central and Southern Africa, hence the red side. I am also assistant dean for Lusaka Apex University and site training coordinator for Oncology University of Zambia. Now, we now have 4 oncologists, surgical oncologists in Zambia, 2 gynae oncologists and 2 surgical oncologists, thanks to support that we have received from Merck Foundation. Before this, we only had medical oncologists who were mainly trained in South Africa. So with the increased number of surgical oncologists coming on board, it's been noted that the cancer cases for the country, we are overwhelming one hospital because everyone is referred to one hospital for treatment. So now government has decided to open up 2 other hospitals to make 3. So the province where I am is called Copper Belt, and on the Copper Belt is one hospital which is under construction. It is currently at foundation level to be completed next year in June. So this is a long-term actualization of the plan arising from the Merck Foundation training in surgical oncology that I and my other colleagues received. But what am I doing locally? At my hospital, we've opened a cancer unit, the 8th department in the division of surgery. So now we have the Department of Surgical Oncology. Our hospital receives referrals from the northwestern provinces of Zambia. We have 10 provinces. So we receive referrals from 5 provinces located in the northwestern part of the country. So I get to see these patients and those that, many of them, when they come, they are locally advanced or they are metastatic. So those that are borderline resection, even those that are metastatic, the ones that tend to come back are the ones that are sent for neoadjuvant surgery because they are locally advanced or borderline resectable. And we do not have a lot of medical oncologists in the country, just like we have only 4 oncologists. So what we've done, we've set up an online meeting, which happens every Wednesday, a multidisciplinary team, where all the specialties will now meet and discuss each case. So while the patients may be treated in different places, such as surgery being done in the city of Kitwe, where I reside, which is 400 kilometers from the capital, where Cancer Disease Hospital is. But we discuss these cases in a multidisciplinary team, and the decisions are made. Those that require surgery are operated. So this is one way that Merck Foundation has actually contributed to the management of cancer in Zambia.
Very amazing. Thank you. Thank you, Doctor. Thank you. If my brother, indulge me, I would like to give the floor to the first lady among us. And if the audience also indulge me, I would like to ask the question in French because I could see that there was a little difficulty. Docteur Sadou, voilà. À ce que je peux voir ici, tu es une chirurgienne mammaire. Donc, en tant que chirurgienne mammaire, travaillant au Niger, quelles sont les difficultés que tu rencontres au quotidien?
Il y a 3 mois de cela que j'ai fini sa formation à Christina Institute. Donc, quand j'ai retourné dans mon pays, j'ai fait 2 mois avant d'être affecté. Donc, il n'y a pas, en plus, on a un programme au niveau de notre centre national de lutte contre le cancer parce qu'il n'y a pas un bloc opératoire. On ne dispose pas d'un bloc opératoire au niveau de notre centre de lutte contre les cancers, ni un laboratoire dans le pays. Donc, tous les cas de cancer, les cas chirurgicaux, c'est à l'hôpital national ou bien à la maternité de Saint-Patrick que les oncologues chirurgiens opèrent. Donc, le gros problème, c'est le manque d'un bloc opératoire au niveau de notre centre national de lutte contre le cancer. Il y a aussi le coût élevé de la prise en charge. Parce que les patients, bien que les cancers du sein, il y a un décret qui a été voté à l'Assemblée pour la gratuité des cancers du sein. Mais le consommable, c'est les patients qui achètent. C'est les patients qui achètent. Donc, il y a des patients qui n'ont même pas de moyens pour acheter les consommables. Il y a des examens qui ne se font pas au niveau du centre et qui ne se font pas même au niveau de l'hôpital national. Il faut les expliquer. C'est aux patients de payer les examens. Donc, il y a aussi un manque, une insuffisance du personnel qualifié à l'oncologie. Surtout pour une population estimée à 26 millions, il y a que 3 oncologues chirurgiens, nous 2 oncologues chirurgiens mammaires. Venons de finir la formation il y a 3 mois de cela. Il y a 4 médecins internistes option oncologie. Il y a un médecin pédiatre, oncologue, une radiothérapeute, et 4 techniciens de radiothérapie, un physicien. On a 11 anatomies pathologiques. Il y a 13 qui sont en formation qui n'ont pas fini. Donc, vous voyez, pour une population de 28 millions, dans les régions, tout à l'heure, il y a un seul oncologue chirurgien qui est à l'intérieur du pays. Tous les patients calculés sont obligés de, dès que tu diagnostiques à l'intérieur, il faut envoyer à la patiente, sur la patiente. Donc, les frais de déplacement, c'est la patiente qui fait. Les examens, même si la patiente a été opérée à l'intérieur du pays, dans les régions, pour envoyer les symptômes à la NAPAT, à la patiente de payer les frais d'envoi à la NAPAT. Il n'y a pas de laboratoire d'anatomie pathologique à l'intérieur du pays. Il n'y a que 2 laboratoires d'anatomie pathologique dans la capitale. Nous avons aussi le manque de la sensibilisation par manque de personnel qualifié. Le fait que la population n'est pas sensibilisée sur les signes du début du cancer, donc il n'y a pas de dépistage à faire. Donc, on voit les patients à un stade stable. Parfois, à un stade de métastase.
Merci. Merci beaucoup, doctor. Well, I'm sure there might be, I mean, she says so much. And if I miss anything, I would like anyone from the audience or even my brother here to help. So, grossly what she's saying is that she just completed her fellowship 3 months ago from Krishna University, 3 months ago, right? And just imagine since she got back home, I mean, it took her 2 months. It took her 2 months to be appointed, to be assigned, in the hospital where she's practicing now. And she has been facing a lot of challenges. The fact that in the locality where she lives, there is no pathologist. The cost of care for cancer patients is very expensive. So most often patients come at a very late stage where there's nothing much to be done. They always have to refer those patients to the capital city, Niamey, to undergo treatment. And in Niamey, there is only 2 surgical oncologists. Actually, they have 3 surgical oncologists in the entire country, a population of 26 million inhabitants. And one of those surgical oncologists works in the interior, in a remote area. And even for access to that surgical oncologist is a major problem. I mean, I'm not surprised because this is what most of us in our countries, go through. I just believe that whenever we have, because if I look at my personal situation in Liberia, we are not as blessed, as fortunate as they are in terms of manpower, because they have many more pathologists in the city, they have many more doctors. We are not as fortunate, but I believe that when there is this number of doctors available to be able to help the people, the government should be able to, put more effort in facilitating, that help. So, I don't know.
I think she just gave us a overview of what's happening. For a population of 6 million, we have 4 doctors who have located in oncology cases. That's it, the incidence rate is 10,000 a year. It's the same thing in almost every country, but at different level of difficulty and different level of administrative issues. Manpower is something that is very important, but I think I know about Mauritius, but I think for you individually from your country, there's a big MOU with countries like India, China, who are helping out to basically help to keep expertise and also sometimes keep buildings and machineries and everything to help. Oncology is fascinating. It's not like internal medicine or surgery, which have already settled the departments and it's running for the last 20 years. Oncology is coming up. It's now that we are building a hospital in Africa. So most of us are trying to get in accelerators, latest medications, and I guess it's the same for everyone. We're trying to get IHC, we're trying to do NGS, we're trying to get molecular markers, because we want, at the end of the day, these cancer patients to benefit from the treatment that you might know all the latest, the best treatment, but if you don't have them, you are unable to deliver the goods to the patients. So in a way, we should, a little bit of patience, most probably, and it will happen in the next few years. It's coming up, I think, as well in Mauritius. It's coming up very quickly, and I hope so in your country too. Soon you will be equipped with the latest technology in latest hospitals and facilities.
Yes. Well, so now that you have the floor, yes, right, yeah. So you could give us, because I could see, during the whole, or during all the sessions that Mauritius seems to be a little more advanced than some of our countries in terms of cancer management. So what is that plus that you got from here?
15 years of experience in oncology. I'm a doctor for the past 25 years. Basically, I was doing my MBBS from India. And when I came back in oncology, there was only 4 oncologists in Mauritius. But luckily, our population is a very small one, 1.2 million, 1.5 million, growing slowly. And we have an incidence of 3,000 cancer patients per year to this day. Previously, it was very less. So 4 oncologists is enough. And then slowly and suddenly they started multiplying. And after 10 years, we had 14 oncologists. And we don't know where to put them to work because there are too many doctors for too few patients. So that's helped out. Unfortunately, what is happening is we don't have surgical oncologists because we have general surgeons. These guys, the name say God people, they don't want to, hello? Yeah, they don't want to change their thinking process. They don't want to change their mindset because they need to diversify and they have been practicing for 25, 30 years. And at this age, you don't want to tell them, no, you can't do general surgery. You need to do only breasts. You need to do only abdomen. They say, no, I can do everything. Who are you to tell me that? So we are lacking in this aspect. Surgical point of view, gynecological point of view, pediatrics point of view, the surgical side. But oncology now, we just came up, also, let's face it, it's also political. Oncology is money. So they build up a new hospital, the government is getting cancer patients to get a dedicated hospital, to get specialized care. Medical facilities are pretty Mauritius. So maybe can you get it? So that's the advantage that you get. And they get votes and they're trying to get new machines, I think we are getting 2 at 1 PET scan and we're getting a bone marrow transplant unit with also dedicated lab with all the latest facilities with the next generation sequencing and everything is coming in a matter of 1 or 2 years. That was helped out. We have MOUs with the PMH, we have other hospitals like Apollo and other specialists who come and give us their expertise and help us to deal with the patient. But at the same time, I mean, let's say we are in Merck, so I'll just give a thanks to Merck because I had graduated 15 years back as an oncologist. There was no monoclonal antibody, there was no immunotherapy, and when this came in, we had to read again. But after the course that I had for 2 years in medical clinical oncology from Barts Cancer University, UK, it just updated everything, and now maybe it's going to help out to even I have 2 colleagues. I have a colleague here, Dr. Sohan and Dr. Naikan, who have studied that. So they, with this know-how, I think it will help us to improve the delivery of care. But we need to the care should be accessible, and that would hopefully happen if I'm very optimistic in the next few years. I don't want to take time, it's getting late, so thank you. I'll leave the floor to the guys. Thank you, brother.
Thank you,
Please,
Doctor.
Carry on.
Thank you, Dr. Kim Karan, for the thoughts and all your experience and all your knowledge on Bart's cancer, how Merck Foundation scholarship has impacted you and your colleagues. Thank you so much. Next, Dr. Syed, I would like to ask, being a Merck Foundation scholar, how according to you is the course content and the learning experience different from the regular learnings that you have seen, and how is it going to shape your clinical practice after completing your course, sir?
First of all, I want to thank Merck Foundation for giving me this opportunity to learn at one of the most prestigious universities in the world online. It was a big honor, and really it was an amazing experience. The whole content was very well prepared and well explained in simple to understand language. The tutors were very professional, and they had a very good person-to-person rapport, and which played a big part in ingesting everything which was being taught, because this way it's easier than the traditional way of one tutor teaching about 20, 30 students at once. But the way we did it, the online, it was really good. And another thing, it was tailor-made for today's clinicians, where they're busy all the time. Everybody's running up and down from morning to night. We just don't know when we are gonna get free time. So with this way of learning, we could log into our computers at any time and finish our tasks at any time of the day and any day of the week. It was really, it is tailor-made for today's clinicians. And also, the good thing, we learned very pertinent, relevant things which will help us when we go to the field and start to work. Because oncology, as we know, it's a big challenge in Africa, and also there are very few oncologists. So to get that state-of-the-art knowledge is very hard, but thanks to this program, I was able to get a lot of things, and I'm sure if I go back to Kenya, I'm gonna make some changes.
Thank you, Dr. Syed. Let's move on to Dr. Musana Otinel. How has the Merck Foundation fellowship programs helped you, and what is your approach to overcome all the challenges in your country, Doc? And also, please tell us what are the challenges you're facing treating the gynae cancer patients in your place, please.
The biggest center for oncology in the Cancer Institute in about 50 years. It offers good services in therapies. We have a training program now for gynecology, and about I think now so far 11 pillars of evaluated since then. The challenge for the gynecology is that most of the gynecologists are not employed, so the demand is big. It's like a cancer. So one of the challenges. Number two is that unlike what we train here, evolving the disease management networks, DMGs, have been a challenge because of other resources. Medical oncologists have been, psychic oncologists, they now feel but of course, oncology has been a challenge. We had the problem of radiation, but that was simple. Pathologists have considerably phase 2, come and upgrade their skills. They think they will do it. That's the biggest problem. So, for myself, in overcoming those challenges, one has been using my position. I don't work for them. I work in the private sector. One of them was advocate to sit on the committee that supervises the private cancer and put them on pressure to begin employing oncologists, as opposed to employing the oncologist who is senior, who is some interest in oncology. So, the report now is about 2 oncologists employed, oncologists. The other one was to also expression because we speak a lot. So speak a lot. And eventually now there is a National Cancer Program, including the HPV vaccination program. It's now being rolled out in schools. And of course, I believe that in the future, well, I think if you stick to clinical work, I think we'll die. But I think if we work with it and focus and make a lot of noise, I think things will change. So my typical work is that I do 2 days of clinical work and 4 days of making noise, attending meetings, and reading policy. So that is the way I look at it. Because when the one that come from one press, one mountain. But as for now, one of the things that we also is the family, we talk about organic beverage. One of the things that we now, the clinical health, of course, also points, is to define the scope of practice for the gynecologists because of their president. So now gynecology is now a standalone, and all the gynecologists know the gynecologists and if we don't really certain things, we make sure we make some analysis. That's it.
Thank you for sharing all the things that is happening in Uganda and the struggle and everything you're facing. Thank you. Let's move on to Dr. Magasoba. Sorry, I was looking for the translator. He's at the other blog. That is why I was running around. And yeah, please, if anybody can help us translate, it would be easier for the audience. And the audience in the online, they have the Zoom where they have the French interpretation. Sure. All right.
Questions?
All right, Doc, I would like to ask you that being the member of Guinean Society of Gynae Onco, how do you intend to find solution for cancer care demands in your country?
En tant que membre de la Société guinéenne des gynécologues, qu'est-ce que tu comptes entreprendre comme mécanisme pour améliorer la prise en charge?
Je vous remercie. D'abord, j'ai été choisi parmi les trois premiers. Ils ont venu en Inde en 2019. Il y a un pédiatre de minutes, plus un activiste. Et moi, j'étais le seul gynécologue qui est venu pour la formation.
Okay, so there were teams of women that was sent for the program. One pediatrician, one pathologist, and myself.
Et du coup, au départ, c'était pas facile.
What is that first?
Parce que je ne comprenais pas la langue.
Language barrier.
La fondation Merck m'avait rassuré qu'ils vont mettre une traductrice à ma disposition.
So Merck Foundation gave him a translator.
Le premier moment était très difficile. Le
first one was very challenging.
Mais on s'est donné corps et âme. Et bien avant cela, j'ai eu la chance de travailler dans le plus grand hôpital de Conakry. Parce que Conakry, la Guinée, c'est à peu près une population de 13 millions d'habitants. Et ok, d'accord. Donc, bien avant cela, j'ai eu la chance de travailler à côté de mon patron, qui était non seulement d'abord gynécologue, mais en même temps oncologue.
So, prior to his coming to India, he has been working with his mentor and also his himself oncologist.
Donc, j'ai pratiqué beaucoup avec lui et on a essayé de se battre pour mettre un programme harmonieux sur toute l'étendue du territoire en construisant un centre de recherche francophone à la prévention des cancers de l'utérus. Le centre là existe depuis 2005.
So since 2005, we built a research center in cancer in Conakry.
Donc, au départ, on était associé avec mon patron, il était ami avec un Indien qui ont travaillé ensemble à Lyon. Donc, ils ont mis ce programme et nous, on a été les premiers à être formés sur les îles de la Fondation Bill Gates. Il a pris en charge pour faire les premières barres de formation pour qu'on puisse continuer à faire le digital en range campagne. Et ce dépistage-là nous a permis de faire asseoir vraiment les fondamentaux de la prise en charge des femmes à un stade précoce, pour ne pas que les gens viennent tout envoyer avec des stades très élevés.
So his boss had an Indian friend that he met in France, and along with that friend, they built a system where young doctors like him would go in the remote areas and screen women in order to reduce, those 8 stages coming in the capital system.
Okay. Évidemment, bon, et quand on a mis ce programme, et malgré que je travaille, je suis parti 2 fois au Caire pour assister aussi au premier effort de dépistage.
par le plaisir de mon patron, j'étais à Alexandrie. J'ai fait 2 fois là-bas et j'ai retourné encore à Paris. Après, à mon arrivée, mon patron m'a dit, ah, attention, il y a la fondation Merck qui a demandé à ce qu'on fournisse les gens qui veulent aller faire une formation en ligne. Et du coup, j'ai hésité parce que je ne comprenais pas l'anglais. Non, il faut y aller. Donc, je suis arrivé en Inde et j'ai commencé à travailler. Et d'abord, je remercie les autorités du Tata le patron qui a arrêté, le Dr. Banagani. Et Maman Mita, qui était le patron en Gagné en Tunisie, Maman Mita du Prince département et Maman Zayagos. Donc, ils nous ont vraiment encadrés et nous donné vraiment l'outil nécessaire, comment il faut prendre les malades en charge. Donc, du coup, à mon retour de l'Inde, nous avons renforcé notre capacité en formant les sages-femmes qui sont sur toute l'état du territoire. Donc, on amène les gens ensemble, on les prend en charge, on les forme, on les envoie. Après, on a fait un travail aussi remarquable, on a créé un groupe sur WhatsApp. Et donc, ils vont faire le dépistage dans la campagne avec, comment on appelle ça, l'inspection visuelle à la CILACITI. D'accord? Et l'autre palpation, apprendre les femmes dans les radios publicaires, c'est ça qui peut vraiment nous donner, c'est-à-dire la possibilité de voir les malades à un stade très précoce. Parce que une fois que la maladie est arrivée à un stade, et très comme nos collègues déjà l'ont dit, la prise en charge, ce n'est pas l'État. L'État n'est pas du tout impliqué chez nous. Donc, c'est les patients qui donnent l'argent pour se prendre en charge, y compris la chimiothérapie, la chirurgie et la radiothérapie. Et malheureusement, on n'a pas de radiothérapie chez nous. La plupart de mes malades, on les envoie à Dakar.
So prior to his trip to India, he had been in Alexandria, Egypt twice to undergo short trainings in screening of the cervical cancer. And I don't know, maybe we'll connect it because I was myself in Alexandria once, for the same program. I don't know, maybe. So, but when he returned after his second trip to Alexandria, he had that opportunity that was given to him by his senior to come to India. And initially he wasn't convinced that that was the best way out because he felt that English was a major issue for him. But he embraced himself and decided to come. And he is very grateful. I think he named most of the head of departments that contributed to who he is today, what he can do today. And one of the things that he did back home, which I'm very impressed with, is that they train many midwives working in remote institutions in India to screen for cervical cancer using VIA, which is something that's at least in India, is also in Tanzania. I saw that a lot in Tanzania. So this is something that he did, and he has been given a lot of good results. They also introduced women into self-breast exam because he was buttressing the point of our colleague from Nigeria, who said that most of the time when these women come at the late stage, they have to pay for themselves. They're always not involved, to sponsor chemotherapy, they're not involved to sponsor surgery, they're not involved to sponsor radiation therapy, and in Guinea, there is no radiation therapy.
Du coup, on a créé aussi des ONG pour donner en aide aux patients souffrant du cancer du sein, cancer du col, du cancer de l'ovaire. J'aime participer activement chez nous parce que j'ai fait beaucoup de campagnes dans les radios publiques, sensibilisation, surtout le mois d'octobre, les gens sont en train de travailler activement dans mon centre. Et il y a un engouement qui est là pour faire le dépistage. Parce que les pays à ressources limitées, on doit se focaliser sur la sensibilisation, la prévention primaire. Parce qu'à partir du moment que la maladie est déclarée, le cancer du sein, est-ce que vraiment c'est un sein inflammatoire? Si c'est un sein inflammatoire, il te faut au minimum 6 kg de chimiothérapie. Et nous, le coût de chimiothérapie, ça varie de 5 millions à 7 millions de francs guinéens. À peu près 700 $. Donc, imaginez-vous, une patiente qui vient, qui n'a pas de moyens. Moi, je suis le point de cas, je suis obligé d'appeler les ONG. Ils se donnent la main, il faut les aider. Mais la radiothérapie n'est pas sur place. La radiothérapie, si tu l'as envoyé malade à Dakar,
il faut minimum 2,5 millions à 3 millions de francs CFA. Ça, c'est comme ça. Donc, maintenant, actuellement, nous devons changer la donne pour que l'État s'investisse pour nous aider à avoir un centre de radiothérapie en partenariat peut-être avec Tata Hospital. Peut-être c'est possible. On nous aide à avoir un centre de radiothérapie parce que nous avons suffisamment sur le sol indien. Mais tous les pays à ressources limitées, si on veut vraiment lutter contre le cancer, on ne peut pas faire la lutte sans qu'il y ait un centre de radiothérapie. Ce n'est pas possible.
So, you mentioned the fact that they have been receiving support from some NGOs, which is very impressive. That's some money together, up to $700 for chemotherapy. Oh, for each cycle of chemotherapy, $700. That's very expensive. So, most often for women who come at an advanced stage of breast cancer, these women have to be referred to Dakar, Senegal, where the cost of radiation therapy is around $5,000. So he is working, he is lobbying a lot for the government to come in to put in place to create a radiation oncology unit, hopefully with the help of TMC. And he feels that if something like that happens, there will be a major change in the care of cancer women or insult cancer.
Et nous cessons de remercier la Fondation Merck et tous ceux qui font comme des efforts pour les pays en voie de développement. Bon, mon pays, c'est malheureusement qu'on est un peu lésé parce qu'on n'a pas encore beaucoup plus de spécialistes dans le domaine tel que par exemple DIC, peut-être l'oncologie, pas encore augmenter, le sorcier qui font l'oncologie médicale. Parce que nous, on fait la pratique chirurgicale, mais la chimiothérapie, ce n'est pas le protocole de la chimiothérapie. Actuellement, je suis obligé de faire le protocole de chimiothérapie parce qu'il n'y a pas de médecin formé. Donc, maintenant, quand on a des spécialistes qui sont nombreux un peu partout, donc ça va un peu soulager les malades. Donc, une fois, c'est une doléance qu'on pose dans la Fondation Merck, de aider toujours les pays pour qu'on puisse envoyer des gens pour les former.
Merci. So he's coming to his clinic is hoping that Merck Foundation will continue to help to increase, the manpower, train medical oncologists, because he prescribed chemotherapy, he gives chemotherapy. So he's hoping to have more medical oncologists, less oncologists who will do that and alleviates the burden of this work.
Right. Definitely, Dr. Magasoba, your proposals will be sent to the scientific committee of Merck Foundation and to the TMC doctors. We'll see what we can do and discuss this with you, sir. Thank you. Thank you for your experience. Let's move on to Dr. Sadao Aichato. Doc, as being a breast surgeon, what are the different types of cancer you find in Niger? Please share your work experience as a chief specialist surgeon in public sector and how, according to you, is the cancer services made you more accessible and more cost effective in your place?
Okay, thank you very much. As previously said, I'm a general and onco surgeon. I just finished my surgical oncology fellowship under KVV in the past 6 months. During this time, my thinking is as a general surgeon, I trained as a general surgeon and graduated in 2015. And I'd been serving for 6 years prior to joining the surgical oncology fellowship. And training as a general surgeon, you concentrate your practice into surgical diseases that are from congenital abnormalities, infection, trauma, and cancer. But there is need to have special training for surgical oncology, as that is another different scope of surgery, and the details, the surgery for trauma and cancer, I realized that they're different. And you need to have a special skill for that. Otherwise, you have to leave residual disease. So Merck Foundation provided me a forum, a platform that I could learn that for 1 year and taking it back, not just learning the technical aspect of surgery. Surgery is beyond cutting, but also the decision-making for the patients. That's what I learned. And also how to work in a multidisciplinary team of care, knowing that cancer is not a one team type of disease. So how to relate with other specialties like radiation oncology, medical oncology, palliative care, and even physiotherapy. It was just amazing to realize that physiotherapists have a role in cancer care. So that's what Merck Foundation taught me when I went to KVV. Now going back home, the past 6 months has been now to see beyond the technical expertise. I believe administrative work is very important because your patients, for the patients to access care, I do a lot of work in global surgery. So global surgery is about access of care for our patients, access to safe and timely surgical care. And that calls for pathways and proper guidelines. Your patients are beyond the operating room. Your patients are beyond the hospital. So what is the life of your patient outside the hospital? How do you relate with your patients? So early diagnosis and treatment is beyond the hospital. So that's what we are currently working for at the moment, working to create pathways, having data. So currently I have a data registry for my clinic. I need to know the burden of the disease, how much. As I said, I work in a central hospital that is a referral for 6 other district hospitals. So within the northern region where I work in, I've created this database so that I now have to log in all the new cases and possibly the ones we saw before I went, so that I understand the disease and what type of cancers are we seeing, how are we treating them, how much are we referring. I forgot to say that where I am, there's no medical oncologist, there's no radiation in my country. So the only way they can access, there's one national cancer center which is in the capital, but not everybody will have to go there. That's our hub. We are the spoke where I am. So working to liaise with my colleagues, I have my colleague here at the back, Dr. Jifundo Kajombo, who also trained here in Tata as a surgical oncologist, how we relate and work with the medical and clinical oncologists at his center to take care of my patients. So basically, in a nutshell, that's what I'm working on beyond the technical expertise, is to create pathways and systems that will increase access for surgical cancer care in Malawi. Thank you.
Doc, we have another question for you, if you don't mind, yeah? Yeah. Please tell us what new or pioneering steps are you taking in the Department of Surgical Oncology?
All right. So as I said, I work in the general surgery department. As for any African general surgeon, even if you get a subspecialty training, you don't stop being a general surgeon, because you realize that at the end of the day, if you do that, you will leave a subset of patients who do not have care. So I continue to work as a general surgeon, but I also, so it means doing surgical oncology is an added work for me. So currently, I'm working with the cancer unit in our hospital, which delivers chemotherapy currently. So we were working on the database that I just mentioned to log in patients so that we understand our burden of disease. We currently also sent into training one senior medical officer for clinical oncology and nurses for onco nursing, so that when they come back, we can now transform this unit to a full department that will be able at least to offer surgery and chemotherapy and other systemic therapies on site.
Thank you. Best wishes for the achievements, Doc. Next, let's move on to Dr. Kisima Tore. Doc, how has the Merck Foundation Fellowship programs has helped you, and what is your approach to overcome the challenges you face in the Gambia?
Yes, the fact that I'm fortunate to as a medical oncologist, but I still face a lot of challenges, back home. In fact, back from the field of oncology is at its infancy stage. We have limited number of oncologists, including myself, and Dr. Jete, this is opportunity to fellowship program in Solitary Oncology. Very limited number of oncologists. So that's the big challenge we are going to face. But we're reaching out to different stakeholders trying to see what can be done to his dream of having an oncology center in my country. Just of recent, with the help of my colleague, Dr. So what we call the Gambian oncology team. It's a platform consist of medical oncologists, surgical oncologists, traditional oncologists. As you know, cancer is a multidisciplinary approach. Have a lot more for the specialty, but we need to committee and is upgrade and then standardize the service of.
Thank you, Doctor. Okay, I would like to thank Dr. Saposi King for moderating with me from morning and bear with all our troubles. Thank you, Doc. I have a few questions for you. I just pick one because we are running out of time. Please tell us about the new initiatives, facilities, services added to your practice as a consultant after training with Merck Foundation, and how have your patients benefited from this?
Thank you. So I'm very grateful for this opportunity to be trained at the People Agency Institute. I was really lucky to have my mentor here today. So since I got back home, we have opened an outpatient for gynae oncology. We have instituted chemotherapy protocols based on international standards, the palliative OPD, palliative care OPD for our late stages. We have revamped our very dormant cancer registry because we understand that if we don't have numbers, we don't know, who our enemy is. I think somehow I have also stimulated my young colleague who is out there, who has started his fellowship in pediatric oncology. So we are building a team. Currently, we have a team of 2 gynae oncologists, one trained by IGCS in Uganda. Thank you. We have 1 medical oncologist trained by Merck in Egypt. We have 3 pathologists, Liberians, with our deeper in the audience. So we have many challenges, but we are, with baby steps, we are trying to build something that in the future we hope will get big. So prior to my return to Liberia, there was nothing. We were dabbling with whatever we're doing there, but now we are trying to put in place something that is based on international standards. And since the month of January, because when I came back home, my first week, I was summoned by the ministry to come and take office. So since now we have managed over 75 cases of oncology cancers, most were free medically. So I cannot say how much this training has done for my country, and I hope that more Liberians will benefit this opportunity in order for us to grow.
Thank you. Thank you, Doctor. Would you like to ask something, Dr. Kimkar?
I wanted to say something. Maybe you could promote exchange programs, because after listening to everybody, everyone has their own issues, but somebody else has another issue, maybe help in something that is lacking in your place. So she doesn't have a medical oncologist, you don't have a radiation oncologist, we don't have surgical oncologists. I'm not speaking government-wise, but that could be in the private with the help of Merck that can actually have exchange programs. Like you want to set up a chemotherapy unit. For me, it's easy. For her, maybe I want to do some breast thing. For her, it's easy. I wouldn't know what to do. I think you should look in, it's just a proposal. where you should look into the matter, and he doesn't have oncologists or radiation oncologists. We can send a few, just set up the whole thing, and this people start training and they work. At least they have they start something. Otherwise, it will always be just there wouldn't be anything.
Right. I will put this up in the scientific committee, as this proposal is very actually informative, and we'll think about it. I'll speak to all the scientific committee members of Merck Foundation. With this, on behalf of Merck Foundation, I would like to conclude this wonderful session. I thank you very much for all your patience and difficulties you face with us. Please bear with us. Sorry, I couldn't get a translator. I was running down, else it would have been much easier for everyone to understand. I thank you so much. Thank you. We look forward to meeting all of you for this wonderful knowledge sharing and great learning opportunities in future. Please be reminded to visit merckfoundation.com and download the Merck Foundation app in the Google Play Store and the App Store. Thank you. Thank you all so much.